Camera off.
Camera in the good. Image on image. Banner.
I can in the program. I'm waiting to receive you. But you are nowhere. Abute, yeah. Then 845. 845. You have half an hour. 845. Isn't it? 845 inauguration. No, not actually inauguration.
ഇതിലേക്ക് കൊടുക്കുക ഇതിന്റെ ഔട്ട് എടുത്തിട്ട് ഇതിലേക്ക് കൊടുക്കുക ഇല്ല ഒരെണ്ണം ഈ കമ്പ്യൂട്ടറിൽ
ഞാൻ നമ്പർ എടുത്ത് യൂട്യൂബിന് ശരിയായോ? യൂട്യൂബിന് ശരിയായോ?
ആ സാർ ശരിയായി.
കുഴപ്പമില്ല?
ഇല്ല സാർ കുഴപ്പമില്ല. പക്ഷെ ഇപ്പൊ ഇതൊന്നും പോകുന്നില്ല. നമ്മൾ
അത് കുഴപ്പമില്ല. ടെസ്റ്റ് കൊടുക്കണോ?
ഈ മെയിലേക്ക് അയച്ചായിരുന്നു വെച്ചേ.
ഇത് കിട്ടിയില്ലേ? അത് ഉപയോഗിച്ചോ. കട്ട് പേസ്റ്റ് ചെയ്തിട്ടേ കട്ട് പേസ്റ്റ് ചെയ്തിട്ട് ആ പ്രോഗ്രാം ഓർത്ത് ഇടല്ലോ. ടുമോറോ പ്രോഗ്രാം അതൊക്കെ ലാസ്റ്റിലെ
പോർട്രേറ്റ് ആണ് സാർ. ഇങ്ങനത്തെ ഇങ്ങനെ ഈ പകുതി മാത്രമേ സ്ക്രീനിൽ കാണുള്ളൂ.
അത് കുഴപ്പമില്ല. വിഷയമല്ലോ. അതൊന്ന് എല്ലാ ഇത് ചെയ്താ പോരെ, വലിച്ചാ പോരെ.
അടുത്ത കമ്പ്യൂട്ടർ അല്ല, രണ്ടാമത്തെ കമ്പ്യൂട്ടർ വരേണ്ട കാര്യമില്ലല്ലേ? ഈ ഒരു
ഈ സിസ്റ്റം കയറി പോകണം എങ്കിലും പ്രസന്റേഷൻ കയറി പോകുള്ളൂ. അല്ലാണ്ട് കയറി പോകില്ല പ്രസന്റേഷൻ. ഞാൻ അതാ പറഞ്ഞ അന്ന് സെറ്റ് ചെയ്യാം. അപ്പം അന്ന് സെറ്റ് ചെയ്ത് ഇപ്പോഴത്തെ കൺഫ്യൂഷൻ ഇല്ല. അവര് കയറുന്ന പരിപാടിയാണ് അവർ നേരത്തെ ഉണ്ടാക്കിയത്. ശ്രീകരനും പറഞ്ഞ എന്ത് സെറ്റ് ചെയ്യാന്ന്. ടിവിന്റെ കാര്യമൊന്നും പറഞ്ഞിട്ടൊന്നുമില്ല. നമ്മളോട് പറഞ്ഞിട്ടില്ല, സാറ് പറഞ്ഞിട്ടില്ല. ഓഡിയോ കയറി പോകും. ഓഡിയോ ഇത് ഈ സാധനം അല്ല ശരി, ഇങ്ങനെ ഉപയോഗിക്കാനല്ല പറഞ്ഞത്. എന്റെ ഒരു ഐഡിയ വെച്ച് ഉപയോഗിക്കുകയാണെങ്കിൽ ഇങ്ങനെ ഉപയോഗിച്ച് കഴിഞ്ഞാൽ നമുക്ക് കയറിപ്പോലെ. ഈ സാധനം ഇവിടെ സ്വിച്ച് ചെയ്യാൻ മാത്രമേ ഉപയോഗിക്കാൻ പറ്റുള്ളൂ. ഈ ഈ സ്വിച്ചറില്ലേ, സ്വിച്ചർ ഇവിടെ ഉപയോഗിക്കാം. ഈ പെട്രില്ലേ, പെട്രോൾ വെച്ച് സൂമി കയറ്റി വിടുക. അതായിരിക്കും ഇപ്പൊ നടക്കാൻ പോകുന്നത്. അങ്ങനെ ഇപ്പൊ നടക്കുള്ളൂ. അല്ലാണ്ട് വേറെ ഒരു മഞ്ഞ
ഈ കമ്പ്യൂട്ടറും ഇവിടെ തന്നെ കൊടുക്കാം അല്ലേ? ഈ കമ്പ്യൂട്ടറും ഇതിന്റെ ഇനി തന്നെ കൊടുക്കാം അല്ലേ?
ആ കമ്പ്യൂട്ടറും സൂം ലിങ്ക് സാറിന് തന്നിട്ടുള്ള അതാ പിന്നെ നമുക്ക്
അതന്നെ ലിങ്ക് ഉണ്ടല്ലോ എല്ലാവർക്കും അയച്ചു കൊടുത്തിട്ടുണ്ട്.
അറിഞ്ഞിട്ടിരുന്നു
ഇങ്ങേ അറ്റത്തല്ലേ
ക്യാമറ?
ഇങ്ങേ അറ്റത്തെ ക്യാമറ.
അതല്ല, അത് മെയിനാ. പ്രൊജക്റ്റിലേക്ക് പോണ കണക്ഷൻ.
ഇതിന് ഇവിടെ മാത്രം സ്വിച്ച് ചെയ്യണമെന്നുണ്ടെങ്കിൽ ഇത് ഊരിയിട്ട് കൊടുത്തത്.
മൈക്ക് ഒന്ന് മ്യൂട്ട് ചെയ്ത് ചേട്ടാ.
ഇവിടെ എന്താ പവർ പവർ ഓഫ് ആയി.
ഇൻപുട്ട് കൊടുക്കണ്ടോ?
കൊടുത്തിട്ടുണ്ട്, വന്നിട്ടുണ്ട്. 2 കമ്പ്യൂട്ടർ ഇൻ കൊടുത്തിട്ടുണ്ട്. ഇവിടുത്തെ 2 ഓക്കെ. അപ്പൊ ഈ കമ്പ്യൂട്ടറിന്റെ ഇൻപുട്ട് ഇതിലേക്ക് കണക്ട് ചെയ്യണ്ടേ? അത് ഇതിന്റെ ഔട്ട്പുട്ട് എടുത്തിട്ട് കണക്ട് ചെയ്യാം അല്ലേ? അപ്പൊ നമ്മള് സ്വിച്ച് ചെയ്യുമ്പോ അത് മാറില്ലേ?
ഞാൻ പറഞ്ഞാലെ കൊടുത്തതിന്റെ ഞാനേ വേറെ കൊടുക്കാൻ പറഞ്ഞു. എനിക്കറിയില്ല കേട്ടോ അതിനെപ്പറ്റി. ഞാൻ പറഞ്ഞ പോലെ കൊടുത്തതിന്റെ ആണോ?
ഇതിന് പക്ഷെ ഒരു ഔട്ട്പുട്ട്, 2 ഔട്ട്പുട്ടല്ലേ ടോട്ടൽ ഉള്ളൂ.
2 മതിയല്ലോ.
സ്വിച്ച് ചെയ്തിട്ടുള്ളത് വരും.
ഞങ്ങൾക്കറിയില്ലല്ലേ, കഴിഞ്ഞ ദിവസം ഒന്ന് കെട്ടി വെച്ചാൽ
അതൊന്നായി.
ആരാ പോയിക്കാറ്? കല്ലാജാണെങ്കിൽ കിണ്ടി മണിയില് സീനാണോ? ഔട്ട്പുട്ട് കൊടുത്തേക്കുന്നത് ഔട്ട്പുട്ട് ആയതല്ലേ?
അത് ടിവിക്കുള്ളത്. ഇതിന്റെ ഒരു ഔട്ട് എടുത്തിട്ട് കമ്പ്യൂട്ടറിൽ കൊടുത്താൽ പോരെ ഇനി?
കമ്പ്യൂട്ടറിൽ ഔട്ട്പുട്ട് കൊടുക്കാൻ പറ്റില്ല അതിന് ഇച്ചിരി ഇൻപുട്ട് മാത്രമേ കമ്പ്യൂട്ടറിലുള്ളൂ. ഞാനതൊക്കെ അന്ന് ആലോചിച്ചത് എങ്ങനെ കൊടുക്കുന്നതിന് എനിക്കറിയത്തില്ല. അത് ഞാൻ അവിടെ മിണ്ടാണ്ട മൂലയായിരുന്നു. മനസ്സിലായോ? മറ്റേ സാധനം വെച്ചെടുത്ത് പെട്ടെന്ന് കൊടുക്കും, അല്ലാണ്ട് വേറെ ഒരു വഴിയില്ല. ആ സ്പീഡിൽ നമ്മൾ ഇൻപുട്ട് വെച്ച് സിസ്റ്റത്തിന് ഔട്ട്പുട്ട് വരില്ല, ഇൻപുട്ട് ഇല്ല, ഒരു സിസ്റ്റത്തിനും ഇല്ല. ഞാനതല്ല ഇവിടെ ഒന്നും മിണ്ടാണ്ടിരുന്നത്, എനിക്കൊന്നും മനസ്സിലായില്ല. വേറെ ഇത് വെച്ച് കൊടുത്തു നോക്ക്, ചിലപ്പോ കയറി വന്നു കഴിഞ്ഞാൽ വന്നു. അല്ലാണ്ട് വേറെ ഓപ്ഷൻ ഇല്ല. ഈ സി വെച്ചിട്ട് സിസ്റ്റത്തിൽ വരുന്നുണ്ടോ നോക്കി. രാവിലെ വന്നു ഞാൻ കൊടുത്ത
Moving out of it once we know that we have at least a sizable number. But if we are just some 20, 30. Yeah. Because right now again the scale.
No, I just spoke him for the questions.
വിളിച്ചിട്ട് എടുക്കണ്ട.
Same thing. Yeah, you are the both you operated. I have a product of humans and so actually humans that I went to visit the research and I went to
അങ്ങോട്ട് പോകാതെ
you operated the operated.
കേരളം കംപ്ലൈന്റ്
സോഴ്സ് ഒന്നും HDMI
WhatsApp number, contact number if you want.
So they can put it in that chat itself. No?
ആൾക്കാരെ വെയിറ്റിംഗ് ആണ്.
വെയിറ്റിംഗ് ആണെങ്കിൽ ആ വെയിറ്റിംഗ് റൂമിൽ മെസ്സേജ് ഇടാൻ പറ്റും നമുക്ക്.
വെയിറ്റിംഗ് റൂമിൽ മെസ്സേജ്
The full group has
ടൈപ്പ് ചെയ്താൽ
പറഞ്ഞത് വെച്ച് നോക്കുമ്പോൾ അങ്ങനെ കൊടുക്കാനാണ് പറഞ്ഞത്. ഇതിൽ 3 ഇതിൽ കൊടുത്തിട്ട് ഇതിൻ്റെ അടുത്ത് ഇതിലേക്ക് കൊടുക്കാനാണ് ക്യാമറ അതിലും കൊടുക്കുക. ഔട്ട്പുട്ടാണ് ചോദിച്ചേട്ടാ അത്. ഈ സാധനം ഈ കുത്തി കഴിഞ്ഞാൽ വരേണ്ടതാണ് ഔട്ട്പുട്ടിൽ കൊടുത്തു കഴിഞ്ഞാൽ. സോഴ്സ് ഡിറ്റക്ട് പോലും ചെയ്യും.
The options are there. You have to search for the option. All options are there. We are operating.
യൂട്യൂബും സൂമും ഉണ്ട്. അങ്ങനെ ഒരിക്കലും വരില്ല. അത് ഇൻപുട്ടാണ്. ഒറ്റ ഔട്ട്പുട്ടുള്ളൂ. ക്യാമറയാണ്. അവിടെ ഒന്നും വിട്ടിട്ടേന്നില്ല.
കേബിൾ കംപ്ലൈന്റ് ആയിക്കാണ്. ഇതെടുത്തിട്ട് ഡയറക്റ്റ് കുത്തി വെക്കണോ ഒന്ന്? അല്ല, കമ്പ്യൂട്ടറിലൊന്ന് കൊടുത്തിട്ട്.
ഇവിടെ
ഇതിലെ എത്തില്ലാന്ന് തോന്നുന്നു. എത്തോ ഏതെങ്കിലും കമ്പനി കൊടുക്കാൻ? അല്ലെങ്കിൽ ക്യാമറ എടുത്തിട്ട് അതിന്റെ HDMI കൊടുത്തേക്കാണോ? പറയാലോ, അതിന്റെ HDMI ഔട്ട്പുട്ടില്ലേ കൊടുത്തു നോക്കി കഴിഞ്ഞാൽ വരണ്ടോ? പക്ഷെ ഔട്ട്പുട്ട്
വന്നല്ലേ നേരത്തെ ഇവിടെ. ഇതൊന്നും ഒന്ന് വിളിച്ചു നോക്കില്ല. അത് വേറെ ഓപ്ഷനില്ല. എനിക്ക് വേറെ വീഡിയോകളൊന്നുമില്ല.
എടാ, അതിന്റെ പ്രൊജക്ടറിലേക്ക് ഔട്ട് വരുന്നില്ലടാ. ആ കേബിൾ കംപ്ലൈന്റ് ആണോന്ന് അറിയില്ല. ഇന്ന് രാവിലെ വന്നതാണ്. ഇപ്പൊ കിട്ടുന്നില്ല. ആ, ഇപ്പൊ വരാന്ന്. പ്രസന്റേഷൻ സർ എന്താണെങ്കിലും ഇതാണെങ്കിൽ നമുക്ക് ഇതിന്റെ ഇൻപുട്ട് കിട്ടണ്ടേ? ഈ ലാപ്ടോപ്പിലേക്ക് ഒന്ന് കണക്ട് ചെയ്ത്
ചെറിയ ക്രൗഡ്
check, check, hello, check, 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 hello, check, 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 check.
ഇതെത്തിയോ? ഒന്നിങ്ങോട്ട് വരുമോ 2.5ലേക്ക്?
your thing is loading.
I'm going to presentation first session. We will
കോപ്പി
have a small prayer.
ഇൻവൈറ്റ് ചെയ്യാതെ ഞങ്ങൾ കൊടുക്കാൻ പോകാം. കാരണം എനിക്ക് 9 മണിക്കൊരു ഡെത്തുണ്ട്. അവിടെ ആ രേഷ്മയുടെ അമ്മയുടെ ആര് സ്റ്റാഫ് സെൻറ്റേഴ്സിൽ കൊണ്ടുപോയി.
We will have a small prayer and then
സൗകര്യം കുറവുള്ള പോലെ ബന്ധപ്പെട്ട് അതിൽ ഒരു ഇച്ചിരി സ്ത്രീതി ഉണ്ടാവാൻ ഇത് അമ്മയുടെ ഫോട്ടോ താന്നിരിക്കണം ഇപ്പോൾ വിളക്ക് താഴെ വെച്ചാൽ മതി. ഈ സ്റ്റൂള് വേണ്ട, മാറ്റാൻ പറ്റില്ല. എന്നാ താഴെ വെച്ചോ, എന്നാ താഴെ വയ്ക്കും. അമ്മയുടെ മുഖത്ത് നേരെ ഉണ്ടോ? അമ്മയുടെ മുഖം മറിഞ്ഞിരിക്കും ആൾക്കാർ. താഴെ വെച്ചോ. അല്ലെങ്കിൽ ഫോട്ടോ വലുതായി ഉയർന്നിരിക്കണമായിരുന്നു. ഇതൊക്കെ എനിക്കൂടെ ശരിയാണ്. ഇതല്ലേ നല്ലതാണ്. എന്നിട്ട് നമ്മുടെ മുഖം മറിഞ്ഞിരിക്കുകയായിരുന്നു.
Please wait for the next session change over. അല്ലെങ്കിൽ വെറുതെ ഇത് നടക്കുന്നതെന്ന് കണ്ടോണ്ടിരിക്കണ്ട.
അച്ഛനാണോ ബാക്കിയുള്ള ലിങ്കല്ല ഇതിന്റെ പവർ ബോക്സ് വരില്ല അവിടുത്തെ സ്വിച്ചൊക്കെ ഓൺ ആക്കി അതിന് തൊട്ട് അവിടെ കൊടുക്കണ്ട അവിടെ കൊടുക്കണ്ട ഇല്ല അതുകൂടെ അപ്പുറത്തോടെ ഇടാം അടിക്കൂടെ തരാൻ വന്നോ ഞാനേ അതിൻ്റെ അകത്ത് മറ്റേ വേറെ ഇച്ചിരി വേണ്ട അതെടുത്ത് നോക്കുന്നു വേറെ സെയിം ഉള്ള എനിക്ക് സെയിം ഓർമ്മ കൊടുത്തോ ദൈവതൊക്കെ വർക്ക് ചെയ്യുന്നു താഴത്തെ ആ നോ സിഗ്നൽ കാണിക്കുന്നവരില്ല ആ നോ സിഗ്നലിന് കാണിക്കുന്നത് ഷുഗർ സെൻസ് വീട്ടിലില്ല. മാറ്റി
അന്ന് കൊടുത്തു ഇതല്ലേ
ഇതിലേക്ക് കൊടുത്തിരിക്കുകയാണ് അങ്ങോട്ട് കൊടുത്തിട്ടില്ല. ഇല്ലല്ലോ.
ഇല്ല കൊടുത്തിട്ടില്ല
എന്താ ചെയ്യുക? അതെ. ഇത് റിന്നല്ലേ? റിന്നല്ലേ? ഞാൻ തന്നെ ഗ്രൂപ്പ് വന്നില്ലേ എസ് ഡി വന്നില്ലേ
റെഡിയല്ലേ സെറ്റ് ഗോ
Check, check, check. You can talk to them also. Yes, you can invite them also, right? Admit. Speak. So, good morning, everyone. It's a very core group, and we are all participants, and we are all going to contribute this to this event as well. It should be 2 intense days, I hope, tomorrow. Usually we conduct the Amrita craniofacial at a more basic level, only craniosynostosis, but this time to include all concerned specialities, we have kept it at a, of course, it then comes to a higher level because then we are looking at the function and the aesthetics. So I'm very glad to see so many neurosurgeons here. Of course, it's all Suhas's effort. So very warm welcome to all of you. I think there are a few more people who are supposed to come and join us. And we are also streaming this live to members of International Craniofacial Society. So there are few people who must have joined us on Zoom and we invite you. And if you have any comments or questions during the course of the session, you're most welcome to put that up in the chat box on the Zoom. And this will also go live on the YouTube channel of Indian Pediatric Neurosurgery Society. So anybody who watches and has any comments or questions can put that up in the chat box as well, and we will take them up as time permits and according to the relevance. I would especially like to thank my boss and mentor, Dr. Shamrao sir, who has come here despite a very pressing another assignment. Thank you so much, sir, for making it. He's one of the reasons why maxillofacial surgeons are the reason why maxillofacial surgeons are in the field of craniofacial surgery today. We are all his prodigies, and he has set up everything. I'm sure the other specialties would have something to say, but I'm thankful for. Thanks for being here. Suhas.
Good morning, everybody. And again, as a part of the organizing team, I would welcome you all again to this place. And I realize that all of you are highly dedicated and going to be a part of the core craniofacial teams in your own institutes. I'll just tell you the scheme of the next set of the program. So we have, if you noticed, we have created a different kind of format for the program. It's a multidisciplinary panel discussion approach, where each, we all realize that craniofacial requires such a kind of a multidisciplinary togetherness when you approach a problem. So we have each of the panels will have dedicated specialists in their own field. So that can be a plastic surgeon, maxillofacial surgeon, a neurosurgeon, of course, and an ophthalmologist, an intensivist. Of course, the psychologist is not involved in this session, but that's the motive, to get together. The thought process of thinking together for these children who are sick and need support from us. So the whole idea of the panel discussion was to collaborate and work together for the goodness of these children. And at the same time, we realized that the youngsters are the future. Youngsters and the younger of my colleagues are the future. So we have identified specific colleagues from my different institutes so that they become spreaders of this message across the country. I have a general instruction to the moderators and speakers that as you take care of your highest level of scientific information amongst you, ensure that there's a youngster sitting across who might be the next level of craniofacial surgeon. So we should all ensure that everybody is taken care of in terms of knowledge and the message which we are trying to portend beyond this room. Thank you, and welcome all again to sessions.
We should try to keep it as interactive as possible. Even though there are panelists on the stage, I think we all should contribute and ask questions and debate as and when required. Yeah, Zoom is open. So we shall start the proceedings.
Om Amriteshwaraya Namaha. A very good morning to one and all of you, one and all gathered here. I once again extend a very warm welcome to all of you to Amrita Craniofacial Update 4.0 Interdisciplinary Discussions in Craniofacial Surgery. This program involves professionals from various medical disciplines collaborating to address the diverse aspects of craniofacial surgery to provide comprehensive and holistic care to patients with complex craniofacial conditions. Without further ado, we begin with the first session of the day, Approach to an Infant with Craniofacial Anomaly. So I welcome our moderator for today's session, Dr. Deepesh Rao, eminent surgeon from Bhagwan Mahavir Jain College, Bangalore. I also invite our esteemed panelists for the session, Dr. Sujitra, Department of Ophthalmology, Amrita Institute of Medical Sciences, Kochi. Dr. Grishma Isaac, Department of Pediatric Pulmonology, Amrita, Kochi. Dr. Anil Murarka, plastic surgeon from Amrita Institute of Medical Sciences, Faridabad. Dr. Anurag Sharma, neurosurgeon from AIMS, Faridabad.
You'll take that out. I don't need a platform. Hi, good morning, everybody. I think the stage is set for a very intense 1.5 days of interactive session. Should I ask the panelists to come on stage, or should we? Yeah, please, panelists. And so, like planned, we will, because it's a very small and cohesive group, we will have it interactive. And from the conversations that we were having in the corridor, Suhas sir was mentioning a few things. I think this is where we will have a very good discussion from what we discuss and brainstorm in the corridor to having it discussed on the main platforms. So I'll let the panelists settle down. So just as we could expect, since I was saying about the corridor conversation, the first point that Suhas sir was mentioning about was how a patient that Vaibhav had seen in his clinic, and he was convincing the patients about the treatment options and all of that, and how the way he convinced the patient really helped him to carry on with the treatment. So the first thing on the slide is, when you diagnose a craniofacial anomaly child, child with a craniofacial anomaly, especially the non-syndromic ones, what do you do next, sir? I will take it as because the patient might come to your OPD. So how do you go about it? From laying the roadmap for the child? Are you going to go into all the details? How much is too much information at the first instance? And what are the next steps in terms of investigating and setting the tone for the child and the parents?
Good morning, everybody. Whenever we see a patient with the craniofacial anomalies, the first and foremost is the clinical examination, and then we have a tentative diagnosis, and depending on that, we further evaluate. And most of the time, our approach is always multidisciplinary. Suppose a patient comes with the, like as you said, it's a non-syndromic one. Suppose a patient comes with a depressed forehead, and we're thinking in terms of cranial synostosis, maybe unicoronal synostosis, and depending on that, we further evaluate, and that is how we always progress. Usually, we start with the clinical ones, then we do the multidisciplinary consultations, then radiological investigations, and genetic investigations.
Right.
This is how I'll go.
So, do you want to add some points?
Neurological,
yes.
Yeah, definitely.
So his question was actually, sir, that how do you break it down to the parents, who have suddenly been told that your bundle of joy is having so and so, and he said specifically non-syndromic. So the problem is that usually non-syndromic ones are very easily missed.
Yes.
It's a very good thing that someone has diagnosed it, because unisutural comes to us very late, unlike
Correct.
in the Western world where the diagnosis comes very fast. Getting any patient here in the window where you can probably even offer the endoscopic surgery, it doesn't happen in India. But once majorly the workup which is going on simultaneously, so Dr. Anil, usually in the first visit only, the parents, they meet him, they come to us, meet us, and as a single phase, our first responsibility is to allay down the fears of the parents. That see, it's just a simple. I mean, as you mentioned, non-syndromic. The moment it is syndromic, then of course you have to break down. You have to tell that it is not that it is just problem. It is a multiple spectrum of problems. These are the problems which are going to have. So it's to convince them that first of all that it's not a very big deal. You can probably deal with it, and the kid is going to live a normal life. And for syndromic ones, of course, you have to lay down the road, because it doesn't happen that one surgery is going to be curative, or most of them are going to require stage procedures further.
We give them some idea initially, and depending on that, like suppose we diagnose some non-syndromic craniosynostosis, we give them some idea. This is what we think of, and this is how we'll approach. And these are the usual sequelae if we do surgery, and we explain them to some extent, not exactly in full details, because we don't have confirmation of diagnosis. And once we have radiological and other disciplinary opinion also, and then we tell them in full detail. Initially, if you tell them in full detail, they get scared.
Correct. Too much information at the first instance is slightly much more worrying. Is there anybody in the audience who wants to contribute. Let's assume there is a child with myopic craniosynostosis, not very trigonocephalic, and the question that the parents will always ask is this going to impact my child's growth and development? I'm not really worried if the child is not the best in the class, if the child is going to do average, but I'm not sure if I have to go through this entire ordeal of getting a surgery. And they have presented late. So I will.
Yeah.
They've come at around 3 or 4 years of age because of that mild trigonocephaly or pointiness of the forehead, and now they're like there are no signs. So would you at that point send them to the ophthalmologist, and if so, what are the things that you will look for, and what are the next steps for this child? Let's assume a scenario, a 3-year-old child with a mild myopic craniosynostosis, not shouting trigonocephaly right at the outset. Parents are guarded. They're not very sure that an open surgery is something that they would want to go through it, because we know that open surgery is like driving in the fast track. So what would be your advice be, and what are your things that you will evaluate for that in that child? So do you want to take that question first, sir?
Yeah. We have to explain them all about pro and cons of surgery. We have to tell them this is what will happen if we do the surgery, and this is what will happen if we don't do the surgery. I mean, even if it is a non-syndromic single suture craniosynostosis, there are incidences that they may have neurocognitive, to some extent, problems in future. So we have to explain them in detail about all this. That is what I'll say.
As far as ophthalmologists are concerned, we are concerned about corneal exposure, then disc edema, then squint, and lobe relaxation. So corneal exposure occurs when there is severe proptosis and inadequate eyelid closure. So that if the situation is like that, we have to intervene early. So initially we can protect cornea by using lubricant eye drops, and we can do tarsorrhaphy. That is as a temporary measure. Permanent is that traction surgery. Then if there is disc edema, that means there is raise in intracranial pressure, that should be corrected as early as possible. Otherwise it will lead to optic atrophy and the child will lose vision. Then squint we can tackle later. Once the orbit is stable, then we can correct squint by muscle surgeries.
One thing I'd like to add I mean, depending on the types of craniosynostosis, we may have deformities which are associated.
Yeah.
And that can have psychosocial implications, especially teaching in the school and other things, because they are not exactly fitting into the normal population. So that also has to be explained. And if we have unicornal synostosis, if we don't treat that, there may be like twisting of the face in the later part of life because of the base is deformed.
So even in
these are all have to be explained to the parent.
So also in single suture synostosis, because I have now put this slide up, that single suture can be syndromic. In such situations, do you do genetic workup? And if so, and if they are syndromic, what is the... You want to take that question, sir? You can take it.
I'll go back. So if for example, you mentioned that whether we offer surgery for a myopic, if it's not a myopic ridge, it's a myopic craniosynostosis. So now we have enough evidence. There's a large series of cases from Japan where they say that age is not a debar. Earlier, the concept of that craniosynostosis surgery is only cosmetic is now not considered. So at every age, we don't know how much is to be translated, but there in the Japan series have shown that, that if it is a craniosynostosis, opening up and providing some space does help patients.
Yes, sir. Sir would want to highlight something. Is there another flow mic? Flow mic.
And to add that the society currently is becoming more, cosmesis conscious society, with everyone uploading their photographs every now and then, people commenting. So the picture or photograph of a kid, when people share it, it's more open to comment. And as he said, that bullying in the school and all.
Just to add to what Anil and everybody said, two issues you have to think when you are looking at a child. One is functional, other is aesthetics. Now the problem is functional has to be treated, no doubt about that, and aesthetics also has to be treated because this child have to be under peer pressure all their lives. So you have to tell the parents about both the aspects, and I believe that in my experience, even when they come late, they do benefit functionally also from surgery. And to what extent I cannot guarantee to each patient family, but there are children who are doing academically, I would say, even better than they would have otherwise, but I have no way to prove that today. But they go on to lead a normal life. I think not operating, you are entering into a territory where you may not get a reversal of the problems that are created over a period of time. So we must go ahead and do something about this.
So Dipesh asked us like the child presenting at 3 years of age. Suppose the child presents even later also. So in that case, what will be our approach? 6 to 9 years, 90% of brain growth is there.
So 6 to 9 years, technically brain growth is completed. Largely it may be cosmetic in nature. However, I cannot preclude the fact that over 10 or 11 or 12 years, they may not develop complications with relation to compression of the brain, because over years what I have seen is a lot of children whom I have missed out, but I have identified as children and I did not operate, have not made it to adulthood.
So is it safe to say that you can periodically follow them up to see if there is any raised intracranial, because the parents are apprehensive. Now they are at the period where the brain growth is almost complete because he is given 6 to 7 years of age, and you have not actually picked up any signs of raised intracranial pressure or gross developmental concerns. Would you just periodically every 1-2 years follow them up?
Provided the parents insist that they are not worried about the aesthetics. However, the problem is not with the parent. The child will grow up. And when the child becomes an adolescent, he will say, why did I not get operated? Because if it was correctable. Because he is in a decision making position at the age of 17, 18 when he is looking for a job in society. And I don't think he wants to walk around with a trigonocephaly and look for a job and be in society. So I believe that we have to educate the parents that it is important to give them a fair chance in life.
Yes, sir. So Suhas wanted to make a point.
I think the functional aspect is very clear. Even non-syndromic ones can have functional aspects later in life. Like SCAFO itself can present with papilledema later in life. So functional follow-up is mandatory. But I think we should not belittle the fact there's a psychological impact of all this. And a reasonably well-performing child, because of a psychological impact, might become a poor person, a poor citizen in the society. So I think that message equally needs to be well marked.
Yeah. Sometimes I am not able to answer myself. Have we ever seen a adult patient untreated with mitopic synostosis?
So I would like to also add that probably to identify which suture is involved is also important. So far we had been only talking about mitopic suture.
Yeah, because so metopic and the scaphocephalic or the sagittal are the ones who tend to miss out. Unicoronals eventually present. That is one of the reasons why in our society we are doing more unicoronal than the others. Sagittal, in fact, invariably gets missed because they are slightly long and narrow, and hair grows. The narrowness is camouflaged with the growth of the hair. So metopic was the reason I picked up metopic as an example, because unicoronal invariably gets picked up. Metopic gets picked up, but again that's like a slight anomaly of the forehead, little pointy. They don't really worry about it as much. Sagittal, they never worry. Of course, now with the, like we were saying, with pictures and all of that, they're slightly now getting picked up more than before. But for a large period of Indian craniofacial society, there was this conversation that we have very low incidence of scaphocephaly, which is not really true. It cannot be true, because if scaphocephaly is the most common, yes, yeah. So
can I ask a question to the neurosurgeons? See, to us these children are presented with a aesthetic deformity. Right? But to you, these children come with functional issues, is it not? Is that, am I right?
I guess they come with both, sir. Sometimes because they are abnormal head, they'll just send to the neurosurgeon invariably. That's something that happens.
So in such patients, we're talking about whether we operate or
Yes.
not. So what would be your thought process in decision making whether to operate and at what age?
I think functional aspect is very clear. So once, let's say, neurologically, if let's say, I mean, if I use the word damage done, so beyond adolescent, I would be very skeptical on why to operate. Beyond adolescent, I would be very skeptical on why to operate, because these are very morbid surgeries otherwise too. You don't want a child who is alive and doing reasonably well to be subjected to a morbid surgery. So within adolescence, before they probably develop their self-image, I mean that's of course around 5+ years, I would still give them a chance. Aesthetics,
we will go ahead because we will touch upon these topics, and I will try to keep to time because we have more things to come up. So is it safe to say that all our children require genetic workup as soon as you identify a craniofacial anomaly? Because there is a thing that either they are syndromic or non-syndromic until diagnosed as syndromic. Is that a common practice that every child gets a genetic?
Come again, please.
So is it common? Is it a common practice for every child to have a genetic workup?
It is. It is important.
Anybody in the audience wants to say that? Yeah.
I think it is more pertinent in non-syndromic patients, specifically in which they have familial history probably, or like some craniosynostosis like coronal suture synostosis, which are more prone to having, because to identify these specific variants, because there are a large number of variants which may be involved in the genetic workup, to identify in a non-syndromic patient may be very, very difficult. But specific craniosynostosis like probably a bicoronal and probably a family history would should definitely go for a genetic workup in a non-syndromic patient.
Yeah, we have unicoronal craniosynostosis. In fact, now there's midline sutures like metropic and sagittal are linked with SMAD6 variation. So there are genes now responsible for so many single suture craniosynostosis also, in particularly the unicoronal. And the reason why we probably need to make sure that we have some knowledge whether they are syndromic is because children with syndromic unicoronal do not have tend to relapse later. So they eventually, after your good FOAR, they become flat again on that affected side. Is that a common observation, Sir Shibu sir? You?
No, my approach has been slightly different in that. So if it is, we are talking about non-syndromic.
Yeah.
So if it is non-syndromic, I explain to the family what are the pros of doing a genetic workup, because it's not cheap.
Yes.
So very often patients may not be willing at that point to spend that extra money. They would rather put it into the surgery. So you explain to them what are the things you're going to gain from that genetic analysis. First, secondly, have they completed their family? Is it going to change something in their future children? Is it going to give them any additional information? So based on their feedback, there are families who are very keen on knowing all these things. There are others who say, no, we'll hold off. So I leave it to them. I don't push them and say this is an absolute must. And that's how I approach it.
But what if, suppose, let's assume that a child with unicoronal craniosynostosis is a mu-K and you've done the FOAR. 6 years later, they're flat again on that side because the gene still has its print.
No.
What if the child has a metropic or a sagittal and has a SMAD6, and you know that SMAD6 children do not have a high IQ, they do not develop well, they may have cardiac issues. So again,
so anyway, all these kids are going to be on follow-up.
Yes, sir.
Okay. So we tell them that if this is the case, A small number of these children are likely to recur, but most people are not going to recur.
Right.
You have to be under follow-up. You're going to be on serial neuropsychological evaluation. If you find things are changing, these are the things you're going to do. So we have to lay down the entire path.
Yes, sir.
So that they are very clear on what is the choice they are making. So that's how I look at it.
Yes.
So if we take out the cost factor from this, I think it should also be done, because the more we'll do, the more we'll understand. Unless we have the data to compare the whole, that what genes have gone back, and then somebody starts looking into it, and then somebody starts asking for it. If we do a specific tests only to know about certain syndromes, then we miss the point. So yeah, it's a costly affair, but if we remove the cost, I think I would want to get it done in all cases.
So I guess with time, we have to push for the geneticist also to become, to make sure that these tests are, more reasonably priced. Eventually it will happen. I think it is all about the reagents and all those things which are right now expensive, but with time, with more usage, it might get cheaper, is our understanding as well.
These are out-of-pocket expenditures.
Correct.
And one more question, which is very important to answer to the parents. If he asks, or if they ask, what is the chance of my second baby if the family is not complete, having the same problem as like this in the next baby? So genetic counseling and genetic testing is very important for that also.
Yes.
I think there are some ideal scenarios where we are talking about genetic mutations we are trying to rule out, but the best way to forward would be to have a pediatric geneticist, as you said, and let him screen him or her screen first the baby and then decide on the further genetic analysis, because I don't think, as everyone said, it's not as cheap as what we think. And imagine the number of genes that we are looking for. And if you're talking about
now they're doing a broad panel, and most clinical geneticists kind of have an idea on what particular gene to look at. It all depends on the clinical geneticist. So a broad panel roughly costs in around 10,000 to 12,000 rupees. Again, when you look at it, it is not very off the mark when you put it in that whole purse of the surgery. And it works out better once everybody understands what are the particular genes to look at. So, for instance, if you're doing, if you're trying to look at a unicoronal, these unicoronals are associated with common syndromes, and probably just run those panels. Invariably, you may hit one or two. If most of the times you may not. They may all be non-syndromic ones at all.
And I think we need to look into the goal that we are looking into. Like, I mean, what is the the solution that we'd offer if a certain mutation is detected.
Correct.
Whether that's going to change the process, I think that also needs to be balanced.
So now I'll just quickly go through the next point. So this is to the pediatric intensivist. So as to, we have these issues with craniofacial children who have apnea. And this is so we are taking away from the cranial, they have also the mid-face involvement. Sometimes they have a mandibular involvement. So they can be either trichocolin or cruzon. In such situations, we always know that, okay, there are these sleep studies to be done. But how reliable are these sleep studies? Because interpreting these sleep studies is purely your domain. We hardly get anything out of those patterns that are made. So how reliable is a sleep study? What are the other things that you would want to highlight in children who need an investigation for apnea?
So in less than 6 months, the sleep in these infants is very fragmented. They don't have a continuous sleep. So it's very difficult, and the EEG pattern is also very different. So it's very difficult to interpret sleep studies in such infants less than 6 months. Moreover, the right-sized probes, binders, all these things are also not very freely available. So less than 6 months, it's very difficult to get a sleep study, and it's not very reliable. In more than 6 months, there are a lot of practical difficulties, but if there's a dedicated pediatric sleep lab, we can have the data and we can interpret the data in this sleep study in more than 6 months.
So what does the composition of this dedicated pediatric sleep lab? What do you need in that?
Yeah, I think it should be more. The parents should be able to stay with the same. The things are same EEG, the nasal cannulas and binders, appropriate size for the infants. But it should be a more comfortable environment where the infants are able to sleep and be with the parents and interact with the parents, so that their sleep patterns are not disturbed.
Are there facilities for home studies?
Actually, in patients less than 6 months, I mean more than 6 months, what we do is do overnight oximetry with a transcutaneous capnometry. So that gives an idea about the gas exchange. Probably many things, arousal index, the pattern of sleep stages, we can get an idea. But if there is any abnormality in the sleep or gas exchange, which is the main determinant for your intervention, that is possible. So here we just ask them to take a room in the nearby guest house and we do it in their environment with the parents. So that gives an idea that that is more feasible. Even in small babies, less than 6 months, we can do that.
And for how long in children with an apnea, say a mild apnea, would you continue to do conservative management? Because there is this talk that children grow, and with growth there is enough airway development that they do not have apnea anymore. So do you wait for a particular period?
I think it's mild sleep apnea, like where we don't have multi-level obstruction or anything. So if there's no gas exchange, we should look for any gas exchange abnormalities. If not, we can just conservatively monitor them continuously. Most of them won't have much gas exchange abnormalities. So some cases where there is a period opens where we can insert an esophageal airway for temporarily till the patient goes. In that case, conservative management can be used. Sometimes if there is also adenotonsillar hypertrophy, either you can use nasal steroids and adenotonsillectomy in left conditions, we can advise them for that as well.
Right.
So I think in mild sleep apnea, most is conservative. CPAP and BiPAP can also be used, but it is difficult if it's a mid-facial hypoplasia. So CPAP and BiPAP can also be advised for them if there is gas exchange abnormalities predominantly. I think most of the decisions will be based on how the oxygenation and the CO2 retention throughout the night is.
Right.
I'm sorry for the interruption. We have 5 more minutes of the designated duration.
Yeah, so I'll just, and I'll just come up to the relevant topics so as to make sure, because there are, most of these topics will be also touched upon in the subsequent session. So we know that we have this conversation about blood loss during these surgeries. So what is an ideal amount of blood loss according to you in a child, say weighing 10 kilos, right? And how much percentage of volume? Because I think it is not right to say the volume, it is about the percentage. How many pints of blood do you reserve? And if there is a massive blood loss, what is your protocol?
Yeah, I think it's like severe blood loss is considered if there's a 10% loss in the blood volume. So in that case, loss decrease in the blood volume. So if it's a 10 kg, maybe like consider like at least 100 to 150 ml should be significant blood loss. So in these cases, we normally reserve at least 2 to 3 pints of blood. So if there's a massive blood loss, we should activate the massive transfusion protocol, where you transfuse 1:1:1 ratio of PRBC, FFP and platelets. If you keep on giving PRBC alone, they become more coagulopathic and there will be no bleeding. And also in pediatric population, I think we should use warmed blood products so that the coagulopathy doesn't worsen, and we should monitor potassium closely when you go for this massive blood transfusion. So I think mainly 1:1 ratio, and main thing is to know why the child is bleeding. Is it a coagulopathy? Is a surgical cause which can be corrected?
So during your surgeries, when you are doing the craniofacial anomalies, when you take the bone panels out, do you soak them in some, Ganga Jal, like an antibiotic solution, or is that a common practice? If so, why? And
I don't know it.
No. Anybody else does that? Put it in gentamicin solution? No.
Just put it in betadine,
Betadine.
diluted with saline.
Right.
Nothing else. I don't think anything is really required.
Yes.
In that sense. Coming back to blood loss.
Yes, sir.
Blood loss on table is the critical component,
Correct.
not off table in the ICU.
Yes.
And on table, what we always do as a precaution is that we keep the blood in the theater as we start the surgery.
Yes.
So by the time you raise the scalp, you already have an idea, depending on the if the venous drainage is under pressure, you would have increased perforators coming out through the skull, and you'll see the bleeding. So we keep a bolus ready in case we need, and if we come across a severe loss, we immediately shoot in a 50 ml bolus and restore the blood volume. Of course, it's done by the anesthesiologist, but I'm just putting you in the picture.
How many lines are you comfortable with having? So if you say that this many lines or this many lines I have with this size of cannula in, I'm comfortable for the surgery. What is your
Yeah, I think the surgery is predominantly anesthetist managing that, but I think there's like good lean in central line with triple lumen and then peripheral cannula and an arc line monitoring the blood pressure should be ideal for this case. Bare minimum you need to provide the surgery, yes.
Do you keep the patients intubated overnight in your immediate post-operative care?
I think the indications to keep motivated is it's a major airway surgery. The child had previously severe obstructive sleep apnea.
Surgery?
No, not normally, I think. If there is not it's a simple surgery and the child didn't have any difficult intubation, intubation was easy, and there was no trauma during intubation and there was no severe or obstructive sleep apnea.
Keep the child intubated overnight? You do, sir. Intubated overnight. If you have had a calvarial procedure only, say a single suture synostosis, you've done an FOAR, does the child go back to the ward intubated?
Yes.
Or ICU intubated?
Yes. Earlier, about 30 years ago, my anesthesiologist, the PICU was not as developed as it is today, and they would like to keep the patient extubated. So they feel everything is fine and all that, and they go to the so-called PICU those days and do well, but sometimes may need reintubation and other things. So now as a protocol, last 15-20 years, we have been keeping them intubated overnight and extubating next morning.
So just to highlight then, in children who've had return to theatre, what is the usual reason to go back to theatre in the immediate post-operative period? Because the other things will determine that, okay, you've had a child, so you've had a large experience. How many of your percentage, roughly, ballpark, patients have required return to theatre? And if so, for which reason?
Two patients.
Two patients in this 30 years of your practice.
One is hypertelorism, which I corrected.
Again, a very complex procedure.
And the night I get a call that the patient is losing vision.
Right.
And need to do something. So immediately we had to undo all
This was a hypertelorism patient who was losing vision. Because when you do a calvarial procedure, there is so much space. Invariably,
there is no issue of that. This was a hypertelorism patient. And we had to actually remove all the plates and screws. And it took more than 15 days for the disc edema to settle. And the vision to come back. It was a very slow process of recovery. After that, fortunately, the patient decided not to go for any more surgeries with me. So I think that was the right thing to do. So the second case was when the child developed meningitis. And we had to take out, because of gross edema, we had to take out the calvarial bone. That was the second patient whom we took back to theatre. And when the child recovered, we put the bone back.
Okay.
These were the two cases.
So which means that you don't really need these patients to be intubated overnight, because the return to theatre also is not very common.
Well, maybe it's because we keep them intubated overnight. I don't know.
Okay. We don't. One last question I want before I wind up. When do you examine the child again to examine the fundi and say that the previous papilledema has resolved? That's one of the questions that I think is important to understand before.
Apart from papilledema, you have to protect cornea. That too, you have to include in the immediate post-op care.
Yes.
Because that is very important. Once everything is ready, if the cornea is exposed and it leads to central corneal opacity, that causes severe vision loss. So that we have to be very careful in the immediate post-op care. Then regarding papilledema, it takes time. It won't resolve quickly.
How
At
much
least
roughly?
6 weeks.
6 weeks? Okay. So
then only we will be able to
I guess
see that it's
it's
resolved.
safe to say
in
3 to 6 months. Just to actually
to completely
because
resolve.
again
starts
looking into the fundi of these infants is also very tricky, isn't it? It's subjective also. So you might as well wait for a longer period.
Longer period.
Yes. All right. Thank you so much. Thank you so much, sir. Thank you, ma'am. Thank you.
Thank you, Dipesh sir, and all the panelists for his enlightening session. We'll move on to the next session by Dr. Sajid Keshavan, pediatric pulmonologist, Amrita Institute of Medical Sciences, Kochi, on interpretation of polysomnogram in children. We have a recorded lecture of the same.
Today we're going to talk about polysomnography in children. So let's look at what are the indications for sleep study in children. Good morning. I am here to present to you about polysomnography in children, mainly talking about the indication and the interpretation of polysomnography in children. I'm a pediatric pulmonary as well as a pediatric critical care physician working in Amrita Institute of Medical Science, and my training background is from both pediatric pulmonary and pediatric critical care. Today we're going to talk about polysomnography in children. So let's look at what are the indications for sleep study in children. One is to have a clinical suspicion of sleep disorder breathing. And the clinical suspicion is generated based on symptomatology of snoring. The parents have noticed some apneas, and they have noticed some labored breathing or choking episodes during sleep. So a normal sleep position where the child sleeps during sleep. Multiple times the child is awakened and has disturbed sleep, or there's a lot of daytime sleepiness or hyperactivity. We might also do sleep study in children whom we think is at a very high risk of sleep disorder breathing, even in the absence of symptoms. Especially when you have a surgical intervention planned, so that we evaluate the child before and after the surgical interventions with polysomnogram. We will also use it for titration of BiPAP and CPAP support, and also to diagnose nocturnal hyperventilation in children who might need chronic mechanical ventilation. There are also non-respiratory indicators like hypersomnia, narcolepsy, etc. We're not looking at sleep disordered breathing, but more of like abnormalities in sleep, which are not related to the breathing. Let's look at a list of diagnoses where there's a high risk for sleep disordered breathing. One is the genetic syndromes like Down syndrome and Prader-Willi syndrome. The mucopolysaccharidosis, the chondroplasia, Amrita malformations, and the craniofacial malformations, which include isolated cleft palate, Robin sequence, and Apert and Crozon syndrome. Then you have children who are obese and children who have adenotonsillar hypertrophy and children who are hypotonic. They're all at risk of sleep disorder breathing. When it comes to sleep diagnostic, the first thing that we have in our armamentarium is a Sherwin questionnaire, which is basically called pediatric sleep questionnaire, especially the sleep-related breathing disorder scale of the PSQ is very useful. The different types of sleep studies, like you have the overnight oximetry, you have the oxycapnometry, we have the cardiorespiratory polygraphy, a home sleep apnea test, as well as a polysomnogram. There are different levels of sleep study, where a level 1 is what we do in the hospital in it's fully attended by the technician who troubleshoots artifacts and disconnections and so on, which happens during the study. Then you have tape 2, which is also a polysomnography, but it's without a technician attending it full time. And then we have limited channel study like the home sleep apnea test, or we have the cardiorespiratory polyraphy without the EEG monitoring, which is level 3. And we have the level 4, where we have just 1 or 2 channels, usually using oximetry as one of the parameters. The question is why you should order a polysomnogram and why not one of these other levels of studies. The main reason is history is often inadequate to differentiate OSA from primary snoring. Not everybody who snores has OSA. The second reason would be in a high-risk patient before interventions to confirm OSA so that the risk of the surgery is justified. Third is to determine the severity so that you can plan perioperative monitoring and care. Children, it's known a fact that children with very severe OSA have more complications in the perioperative period, so they might need an ICU bed and so on. The next would be to test the efficacy of the surgical intervention, because this is the best objective way to know whatever you have done has helped or not, and to also quantify it. And also we use it to titrate a BiPAP or a CPAP support. This is the sleep questionnaire, which is basically a 67-item questionnaire, of which there is a subscale called the SRBD scale, which has got very great predictive value, positive predictive value when the scores are more than 30%. Overnight oximetry is a very simple and useful tool which we use in our hospital, where we have a special oximeter attached to the patient for the night, followed by the next day when we analyze this data in the computer, and the computer software gives us a printout showing these clusters of desaturation and the nadas of desaturation, and it also gives us a desaturation event index. All of these are very useful in selecting out patients who might have significant OSA, especially the ones with significant gas exchange abnormalities. Capnometry is a non-invasive method of estimating carbon dioxide levels either by transcutaneously or by end-tidal levels. Cardiorespiratory polyraphy combines desaturation and saturation data with the respiratory events like apnea, because it also has a pressure sensor as well as the movement sensor in the chest and abdomen. Polysomnogram is the gold standard because it has got multiple channels, like it monitors the EEG waveforms, the eye oculogram, the chin EMG, snoring, flow, nasal pressure, bands for chest and abdominal movements, EMG for leg movements, ECG for arrhythmias, saturation for desaturation events, and as well as carbon dioxide is measured and depicted by either transcutaneous or end-tidal CO2. It also tells us about the position of the patient during each phase, as well as the level of the PAP therapy that the patient is on. So AEG helps to score the sleep stages and to document arousals. EOG is very useful to identify REM stage. EMG is also useful for staging of REM sleep. REM sleep is very important in any sleep study because it is during the REM sleep that you have the majority of sleep disorder breathing events that you see. Flow is for thermistor. It senses not only the flow through the nose but also through the mouth. And nasal cannula is more to document hypopneas. You have chest and abdomen bands to differentiate between central and obstructive apneas or hypopneas. You have saturation monitoring, EKG monitoring, as well as CO2 monitoring for hyperventilation documentation. To note that hyperventilation criteria according to American Association of Sleep Medicine is slightly different in kids, where the cutoff is 50 for more than 25% of the total sleep time. The other important definitions for respiratory events are obstructive apneas, where you have events, breathing events which last for more than 2 breaths, and is also associated with a fall in amplitude of nasal pressure signal more than 90% accompanied by inspiratory effort. If the same events are not accompanied by inspiratory effort, then they are called central apneas. And hypopneas are basically only 30% fall with associated arousal, awakening, or desaturation. OSA is classified into mild, moderate, and severe according to ASM, and you have to note that the pediatric criteria is slightly different. The normal values also are different. So if a child has an AHI of 12, it corresponds to severe OSA, whereas an adult with an AHI of 12 only has a mild OSA. Why you need to grade the severity is mainly because if it is mild, it usually indicates that a surgical intervention may not be needed, and you can try with wait and watch method, or you can do nasal anti-inflammatory medications, especially if there is not much of daytime symptoms or gas exchange abnormality. But if a OSA is moderate to severe in a child, it often indicates the need for treatment. It could also be like a PAP therapy and need not always be surgery. When reading a PhD report, these are the important things that you need to look at. One is minimum of 4 hours of sleep with at least one REM stage is needed, so that we know that we have got good data. So look at whether there is sleep fragmentation with multiple arousals and stage shifts during the sleep. We can measure the sleep efficiency. We can look at respiratory events. We can know the total AHI as well as the grading of OSA. We can look at the gas exchange parameters like oxygen and carbon dioxide data, and we can also document whether there is hyperventilation or desaturation. When you see a PhD report, the first part will have patient details and technical details of the study, including the technician's comment, followed by a hypnogram which indicates the sleep architecture, can measure the sleep efficiency, time taken to go to sleep, total sleep times, whether there's a sleep fragmentation or not, look at different stages of sleep and how it contributes to the total sleep. You can also look at obstructive events, and central and total AHI can be measured with scoring. You can also look at gas exchange parameters like desaturation, hyperventilation, and finally you will have a recommendation by the pulmonologist as to what is the next best step for the patient. So again, running through a checklist, is there enough data? How good was the study? How was the sleep quality, and were the respiratory events? And if there were respiratory events, what was the grade of the OSA? So if you look at a typical sleep study report, at the end you will have this pictorial representation, which includes the hypnogram, which tells you the different stages of sleep, and also tells you whether the sleep is very fragmented. It can give you an idea about the respiratory events in the next row, followed by saturation data in the next row. So you can see the REM sleep corresponds to a lot of obstructive apnea, which you see on the second row, which corresponds to a lot of desaturation, which you see on the third row. And if you look at the last row, which actually indicates how the CPAP was titrated, is a split night study. So the first half of the study until 1:24 a.m. was done with the patient without any PAP, and the second half has been done on positive airway pressure, and see how they have escalated the CPAP pressures, mainly looking at the events, and as they titrated up, you can see the respiratory events are coming down. But unfortunately, in this patient, if you see, there's a lot of arousals and fragmentation since the patient has been started on CPAP, which might be because the patient was a little uncomfortable with the CPAP as well. So that's an overall picture of what a polysomnogram means and when it is indicated and how it is useful in the management of patients at high risk of having obstructive sleep apnea.
Sleep study in pediatrics is a very different thing from adolescent and adult sleep medicine practice. One is AHI of anything below zero, more than zero, that is AHI of 1 is significant. We have to remember that we cannot classify them as an adult, which is 6 as a mild OSA. Second, desaturation 10% is considered as relevant in adults, but even less than that would be very significant in babies. So when you're practicing sleep surgery as with respect to craniofacial anomalies, I think we have a panel on that, whether you should look at the ICP first or the OSA first. I think whatever is going to damage the patient first is to be treated first. We'll come to that when we have that panel, but I just wanted to bring this point out.
Just to sum up, if a patient
If there is a complaint of sleep apnea by the parent about the child, the first thing is you give a questionnaire. Yeah, and what will be the criteria, ma'am, for us to take the child to the next level of getting a polysomnography?
So if there are symptoms like more snoring, they are noticing apneic events, or there's a desaturation. First, we can even do an overnight oximetry and see the desaturation events. And there are these, the parents have noticed apneas. Normally, we advise a PSG, but it's not always possible in infants. So mostly we go with transcutaneous capnometry with overnight pulse oximetry. Then we make a decision whether to go for PSG is really indicated.
So the parent comes with the child. She says that the child is having apneic spell. You ask her to fill the questionnaire first.
Yeah, like not normally. We just normally take few things. Ask is the child snoring? How is the daytime activity? Sometimes in pediatric patients, they might not be sleepy during the day. They might be very hyperactive during the day. So when they are not properly sleeping during the night. So we ask. We don't normally always go with the questionnaire. We ask few relevant questions, and if we are thinking really there is a chance of OSA, we go ahead with the investigation.
Can I ask how many of you look at the actual witnessed, apnea? How important is that? All these are, objective, but how important is subjective? How much would you consider that?
You wanted to say something first. See, witnessed apnea, you would ideally see if you are doing a level 1 PhD, where you also videograph the patient. So you will get witnessed apneas, restless leg movement, everything would be captured on video apart from objective printout that you get from the machine. Otherwise, clinically, if you are going to sit by the child and the parents don't realize very often that there are apneic episodes. Many adolescents come to my practice who have been treated by psychiatrists as ADHD, and they've been put on either antidepressants or ADHD medication because they are not able to perform well in school or college. And they're tired during the day and the concentration levels are not good. So eventually I diagnose them as OSA and I treat them as OSA, and a lot of them get better. Not all, there are some ADHD patients as well. But you have to be very careful that you differentiate the symptoms. Patients may not present with these apneic symptoms as a primary symptom. That is the main problem. So your degree of suspicion about the patient should be quite high. I'm saying this because I practice sleep medicine in my private practice. That's why I see adults as well as pediatrics.
Yeah, I think apart from the objective, we all agree that infants, it's difficult to get a sleep study. So one of the things I have observed, and it's a regular thing in babies, is the presentation as failure to thrive. Children presenting as failure to thrive, and even though the family might get you the objective evidence, including the PSG, if you have a failure to thrive, you start thinking of, especially in these syndromic children.
So I think you have to differentiate the kind of patients you see, whether you're seeing very young children or you're seeing older children. So when you see a very young children, the damage is a potential damage which can happen and which can be prevented. In an older, there's already some damage done. When you see a very young child, what we look at is failure to thrive, whether they're reaching their milestones, whether the weight is appropriate. And also look at, we ask the parents to send videos of the child sleeping. If you see distress when the child is sleeping, then of course you have to consider it more seriously, apart from these objective parameters. Can we move to next? Suhas?
Now we have a pre-recorded session on perioperative concerns for craniosynostosis correction surgery by Dr. Matthew George, anesthesiologist, Amrita Institute of Medical Sciences, Kochi.
Good morning, my surgical colleagues, delegates, chairpersons, and organizers. I would like to thank Dr. Suhas and Dr. Pramod for giving me this opportunity to present this topic here today. So, craniosynostosis correction surgery or anesthetic viewpoint. So, surgery, anesthesia for craniosynostosis is definitely regarding as one of the more challenging cases that we might face. So, why is it that this is so? These syndromic children not only are they difficult as is because of the basic complexity of their physiology, the surgery's nature also adds a lot of issues to our intraoperative management, especially related to the aggressiveness of the surgery and the site of surgery. So these children present issues to the anesthetist in the form of raised ICP, positioning and airway issues, issues related to obstructive sleep apnea, respiratory infection that is very common in these children, ocular complications, and issues related to the other congenital abnormalities that these children may have. The surgery itself results in significant blood loss and ensuing coagulopathy. There's a high risk of air embolism. Hypothermia is almost universal for many of these children at some point during the surgery. And post-extubation issues and respiratory failure resulting in difficult reintubation is also a major brief. So I would like to briefly touch over an incident we had with a 1-year, 3-month-old non-syndromic metopic craniosynostosis child who was undergoing surgery, and during the stage in which the frontal bone was mobilized off the duro, there was a sudden gush of bleeding, which prompted us to start resuscitating with extra PRBC and fluids, and the surgeon asked for a little bit of backup so as to decrease the amount of bleeding from the surgical. So simultaneous to raising of the head end, there was a sudden drop in the EtCO2 trace. That was over the stage, over each breath, the EtCO2 trace started to come lower and lower. So this is pathognomonic of venous air embolism. So this preceded immediately following this, we had a sudden drop in BP, and there was actually no arterial trace within a minute. And the child was basically in pulsus electrical activity, and we proceeded to take steps to resuscitation. Steps included IV adrenaline, left table tilt, and aggressive boluses of fluid and PRBC. And thankfully, we were able to get the spontaneous circulation back in 3 minutes time. We did not give CPR for this child because the child's drapes were still on, and we didn't have access to the child at that time, but thankfully we were able to continue the surgery on suppose, and the child went home neurologically. So venous air embolism is a very common complication during this surgery. It's almost there in 82.6% of these surgeries, but thankfully only 15% odd of these are actually hemodynamically instability causing. So EtCO2 thankfully will pick up most of these significant emboli, and we are able to warn our surgical colleagues well in time. This is generally managed by supportive measures. So when this child comes to PAC clinic, the syndromic children are bound to draw more attention for us because they are associated with multiple problems. So the commonest ones are Crouzon, Apperts, fevers, rarely Sather-Chosin carpenters or Minkies. So syndromic children generally have these underlying common issues of respiratory infection that may rarely be significant enough to cause a postponement of surgery, but it happens only if the child is actively febrile or looks dull according to the parents' opinion, and or if they have features of flagrant infection like elevated total counts or significant chest signs. But a little bit of running nose is quite common. So all of these children do need a screening echo and preferably a CT chest to rule out any airway issues. And difficult airway is common if these children have midface hypoplasia, choanal atresia, fusion of cervical vertebrae, tracheal stenosis, or scaphocephaly. And many of these children also have difficult eye. So a lot of these syndromic children do end up going for a polysomnography, and many times we do see that it is significantly abnormal, but thankfully the surgery is therapeutic, and many children do well after the surgery despite the fact that they're undergoing an extensive surgery and they have significant sleep. Intraoperatively, our anesthetic issues include separation anxiety, difficult airway management in the syndromic children, hypothermia, difficult vascular access, poor access to the airway and lines introp, blood loss and massive transfusion, venous air embolism, obstructive sleep apnea, and difficult extubation. Smooth separation of these children from the parents is very important since these children do have raised ICP. Most of our children do come with an IV access in situ, and midazolam IV is a preferred drug. If not, oral midazolam is our second choice drug to sedate these children. Other centers do use dexmedetomidine or fentanyl, and we generally do avoid ketamine as far as possible because of the ICP issue. Induction of anesthesia for these children is generally achieved by intravenous propofol or inhalation of sevoflurane with fentanyl, and the humble oral airway is frequently life-saving because that is the only device that will reliably allow us to maintain the child's airway till we get the tube in. Thankfully, laryngoscopy is rarely difficult for these children, but if we do have difficulty, the video laryngoscope is. So the video laryngoscopes we use are the CMAC with the hyperangulated D-blade and the Turin scope. These are both very useful and are life-saving in securing the airway for these children. So our surgical colleagues do prefer RA tubes or flexometallic tubes to be placed in children who are having shared airway procedures. It's very convenient for the surgical team, but the issue is that post-operatively it's a little difficult to manage in the ICU with these tubes, and intraoperatively also, because our children are generally small built, we frequently find that RA tubes protrude a little excessively out of the mouth to make sure that the tube doesn't go endobronchial. We can adjust and stick the tube in such a way that it doesn't interfere, but it does predispose these children for accidental dislodgement of the tube intraoperatively, and it's something that the surgical team has to be aware of. Hypothermia is likely to develop in most of these children because they have a large head and it's quite vascular there, and they lose a lot of blood, which has to be replaced with fluid that is frequently not actively warm. So we do combat hypothermia by keeping the OR as warm as tolerably possible and using forced air warming blankets. So the issue is that if the child does become hypothermic, they can have increased bleeding due to the platelet dysfunction. They become more sensitive to the anesthetics and relaxants, and they may have excessive vasoconstriction and resulting post-op shivering. Positioning these children prone may be excessively challenging because of the protruding eyes that are likely to be injured, especially these children need a horseshoe fixation. We do take care to make sure that all our plasters are tightly secured with occlusive dressing so that the antiseptic materials do not soak into the tubes and loosen the plasters. We make sure that the circuit is firmly fixed to the side so that it doesn't get pulled out intraoperatively. So fluid management in these children is definitely a little bit of an art. We don't have very good parameters to objectively tell us whether this child is underfilled or overfilled. A lot of those parameters are available in adults that technology hasn't filtered down to children yet. So we do use balanced crystalloid with ringer lactate intraoperatively. CVP and pulse pressure variation may be used to guide our fluid management, but they're not always reliable. Most important guide I feel is the actual clinical assessment of the blood loss and intermittently checking for hematocrit to see how far off from the target we are. So from the point of view of the anesthetist, you can see that we are far away. We're pushed to one corner of the operating room. We have very poor access, and these fragile children will need blood transfusion quite early in the surgery. Otherwise, they do become unstable if you don't start blood transfusion once they start losing their own blood. So there are no clear transfusion triggers for these children. Their blood volume may range from 450 ml to 3.2 liters. So of course, the more fragile children will need blood transfusion earlier on in the surgery. And the loss on the surgical side depends on the degree of deformity. That is, syndromic children definitely lose more, and also depends on the number of sutures that need to be freed up. And because all of the loss is very difficult to assess, because it all goes up into the drapes and partially soaked gauze, we start transfusion very early. Rarely the loss may be sudden and associated with sudden instability, and so we rely on communication from the surgeons to actually warn us if there is something that is out of the normal. So the complications of transfusion of allogenic blood include hypothermia, dilution of coagulation factors, hyperkalemia, acidosis, hypocalcemia, and hyperglycemia, and ironically, even impaired oxygen delivery. So many of these children will need blood component therapy apart from PRBC transfusion. So depending on the stage of surgery and the amount of perceived loss, we may rely on clinical parameters and assessment of blood loss, or we may rely on lab and point of care parameters to decide when to transfuse. So INR and the thromboelastogram are our primary agents to decide on which product we need to transfuse. So antifibrinolytics are standard of care for these children. We used to use aprotinine, but now tranexamic acid is universal and definitely been shown to decrease the amount of loss for these children. So we use a dose of 10 milligram per kg as a bolus, followed by an infusion of 5 milligram per kg per hour, which is continued throughout the surgery. Because of all the blood loss and the transfusion and replacement of blood loss, many of these children do develop metabolic disturbances intraoperatively and postoperatively. So acidosis, lactic acidosis, hyperkalemia, and hypocalcemia are the commonly seen issues. And if they are very significant, we do decide to ventilate these children post-op to give them time for their system to recover. So sleep apnea syndrome is a major issue for these children. As you would have seen, 50% of syndromic craniosynostosis do have sleep apnea, and this may both be obstructive sleep apnea and a central sleep apnea, because the anatomical issues are obvious for these children. That's why they're getting operated. But the central sleep apnea very frequently goes under the radar, and this frequently manifests for us post-operatively by excessive sensitivity of these children to even small doses of opioid. So we have to be very careful. We generally don't use opioids as far as possible in the post-operative period because of this. So extubating these children is fraught with danger, especially if you have done a shared airway procedure. You can face a lot of issues in the post-operative period. These children, you can lose their airway as soon as the tube comes out, and having an oral airway is really important again. So basically the rule of thumb is, if you need an oral airway for induction of the child, you will need to have it for extubation. And it's very difficult to pick up an obstructed airway in a child that's flailing about, and you need somebody senior around to deal with issues when they crop up. Extubation failure occurs in around 6% of complex craniosynostosis in our series, and the issue is that if you need to reintubate them, and if it's a shared airway procedure, you can have a really difficult time. Even with the video scope, it can be really challenging. So just to show how challenging these children may be, we had a 14-month-old Apert child who had come for a craniofacial procedure with Lifort maxillary advancement. We extubated the child on table and shifted to ICU on oxygen, but the child very quickly went into respiratory failure, CO2 retention. The child needed to be reintubated, and this reintubation was really challenging. We needed the video scope. Without that, it was not possible. So the next day and the day after, we decided to give a trial of extubation while bridging with a nasal airway and CPAP. For some reason, it didn't work out, and both times we had to reintubate the child very soon after attempting extubation, and each time the intubation became harder and harder because of the airway edema. Decided to proceed for a tracheostomy for this child because the airway was just too challenging. The tracheostomy was also quite challenging. The surgical team had to be changed twice, and finally it was a HOD of plastic surgery who had to come in and do the tracheostomy because he diagnosed the child to have a rare anomaly called a tracheal cartilaginous sleep. So we were seeing it actually for the first time, but thankfully the tracheostomy went off well. We were able to put in a 4-size Bivona uncuffed tracheostomy tube, and we were able to shift the child back to the ICU, and everything seemed to be okay. Tracheal cartilaginous sleeve is actually a rare complication seen in children who have midface hypoplasia. We need to actually do a CT of the thorax, or at least the lower airway, the neck and the upper thorax, to actually diagnose this condition. So this child continued to have issues after the tracheostomy with repeated episodes of desaturation and CO2 retention. And the child was too unstable to be even shifted for a CT scan. So we were really stuck with this child. We thought of doing a custom tracheostomy tube, but without a CT, that was also not an option. Actually, on post-op day 6, actually the child had refractory respiratory failure with nothing we could intervene was actually helping, and we actually lost the child to cardiac arrest. So what you should basically understand is that anesthetizing these children can be extremely challenging, especially the syndromic children, and you need experienced anesthetists to help you out throughout the perioperative period. Even though complex craniosynostosis children likely have more perioperative and post-op incidents, intraoperative issues are common to all of these children. And each child is actually a learning process, and you can learn something from each of these children, and you can get a surprise at any time. Thank you.
Thank you, sir. Dr. Matthew has joined us online, so you can go ahead if there are any questions. So we'll move ahead with the next session on perioperative care and craniofacial. It's a panel discussion on perioperative care and craniofacial surgery. I invite Dr. Shibu Pillai, a neurosurgeon from Narayana Multispecialty Hospital, Bangalore, to moderate the session. I invite our esteemed panelists, Dr. Jerry Paul, anesthesiologist, Amrita Institute of Medical Sciences, Kochi; Dr. Subhash Kolo, neurosurgeon from NIMHANS, Bangalore; Dr. Sherry Peter, craniomaxillofacial surgeon from Aster Medicity, Kochi; Dr. Madhubari, a plastic and reconstructive surgeon from AIMS Rishikesh; and Dr. Suhas Uday Kumaran, a neurosurgeon from Amrita Institute of Medical Sciences, Kochi. And Dr. Matthew George, he'll be joining us online.
Morning, everybody. So that's been a pretty interesting few talks, and let's see how far we can take this half an hour. So can I have that initial thing? So we're talking about perioperative care, and I'll start off with how do we decide when we should operate. First question most parents come and ask me is, do we really need to operate immediately? Can we wait? Because especially among infants and small children, they're always very worried. Is it really needed that such a small baby should undergo surgery right away? So that's where their first concern is. So let's see what how many of y'all would tend to advocate early surgery in an infant, or do you prefer to wait till they are a little older? Early surgery, most with, so fewer with early surgery. Okay. What about Suhas? How would you go about the slides. What are the things which you take into consideration? For example, would you look at, say, ICP? Is that a factor, or do you think it's because it's a syndromic child that you would like to go for early surgery? We'll keep endoscopic aside because there's a separate session. But other than that, if you're thinking of open surgery, what are the things which you would take into consideration when you want to suggest earlier surgery rather than, say, wait few more months?
My two most important considerations will be the age of the patient and second, the presentation. Yeah, the second is the functional presentation the child makes to us. Meaning, age is, let's say you have the youngest ones. If you have a very young one without a functional issue, I would of course stagger to wait until I consider myself anesthetically safe. So that would be easily around 6 to 12 months, because we realize that physiologically they are different below 4 months. So 6 to 12 months is ideal in a completely issueless child. Let's call it. I'll put it issueless in words, meaning no functional distress. So 6 to 12 months would be ideal for me. If it's a syndromic child and has functional issues, especially let's say ICP or the airway, and the child is in distress, I think timing would be at the earliest. Meaning the smallest immediate priorities will be taken into concern, like the child has URTI will be taken into concern. But at the same time, if the child is in distress with functional things under impending danger, I would proceed at the earliest, whatever the age of the child be.
No, what is this danger? What are you talking about? What danger are you considering in terms of breathing?
Meaning, are you talking about children with functional issues?
Yeah, I mean, what exactly is it that you're going to tell the parent? This particular problem is there, hence I'm going to operate early.
Yeah, suppose if a child comes with, let's say, very grossly failure to thrive, a child not picking up weight, child getting URTI repeatedly, child not catching up URTI again and again, multiple hospital admissions, I would. That would be my airway concern. ICP is obvious. Many times it's obvious on the face, and that the child is very sick, in distress, full fontanelle, full hydrocephalus on scans, etc., etc. So if there are acute, functional issues, I think there would be no waiting. Only thing is I have to build up the pre-op preparation, and the intra-op and the post-op has to be well counseled, and the team well built up. So I think.
Okay. So essentially, what you're saying is that, particularly airway issues, if they are urgent, you would try to push for early surgery. So that's primarily. ICP, if it is grossly there, as in the head is really constricted, again, you will think of early surgery. But what if that ICP issue is not obvious, not so obvious? How many would consider doing ICP monitoring, especially if you have a doubt, it's a borderline kind of issue, to decide on surgery? Has anybody done ICP monitoring? There are many centers which do ICP monitoring, especially in syndromic. Do any of y'all ever take that as a practice? Suhas, what about you? Subhas?
Sir, you are asking about before the surgery?
Before surgery.
Before surgery,
What
actually.
exactly decides?
Yeah, there are so many surrogative markers. Like now in NIMANS, we are doing ONSD also to look for any other indirect evidence of raised ICP. Is that evidence then will subject for ICP monitor? Though in NIMANS, we do frequently intra-op ICP monitoring. Like before the surgery, starting of the surgery, we place the catheter, then we'll monitor, and we kept the catheter for 48 hours. Because one case we have found, like after the surgery, we did a height reduction, and day one suddenly ICP goes up. So we have to take up to OT and then release the plates and the screws. So, but pre-op, if there is a indirect like ONSD, if you're able to do in children, but it is the values are still not standardized. Like what will be the cutoff to say? Even for the ICP also in an infant, we don't have the proper cutoff. Like 15 is the cutoff, but for infant less than 6 months, because frontal lines are open, so that like the cutoff is not there.
So the biggest problem with ICP monitoring is that we don't have any standards, and whatever value we identify, it's really difficult to say. Even if we look at the waves and the patterns, say plateau waves and things like that, it's still difficult. Among single suture, as you see in that chart, the ICP values have varied widely. So it's very difficult to say that what likelihood of a particular child having raised ICP without actually monitoring. And even if you monitor, then what does that value mean? That becomes difficult to say. In syndromic, because the chance of ICP problems is higher, you can sort of bring that issue up much more commonly. But again, that percentage varies, and so we may have difficulty to decide. You were talking about ONSD. Anybody else uses these kind of non-invasive methods to take a decision? ICP monitoring. No, non-invasive pre-operative. ONSD. Okay.
Yeah, I wanted to ask one more thing. What are the
Yeah,
options
even
of?
Yeah, sorry.
What are the options? What are the methods you use for pre-operative ICP monitoring?
So if it is a syndromic that as told, and is there any radiological evidence like in syndromic child, the raised ICP, the probable cause will be either
No,
hydrocephalus.
I'm asking about the methods you use for pre-operative ICP
Methods
monitoring.
is like invasive methods.
Yeah.
Best is invasive method.
Any non-invasive method which you use?
Yeah, that is ONSD is one of the method.
Any other method?
Others is like you can do a TCD in a children. Like if you do a TCD, there are a few parameters there that will indicate that there is and you can do perfusion study also. So that is also will give a MRI perfusion study that ICP is raised, but that is not a dynamic. Like one time that will give a indirect evidence of raised ICP. But best is invasive.
Any experience with reverse visual evoked potential for ICP monitoring?
Visual evoked potential actually for anterior pathway we do during surgeries, but for ICP correlations I don't have any experience.
Can I just add, there is also a growing discussion regarding a base scan of the eye as well, which is more sensitive than papillary edema, just fundoscopy, but less sensitive than invasive monitoring.
OCT.
OCT is also, yeah. That is
so what we typically do is we'll do a B scan, we do OCT, and we get the opinion of the ophthalmologist about the fundus. Problem with fundus is in less than 8-year-olds, it's not a reliable indicator. So papillary edema, if present, definitely it indicates raised ICP, but just because it's not there doesn't mean there is no raised ICP. So that's something we have to always remember. So I think Dr. Matthew wanted to say something. He was online, he said something. You wanted to say
No,
something.
just that we also are, we also are using ONSD of late to better understand what is the ICP situation of these children. Obviously, it's very difficult to do an ONSD measurement preoperatively, so I don't think it will really contribute to decision making, but it will probably give us some information as in which children are likely to have ICP related issues, either introp due to, let's say, a tight ear or tight brain introp. And anecdotally, we found that a couple of children have had post-op issues due to hydrocephalus or raised ICP post-op if their ONSD has been above 5, which is actually the adult cutoff. In children, they generally say a cutoff of 4 millimeters is actually significant, but we've seen that above 5 actually predisposes these kids to issues post-operatively. I think Dr. Suhas might also want to add something to that. We had a couple of children recently that had issues.
Yeah.
You were. Okay, Suhas.
ONSD is an option, but the only thing is like reliability. So I think one point I would like to stress is considering that objective evaluation is fallacious, having a diagnosis like a cruisum, you assume there is raised ICP and proceed.
Yes.
You do not wait to understand what is happening. That's one. I mean, of course, like upwards, etc., can be separated. And then you have in non-syndromics, I would put a scapho in the high. I mean, a very gray margin. So that if you have a scapho who presents to you, you might think about early surgery in spite of no other signs, because they can have raised ICP otherwise too.
What about the, I mean, when we are doing a CT, MRI, and or an MR venography, if we find emissary veins or any other dural sinus stenosis, I think these are also indirect indicators of raised ICP, which can give us an idea of.
Venous hypertension is one of the reason of raised ICP.
Yes,
like
so
in this type of patients, the causes of raised ICP is either could be hydrocephalus, that will come to know in scan. So
yes.
you have to manage that either with CSF diversion procedure, or it can be because of venous hypertension because of a stenosis at the skull base.
Yes.
Like so, in that also you have to
Yeah, so
address.
what I'm saying is we can use that also as a predictor for.
Yeah, emissary veins, yeah, that is the anatomical veins will be
Vein.
there, but we can see that one also.
Yes.
But one of the important things that we all tend to miss is that we can't measure the brain cerebral compliance. And the status of the compliance is what determines how much ICP is going to be detrimental. So if you have poor compliance, small changes in ICP are going to get manifest rapidly and create problems. Whereas if we are still in early stage of good compliance, that may not matter so much. So that's why they found that clinical indicators like if you have that copper beaten kind of appearance or even venous engorgement may not truly reflect, when you actually measure ICP, it may not be truly reflected in the values of ICP. Now, whether it's the problem with the value we are taking, the cutoff value, or it's the compliance, we don't really know. But all these are factors which can play a part in our decision.
One more point and to add, like recently I was reading one paper, even the lymphatic drainage also is important for raised ICP. Like if there is a prominent Virchow-Robin space, so that is also indicator of a raised ICP.
I think let's move on from ICP issues. The other issue we tend to sometimes overlook is, or sometimes over address is, how much are the eyes going to get affected? The ophthalmological problems may be something which tend to push us into doing early surgery. Do you think that is an important factor that we should consider?
Yeah, I think
Does it matter?
Eyes should be taken into consideration, because if you have a socket which is small in disproportion to the volume of the orbital contents, you tend to have exposure keratitis, and that can be a terrible situation. So I think that should be taken as one of the priorities to take the child and manage it quickly.
Okay. What about things like strabismus or astigmatism? Are those factors we should consider? Does it matter, or any of the panelists? Do you take any of that?
Unless strabismus is due to raised ICP. But I think subluxation, acute subluxations can be very dangerous, and you can have visual blindness secondary to subluxations. That's another factor, secondary to shallow socket. Shallow orbit, yeah.
So yeah, I think those two would be the key issues. Maybe if there's exposure going to happen or there's subluxation.
Yeah.
But otherwise, what they have seen is, irrespective of whether you do early surgery or late surgery, the ophthalmological problems such as strabismus, amblyopia, astigmatism, nasolacrimal problems, all those things don't really change. You may have them even after you do the surgery. So it doesn't really change whether you do early or late surgery. The other issue is parents are worried. Small baby, if you subject it to early surgery, are you going to have more complications? Has that been your experience? What do you think?
That should not be a big problem, because we are doing a lot of operations on children, complicated surgeries on children. Now, the problem unique to these children are basically the airway related. Okay. And many of them have frequent infections, so we need to be very careful about how you select these patients. Make sure they optimize prior to being taken for a surgery. The reason being simply that in the post-op, you're going to have two problems. One is an uncorrected or unoptimized child with an infection. The second one is maybe an airway obstruction. Okay, so these are things which can compound your complications, whatever it is. So that's
most important to optimize the child before taking up.
That you should be very careful about. Other than that, of course, you know, all those other things that get added on to it. For example, Matthew spoke about the blood loss. That can be quite significant in these children. Quite a lot, because I've seen up to 2 to 3
blood volumes being transfused in children. I think it's less down with a lot of controls and everything, but those are things that we should consider. So that actually puts the child at higher risk than anybody else.
In fact, there's been a study where they have looked at the number of complications vis-a-vis the age at which the child was operated. And amongst almost 8,000 children, the number of complications were actually higher the older the child. And the other factor which influenced was syndromic. Syndromic kids are more likely to have complications compared to non-syndromic. And I think that's what you're pointing out to. So I think we'll skip this endoscopy question because it's going to be addressed in another talk and later. What about hemoglobin or weight of the child? Is that something that you take into consideration? Is that part of your optimization, or irrespective of the hemoglobin or weight, it's not that big a issue?
I think Matthew can answer that particularly because he manages these cases. But what I'm saying is that hemoglobin should be at least 11 to 12 before you take this patient. Right? That's mine.
Okay.
Matthew, do you have anything on that?
Matthew, any suggestion about the hemoglobin criteria?
Yeah, naturally, the higher the better. Would give us more leeway to actually manage the children intra. But physiologically, especially if you're trying to take these children at a younger age, around the age of 6 months, they will physiologically have a little bit of anemia. So we do take that in stride and try to manage. Thankfully, the younger they are, I think most of the surgeries are generally they go for endoscopic and procedures like that, which are bleed a little less. So transfusion requirement is not much. But yeah, definitely, I think 9, would be the cutoff for a younger child, for an infant below 9 to 10 months of age. Beyond that, of course, we prefer it above 10. As high above 10 would be better. But I don't think we have ever actually had to transfuse a child or send a child back due to a low hemoglobin. Thankfully, in our population, everybody has had reasonable numbers.
Okay, thank you.
Maybe role of acute induced hypovolemia.
Induced?
Induced non-volemic.
So, I mean, there have been attempts to look at drawing out the child's blood, and then so using the child's own blood. But what they found is there are actually more drawbacks to doing that, and so most people, I think, have given up that practice. So, especially in children, in older persons, there are still being, but in infants, I think it's now generally avoided. Anything about that?
I don't think you should try such stunts in child of this age.
Yeah.
Okay, adults you can definitely do it.
Yeah.
As long as they have a good hemoglobin, you can definitely try it. But in infants, definitely not.
Any role for erythropoietin in optimization?
Studies haven't shown much benefit that way. Okay. In adults, what they've shown is that the chance of thrombosis is high. In children, is not much. I mean, they have not found any difference by giving erythropoietin.
We talked quite a bit about airway already, but when you do the preoperative assessment, what is the kind of counseling you give to the parents regarding its impact on post-op?
Airway generally tends to improve when you do a fronto-orbital advancement or something. But the child has got obstruction, and that is not likely to improve in the post-op. Then what we have to actually tell them is the possibility of ventilation for few hours until the child is fully awake, and then how would they nurse the child in the post-op. Those are the time when we have a problem. And in the ICU, the setup is a little different. In the theater, we have more controlled conditions, you know what. And you go to the ICU, when you need an airway to be secured quickly, it can be a little bit of a problem. Okay, because we don't have equipments, we don't have hands, and we are less prepared than that in an OR setting. So these are things, I don't know, if we can talk to the parents and tell them that in the ICU, if something happens, we won't be able to take care of that. That should not happen from our side. So you have to have a very good team which can look after and take care of this. So that's about the airway part.
Moving from pre-op to intra-op, let's talk about how you clean the hair. Many people use betadine, iodophores, others use chlorhexidine. What's the general approach? Is there any fear of iodine-related allergic reactions and you avoid iodophores. And somebody was saying about betadine, right? So what is your general practice? How many use betadine and those kind of things? Any experience with allergic reactions in these children? So looks like in Indians, it doesn't seem to be that much of a problem. So Has, you have any thoughts about that?
Not with betadine.
Okay. We generally tend to use chlorhexidine for all, particularly babies, and the more dilute ones on the face, and so less than 0.5%, those kind of things are used around the eyes. But our practice has been to use chlorhexidine over iodophores.
We ask for hand wash right before my parents
Yes.
and the morning surgery, and then
Yeah.
of course chlorhexidine in the morning.
Yeah.
We do it ourselves.
Yeah.
And
Yeah. So all our preoperative patients, we send them with chlorhexidine scrub. So at home, before they come, they start about 2 days before. So they use that. I don't know how much it has changed, but generally our infection rate has not been much. Regarding steps to reduce blood loss, what are the things that you would follow during surgery? So
I think your preparation is already done.
Yeah.
So introp, I think I'll be careful from the step 1 onwards, which includes, which most of us agree that we infiltrate well with adrenaline-based solution, including additionally tumescent is added, and then using a fine Colorado needle to cut the skin, etc. Rennie's clips, etc. This is standard. And I think even that step, when the youngest come to the operating room, I'm there, or I'm doing it.
Actually,
So,
Rainy clips I have stopped using because one is that, of course, why compress the skin? But if the bleeding stops before that, then I know it will not. It's not just the Rainy. If the Rainy becomes loose, nothing is going to bleed later. So I make sure the scalp is completely bloodless before I proceed with my next step. So each step, it's a good practice to make sure you're absolutely happy with it before going to the next.
yeah, only thing is, see, once your adrenal effect wears off, the Rennie might additionally
accept it.
Yeah. So, and each step, I mean, you anticipate venous sinuses from the scans.
How many of you would raise the pericranium? Because that's one step where you are going to have more bleeding than if you're in the loose areolar plane. Either way, you go in the, if you take off the pericranium from the bone, there is more bleeding from the bone as opposed to if you're in the loose areolar plane. So what about you, Subhash?
We don't we keep on the bones.
How many of you keep it? Keep it on the bone? No, then you raise it ultimately.
Yeah.
So that's the thing. There are people who prefer to not raise it at all and just cut it. There are others who raise it, but when you raise it, you're going to inevitably cause more blood loss. So you've got to be careful as you raise it, coagulate, bone wax, all that, keep doing it. And that is one place where if you're borderline with your blood loss, maybe just leave the pericranium there. So what is the advantage? I don't know if raising the pericranium and then covering it later on the bone actually makes a difference in the long term.
That's the pericranium can be used as a graft also if incidental DVT happens sometimes. So pericranium can be a very good adjunct for that. You can use it.
But then you don't need to raise it completely as a flap.
Yeah, that's true.
So because when you raise it as a flap, throughout the entire process of raising it, you're losing blood. So that.
Can I clarify? You're saying that you'd raise the pericranium along with the scalp, not separately, right?
So whether you raise it separate, the question is, do you raise it at all or leave it on the bone while you cut it?
So then what happens when you remodel? You remodel the bone with the pericranium on it, is it?
You can do that too. So the whole issue is that whether once you put back the pericranium, is it going to do anything?
5 more minutes, sir.
So anyway, I think we'll move on, or okay, last.
When you want to remodel the bone per se in certain positions, I think it is nice to have the pericranium taken off, do your work, because most of the work is done ex vivo basically, and then you reposition the bando and other things. Very few situations, especially Areas like fontanelles where you want to keep it intact is fine, but other areas where actual bone is there, we tend to go subpericranially. I agree, it bleeds much more. I do agree.
Pericranium separate so that you can, otherwise it will sink down, no? You will get the hollowing, because even if you're taking the pericranium, keeping the pericranium on bone and then detaching everything, then the temporalis part will not have an attachment. So I guess pericranium comes off in most instances.
I mean, I raise the pericranium, but in Vancouver, it's never raised the pericranium. It makes no difference. So because my max facial team, they prefer raising the pericranium, and so we raise it, but it's not necessary. So keep it open. If you want to avoid blood loss, if you're on the borderline, there's no compulsion. You'll be fine. So tranexamic acid, does everybody use it now, or is there anybody who doesn't? You don't use. So most people are using it.
What about PXA in a prone patient? Because of central retinal artery occlusion reports in prone patients, would you go ahead and do a TXA in a prone patient? Yes, sir.
What about TXA in a prone patient? In supine, we always use it, but in a prone patient, because there is a risk of CRAO.
Most of the thrombotic complication with tranexamic acid has been shown in adults, but in children it has not been shown. But if you have any case reports where it has been documented, then it's probably something that we should look seriously at.
There are a couple of reports.
Yeah,
Matthew,
but
any?
the concept of CRAO is a very obscure one. There are multiple reasons for CRAO, including the position by itself and hypotension, many things. So I think pointing out to tranexamic, which is supposed to be very useful in blood loss and in general, might be a bit, you have to be skeptical about that issue. CRO is a very rare complication. Even the anesthetist together as a forum collected very few numbers to come up with some guideline. But one answer is difficult.
There are also reports of using tranexamic acid as soaks for causing hemostasis. So if that is a concern of the amount of tranexamic acid used, then I think local soaks can also be used.
There are.
Yes, yes. Local soaks is also soaks.
Okay. So in syndromic kids, we have a situation where the entire circulation, venous circulation, is exiting through the scalp veins. So in those situations, what do you do about the scalp veins? Do you cut them? If you have to go through that particular, you may have difficulty cutting the bone without taking the veins. So how often would you take that chance? Or do you desperately try to retain those kind of veins? The emissary veins coming into the scalp, they may be the primary exiting vein. Then what do you do? So
I would avoid. I think I create a plan around it, not especially the prominent ones like PC. I mean, we are doing a PCVD for the toddler ones. Parietal ones sometimes
so you'll retain that.
I would retain, and instead, I would make all other cuts so that venous bleed becomes lower, and even if it bleeds, you're already in control of the ICP.
Okay.
So one more option is like you can do a neuronavigation and point it out during the surgery, like where is your sinus position and the emissary vein. So you can avoid those injuries.
In fact, there have been situations where I've left islands of bone around the veins and then tried to work around it. So that helps.
So in the posterior cranial vault distraction or this one, there are, I think, multiple techniques that have been also introduced, like clamshell and complete osteotomy. So if we find the emissary veins below the torcular, near the torcular, then we can use only a clamshell, and rather than going through that.
So all of you all agree that we
change the planning, surgical planning.
To preserve the veins. Okay. What about venous air embolism? How often has that been a problem, Sherry? Have you encountered that?
No, I've not encountered any.
They presented one interesting case, but even I have not come across that. I mean, it may happen, I guess.
If you keep a esophageal Doppler, you will see venous air embolism in up to about 80% of the cases.
Yeah, I saw that number.
That is how it is, but they are not symptomatic.
Right.
Most of the time, we see it only when the patient arrests. And someone who's very alert, like Matthew said, if you look at the ETCO, if you see it coming down, same time the blood pressure dropping, that's an indication that this is happening.
So you would advocate monitoring for all patients?
That is not really necessary because it can scare you a lot.
Okay. Okay.
You might want to over-treat those patients. But what I'm saying is that just monitor them, look at the entire carbon dioxide, look at the hemodynamics.
Right.
That's it.
Be aware of the problem. It's more common than we think. Okay. Dural tears are something we're always afraid of. It's going to end up with bigger problems than we anticipated. So is there any extra precaution that you take, or is it, if it happens, then what is the strategy you use?
I think in non-syndromic ones, even if it happens and if you leave it to it, might not be like the biggest problem. But in syndromic ones, you should anticipate that it's going to happen and maybe be prepared for it. And it can subvert your surgical plan, isn't it? You have a PCVD, you have a leaking CSF, or you might have a child who has a pseudomeningeal which never heals, or you might have a bone which is floating always. So dural tear is a real problem in syndromic ones, which can lead to further problems. I think difficult to stop it.
What would you do, Subhash, if you have a dural tear? Small.
Like if there is a major dural tear, we have to repair, primarily repair, there is no doubt. Minor dural tear, actually nothing will happen, sir. Like recently we analyzed our data also, 103 patients in Imans operated, where in 22 cases it was like unnoticed dural tear, nothing happened. In 5 cases, we have to primarily repair the dura. Only one case there was a CSF leak in the post-op, so we have to take up and do. The other problem with, like we had one patient with a syndromic, the Cruzen, and where we monitor the ICP monitoring, put the catheter, and that dural defect we didn't repair, we put a glue. Later that patient developed CSF leak. So now we have changed our policy, we are closing that part of the dural.
Yeah, sure.
We have kind of learned from our mistakes where we left some of the dural tears just like that to heal. And we had one case out of our series who had a growing fracture of the skull later on. So after that, every small dural tear, neurosurgery wants to do that.
Not be growing skull fracture. Because growing skull fracture, if you see the risk factor, one of the reason will be the raised ICP. If the raised ICP is persistent in that child, like in the post-op period, there is a high chance of growing skull fracture. Then if it is a syndromic and you are handling the sphenoid wing, like where that sphenoid wing is small, like in a syndromic child. So there will be inadvertent dural tear, and that we notice, and then can be growing skull fracture. So raised ICP you have to rule out. That is one important point.
Even without raised ICP.
Yeah, it can happen. I'm not telling.
Because we have done so many
Yeah.
osteotomies on the bone, so.
Yeah.
It can happen. Even
My approach, my approach is,
primary closure is the best way.
Suture it, put a seal, put some pericranium, do everything, the works. Jiten?
So what are the common sites for dural tears which one should be aware of? What are the common sites in syndromic and non-syndromic?
Telling that lateral sphenoid wing. Like
Near the terminal region during advancements, these are the difficult dissection sites. And one more thing, sir.
Child, now it will be short and anteriorly placed. So when you do the regular cut, you may cut the dura there. So there is one place you have to be very, very careful. See inside, outside, separate the dura properly. When you are making the cut, always separate the dura beyond the cut. Otherwise, your craniotom may hold the dura and dura will get cut there.
So that was the site maximally noted in your series there.
That's one of the literature also reported, that is one of the site. Other areas like you can modify depending on like if the copper beaten appearance is more, or there is a more adherence of the dura when you are separating, so you have to be very more careful.
And what do we understand by unnoticed dural tears? So how they were captured in your
Unnoticed is
series?
like in literature, one is for endoscopic suturectomy, that is one common unnoticed.
During surgery, but post-operatively they
We will
have
not notice. Even small minor cuts also will be there, we don't notice because CSF is not leaking maybe. So, and then later we'll see that there is a CSF leak and other problem. Those are they defined as a unnoticed. There is a clear cut dural tear, best is to close the dura.
Yeah.
I think you should take care in case of a trigone also, because your dura might be inside
inside the bone. That's better metopic. So you should be able. So I think the key is to know where you can run into trouble. So the in preoperative, I think you should look through the venous sinus and things like that, so that you know exactly where you can get into trouble, so that you go slow on that, or maybe do a different technique, maybe to put 2 holes and go drill into the bone slowly and come back nearer to the dura and then something like that.
Separate the dura.
Separate the dura well. Yeah, so, but you can't be doing the whole thing on the whole place. So in those points you identify, localize, and then do it. So I think you get out of trouble.
Okay. Okay. Thank you for a very interesting session. We have run out of time, so we'll continue this later. Thank you to all panelists.
Thank you, sir, and all the panelists for this insightful session. Now let's take a brief tea break. Kindly reassemble within 15 minutes so that we can resume the sessions by 11:30.
Please come back in 15 minutes. We have people from UK who are going to wake up early and join us, and so get back in 15 minutes, please.
I have notes. I want to see the notes.
If you go in presentation mode, I can
So we commence the next session on single suture craniosynostosis, open versus helmet. I invite Dr. Vaibhav Doraj, plastic reconstructive surgeon from Apollo Spectra Hospital, Bangalore, to moderate the session. I also invite our esteemed panelists, Dr. Krishna Sharma Rao, craniomaxillofacial surgeon from Bangalore, Dr. Dipesh Rao, Dr. Suhas Udayakumaran, and Dr. Jagjeevan Jagdishan, plastic reconstructive surgeon from UK, who will be joining us online.
Yeah. Good morning, everyone. First of all, I would like to invite all our panelists, Dr. Krishna Sharma Rao, Dr. Dipesh Rao, Dr. Suhas, and Dr. Jagjeevan Jagadishan, who is joining us from the Birmingham unit in UK. So he is with us virtually. So I welcome you as well, Jag, as you're called in the UK. All right, to start off, let me go to the first slide, please. I would like to first ask for a show of hands of how many people actually do open procedures only and how many people do open procedures and the endoscopic procedure. If I can have a show of hands in the hall, please. Open only? Open only? Okay. Dr. Jag, I can't see you at the moment. Do you do open and helmet as well?
We do open and helmet.
Yes, all right. Okay, so that's just so that I can direct my questions appropriately. So first of all, I would like to ask all our panelists to give their 1 minute of a overview regarding their philosophy of treatment of specifically single suture craniosynostosis. So if I can ask them what are their priorities, what is their outlook of surgical intervention, and what's their concept of providing healthcare delivery for such babies, because it's quite a diverse kind of a country with government, semi-funded charitable organizations and private organizations. So if I may start with the senior most, Dr. Krishna Sharma Rao, please.
Regarding single suture synostosis, though much can be said that it's sometimes only cosmetic, it is not, believe me. And I genuinely believe in my experience that patients do benefit from surgery, and that too early surgery. I know that you are doing endoscopic work as well, and it's a good thing, but it's not, according to me, indicated for all kind of stenosis. And open surgery has some risk in terms of the surgery, but has a lot of benefit in terms of the outcome. I feel you can give a significantly better outcome with open surgery, and at this moment, this is where I stand. Of course, I might change my mind after this discussion.
All right, thank you, sir. If I may ask, we'll
In
come
terms
to the
of redo surgeries and long-term outcomes.
All right. We'll have a free-flowing kind of a session later on in the session. We'll just have this first 1 minute of a brief kind of introduction from everyone. If I may ask Dr. Jag from UK, if you can just elaborate about this slide.
Yeah, the priorities we have in single suture synostosis is twofold. One is, of course, you have to make sure that the head shape is better. And the other most important thing is the risk of raised pressure. And although it's less, there is always a risk of subclinical raised pressure, which we don't know about. And the figures quoted in literature varies from sort of, say, 2% to around 40% in sagittals. So unless we do invasive monitoring in all of them, we can't quantify that. These are the two main reasons why we offer them. We have seen some adult unoperated single sutures who present, and it's very difficult to correct them. And this certainly has a psychological impact on them as they grow along, especially when they go to secondary school and all those things. They have an impact. And so our priority is we offer surgery for all of them. With regards to open or endoscopic, we are very early in terms of our experience in endoscopic procedures, because we've just had our first year of helmet therapy in endoscopic procedures. And the results are, we were dubious about it when it started, because we started because majority of the units were not doing it. And then it's a push from the government saying, okay, why are we not considering a less invasive procedure? And we started doing it, and the result is very encouraging at the moment. We can't comment about our long-term results yet, but it's very, very good at the moment.
Thank you. Dr. Deepesh, the youngest in the panel.
Yeah, looks can be deceiving. So anyway, I think the most important thing is to make sure that we minimize the number of surgeries that we are doing. That is one of my priorities. If we are trying to look at, of course, all the above that has been said, and one of the things with single suture synostosis is trying to minimize potential redo surgeries. And that is one of the reasons why I'm more of an open surgery approach guy, because the understanding is if you do the open surgery, you can correct it or overcorrect it. Whereas with conservative approach or endoscopic strip craniectomy approach, you don't have that ability. You are allowing the brain to correct the rest of it. Anyway, so that's in a nutshell, minimizing the surgeries for a single suture and all the above that has been said thus far.
Thank you. Dr. Suhas, your view from the Amrita point of view.
I offer both the situations to the families, endoscopic versus, because that's nearly the standard of care. But very clearly, literature does not talk about superiority of either of the concepts in terms of primary surgery or even the long term, at least until now. I mean, the long term issues might be picked up later. But so hence I offer both, but at the same time, I gently tilt towards open, but because the functional aspect is a key aspect in my thinking. And as Sir pointed out, I would still believe that a functional surgery is the open one, probably because we address all the areas immediately. Gentle opinion, which I'm sure will never be proved in long term.
Thank you very much. Coming to my next flow of thought, if I can have the slide on the screen, please. What's your current protocol, sir? You said that you prefer early surgery. So how early? What's the timing that you do? And what's the typical patient journey, immediate pre-op, immediate op, and immediate post-op of your patients and your technique in general? You can take probably 1.5 to 2 minutes for this, sir.
Typically would be if one in India when the patient turns up. However, ideally 6 months would be a good time to do that. The bone is still very malleable and easy to contour, and that makes the procedure, apart from the surgical risks, procedure much more easy to do. In terms of the protocol, for all of them, I have been doing only open technique and fronto-orbital advancements and complete tender vault remodeling. We have followed up for over, now some of my patients are 15, 20 years old, and redo surgery is very less common as compared to what I have read in literature about endoscopic surgery, where redo is a little higher. Now, I don't know what it is today, but this is what I have known. So the technique is standard. I don't think there's anything significant in the technique. Everybody does something similar, more or less.
So you mentioned 6 months is your usual time of doing the open
that
procedure.
would be
If you
the
get
idea.
the patient
Yeah.
as per your thing.
Yeah.
Dipesh,
would you concur with the
Mine
same
is
thoughts?
slightly
or-
older, so my patients are around 10 to 15 months of age. That is my usual time of operating. I like it a little more solid. If they're slightly more malleable, it becomes a little difficult to put the construct in place. So you need the bones to be slightly stiffer. And because my predominant route of fixation is wires, I don't want to cheese wire through the soft bone. So wires reduce the cost, allows me to utilize that benefit in our population, and it has stood the test of time for the last 30 years in various units where wires are still being used despite the advances. So that is one of the reasons why I wait till 10 to 15 months of age. The patient journey is, I see them after 15 days of after discharge, and then 3 months later, and then follow them up once in every year, the first 3-4 years. And after that, they come whenever they come. But usually it is the first 3-4 years are the more intense period. Technique, I think everything is standard, just focusing more on the forehead. That is something that I will never compromise. I'll probably spend more time staring at the forehead, getting that bit right, especially because you're doing that open, and that's the most visible part of your repair. And yeah, I've touched upon everything else.
All right. Dr. Jag, what's your protocol for how do you do about endoscopic versus open? Because I'm sure you do both depending upon the presentation. So what is your protocol? Like what is the cutoff point when you say no for endoscopic?
So as I said before, we are very early in the journey of endoscope at the moment. So cautiously, our cutoff is 4 months at the moment. And we've done sagittals, around 10 sagittals at the moment. And metopics, we haven't done them yet. We are doing our first one next week. And it depends on the timing of presentation, because although some awareness is there, we still get patients later on in life. In terms of the timing for surgery, if for open procedures, for sagittals, we prefer to be 6 months or less. And because of our, after COVID, our waiting times have gone higher. So we are operating around a year old at the moment. For metopic and unicoronals, we prefer to operate around 15 months of age, 15 months and now around 2 years of age. Part of it is the waiting time, and part of it is the bone being slightly thicker, the forehead construct. We use resorbable plates and screws. And if the bone is reasonably strong, then we feel that the construct is better. And because of the delay in the sagittals, we found that we have to do a bit more extensive procedure. We start prone, we take the panels and the occipital bullet off, remodel all of them, and then we turn them supine and take the forehead off and remodel them. And if their skull base is already fixed long, then we prefer to go much lower down, below the squamotemporal sutures for the panels, to make sure that everything is released. And we found that at least in older children, we get a reasonably good result. In terms of patient journey, they stay in hospital for around 4 to 5 days. And 3 weeks after, a nurse practitioner sees them. And we see them at 3 months, and then 18 months, 3 years, 5 years, 7 years, and 10 years of age. During this time, the sagittals get ophthalmology review for a papilledema, and unicoronals get ophthalmology review for squint. And they get speech and language assessment and a psychology assessment at different stages. Look for their developmental. Till at 10, we discharge all single suture synostosis.
All right, thank you. Dr. Suhas, any difference? Because he says his cutoff is 4 months for endoscopic. Because we know that the coronal ring, for example, in unicoronal, after 4 months is when it's not only the coronal suture that is fused, but also the frontosphenoidal sutures get fused. So is that a probable reason why 4 months is the cutoff, and what is your cutoff?
Yeah, for endoscopic, I would keep 3 to 4 months as my cutoff. But sometimes there are exceptions when you have a premature who is extending beyond that. So you can have exceptions, but 3 to 4 months is a good cutoff for me because it's endoscopic. And for open, it's 4 to 6 months. I set the ball rolling for open procedures. But at the same time, again, literature does not support the exact timing of surgery as a portender for better outcome. I mean, I'm not talking about more than 2 years or more than 5 years, but at least 0 to 2 is considered decent enough to get a good functional outcome in spite of whatever is available as literature.
No, thank you. At this point, does the audience has any questions or inputs? It would be very welcome. Just regarding just how the cutoff is and the timing of the surgery. If anyone has any questions, please, you can raise your hands and start off asking our panel.
What is the reason for not doing out 4 months? Suppose you get it 6 months, will you be doing or not?
Yeah, but as he mentioned, there are secondary changes, additional ossifications happening. So even this might not do the release. And second is you have the fastest time for the brain growth. If you look at the normograms for the cephalograms for the children, the fastest is in the first 6 months. You have an extreme steep and then it plateaus down. So essentially the endoscopic believes in that philosophy that the brain adds to the inward outward pressure, isn't it? And the addition of the helmet, of course. So if you want to rely on endoscopy, logically, 4 to 6 months it should be the cutoff.
As I told, I would like to add something on this, that after 4 months, we still do it until 6 months. But because the frontosphenoidal sutures are also fused, we do an extended suturectomy, and we also take out the frontosphenoidal sutures, at least the lateral aspect of that. That's the only tiny modification in cutoff times, where we are still able to offer that for 6 months. In the literature, some people have done until 8 months, 9 months too, in mild deformities, where the compensation has not been that much. So that's was.
And is it endoscopic assisted or it is endoscopic?
That's a very principled question, whether it is endoscopic at all, because we don't use endoscope at all. We call it minimally invasive suture craniectomy. What about you, sir?
I think essentially it's endoscopy assisted. I mean, it for us, it helps us when you want to see the emissaries going across in the cytosine. So there are some situations where you need it for additional benefit. So endoscopy assisted, because then the rest scissors come into place.
If you use the endoscope, I think it becomes endoscope assisted.
Yeah.
So,
Yes, absolutely. And they mentioned about stainless steel wires and resorbable plates like that in endoscopic. What do you use? What instruments do you use for the suturectomy? Because we have tried scissors, but it never works.
No, I use scissors only.
Scissors.
Yeah, so that's why my choice of age is very important for me.
All right. Okay.
Scissors works very well for me. Good straight fine cuts.
All right.
Excuse, just to answer to the last, that in metopic things, like it is endoscope assisted, but in metopic, if you have an endoscopic view, so drilling of the base or removing it will be easy.
Easier. Yes.
In a superior, it is fine. You can tell endoscope assisted or minimally invasive, but there the view, the light will go there and you can have a better view. So in metopic, it is endoscopic assisted definitely.
I think
yes, sir.
The two main points at which the endoscope is useful is, one, making sure you've reached the lowest part, both for coronal as well as in the metopic. And the second thing, it's very useful for coagulating the bone edge to see and coagulate so that hemostasis is perfect. So you don't have the little bleeding constantly happening. So those are the two areas where it helps. But the endoscope is there to view it. The actual coagulation is beside it. You don't have an instrument which can do it through the scope. So strictly speaking, I guess you can call it endoscopic assisted only. All craniosynostosis surgery is like that.
Yeah.
The other thing is with respect to time, I think what I do is for the coronals and metopics, I want them less than 3 months. For the sagittals, I do it up to 6 months. So that's how I do. But the unfortunate thing is, even when the parents identify a problem and they go to a doctor, the doctors will say, it's okay, don't worry, it will get better after some time. So they never reach us in time. So that's the biggest problem. So I think we have to try to educate, particularly among pediatricians. And that's something as a group we have to probably spread the word.
Yeah, my question to Dr. Deepesh.
What is this?
Yeah, so you mentioned you wait for 10 to 14 months for the any remodeling procedure. Suppose if there is a raised intracranial pressure and also there is a pressure on the optic nerve.
The question was about the single suture non-syndromic
Single
cases.
suture,
So we were restricting to that. Of course, we will, if there is any signs of distress, functional issues will get addressed on priority. There is no waiting time for those cases. I think the waiting time here was particularly being discussed for cases where you have that ability to wait. So yes. So
Okay, let's move on to the outcomes, which Dr. Krishna Rao told about. What have been your outcome measurement tools, sir, and how do you measure those outcomes functionally as well as aesthetics wise when it comes to your long-term outcomes? And have you seen any major kind of complications that you would want to share in this audience, which has taught you many things in the past?
Major complications is what I should share, I think. Outcomes you can measure through clinical assessment, psychological assessments, and self-analysis, etc. See, these are just tools for showing that the patient has grown well, doing well scholastically, and is integrated back to society, which is the primary aim of any treatment plan. Issues which are difficult to treat, like I think Suhas also mentioned, pseudoencephalocele do happen once in a while, especially these are, I won't talk about single suture synostosis, especially in syndromic children, and they are quite difficult to treat. We've had to put 2-3 shunts eventually to get them, to settle down. So you do get complications which are not so easy to treat. You get bone loss if you are over enthusiastic in cutting the bone, and eventually you find islands of bone and most of the skull starts getting resolved, vanishing bone. So I've seen that as well. So I think open approach, minimalistic technique, but rigid fixation. I would differ with Deepesh on this because it was good for orthognathic surgery when for a Lefort 1 and BHSO transosseous wires were used. It would help to settle the occlusion. But I think with the advent of good fixation devices, whether it's resorbable plates or if the patient can't afford titanium plates, I would prefer that to wires. We do use PDS in areas where nothing rigid is required. I think Deepesh should comment on this.
Yeah, so the fixation is pretty rigid, sir, to the skull base. We use around 4 wires on the sides and 3 on the front. I guess resorbable plates in their own right are not rigid. When you look at the way they are quite flimsy when you put it. And after they solidify also, or after they get their shape, again, they are not very strong like the titanium plates. Do you agree, sir, on that aspect of resorbable plates?
They are good for the first 6 months.
Yes, sir.
After that, they get weak.
So the wires do a pretty good job. I guess I'm not saying it's just from my small size experience. The place where I trained in Oxford, they use wires for the last 30 years, and they have not changed their practice in the 30 years of experience, or 35 years now.
Just on a lighter side, University of Zurich for cleft palate has been using Prolene sutures for closing the cleft palate since about 55, 60 years. They switched to resorbable sutures, had to couple of fistulas, and they went back to Prolene. So even today they're using Prolene sutures. So I think if you are used to a particular technique, it works well for you, it's good. But you can't generalize it for the rest of the world.
Yeah. All right, Dr. Jag, with regards to endoscopic technique, in the past 1.5 years that you have mentioned, have you encountered any complications, challenges, and what's your protocol for the helmet therapy? Is your orthotist in your hospital? How many visits does it take for the parents to travel all the way from their home and see their orthotists? And what's the protocol for your helmet therapy as well?
In terms of endoscopic, thankfully, we've not had any major complications. And as you mentioned about use of endoscopes and not, we simplified it very much in terms of the endoscope is only used probably around 3 minutes of the whole duration of the procedure. And we use a lighted retractor, which is a disposable lighted retractor, which is used for rhinoplasties and breast augmentations. And that works really well because you can see the whole view of the entire field. Even for coagulation of the bone ends, we use them. In terms of the helmets, we have a commercial company we contracted with, and they have clinics in different parts of the country. We have patients referred from, say, north of England, from Sunderland down to Wales. So they have clinics in different places. So they do a photographic scan and plan the helmets. And they go through 2 or 3 helmets during that time. And the first helmet is sort of worn up to around 9 months of age. And then they changed to the second one up to 12 months. And if the head shape is normal, they don't go for the third one. And the parents go to the clinics initially every 3 weeks or so to monitor and make sure everything is okay. And after that, it's changed to 3 monthly. They see us every 3 months till around 9 months of age. And after that, we prolong it, change it to 6 months.
How closely do you get involved with the orthotist to monitor the progress?
So they update us with photographs regularly. And then if there's any issues, they contact us straight away. And these orthotists have been treating, commercially, sort of these things for Great Ormond Streets, and they've been doing helmets for quite a while. So that's why we've used them, because they've been doing it for a little while and they have the experience of managing it.
Any specific outcome measures that you follow or you have been asked to follow?
So the outcome measures is mainly, of course, the aesthetic in terms of how the head shape looks like, and the cranial index we use. And we sort of compared our cranial index between the open and endoscopic. Of course, the endoscopic we only have 10. The early results of the endoscopic, the cranial index on average is around 85%. Whereas with open procedures, them being a little bit delayed, we found that it's around 75 to 78. So the endoscopic seems to be good at the moment. But of course, we'll have to wait and see the long-term results.
Yeah.
Can I
Dr. Suhas, he spoke about sagittals.
Yeah.
What are the outcome measures that you use for metopic and unicoronal? Do you have any specific things when you use for the helmets?
Actually, our experience with endoscopic is very less because of population.
Okay.
But in general, I would say that the post-op is a bit uncomfortable for me when I do endoscopic for scaffold.
Yeah.
Because sometimes I prefer being open there because the procedure is same, but I have a better control on the hemostasis and my post-op piece is much.
Can I ask a question?
Yes.
Can I ask a question to all the neurosurgeons in the room? What has changed from the previous strip craniectomy that was always done for single suture, like say for instance a sagittal craniosynostosis before the calvarial remodeling, and now when you say the minimally invasive, has that the width that you strip off changed in terms of the strip craniectomy? Because strip craniectomy was done for many years and then discarded.
Not for scaffold. Scaffold can still be used.
Dipesh, can I answer that as a moderator?
Yes, sure.
All right. The strip craniectomy is the same, and everybody who does endoscopic strip craniectomy will tell you that the thing that has changed is the helmet therapy. So the helmet therapy by an orthotist is the most crucial part of the management. And sometimes we as surgeons kind of hesitate when we lose control of the total management of the patient. And that's where probably the hesitancy is to adopt this, where more control of the final management of the baby is probably with the orthotist and the parents. Parents with terms of compliance and expertise in terms of orthotist, where we have just facilitated it by doing an endoscopic suture craniectomy, if I have to answer you.
Can I comment on it?
Yes, yes.
I mean, I always felt that endoscopy has a gentle drawback compared to the other way. Open has a drawback over the endoscopic, because open, once you do, the child still has a positional preference, and then it does not give you an outcome which you want. Whereas endoscopic with the helmet together gives you a complete cover of the outcome. Which I mean, in spite of doing a well-conducted surgery, strip craniectomy with barrel staves, etc., in open surgery, I've always felt my outcome is gently lesser than my endoscopy with helmet.
Can I ask a question to
Dr. Jag?
Yeah.
Please.
If the pressure was not there from the NHS to offer strip craniectomy and helmet, would your unit go ahead and do that? Because the NHS is now saying that this is the literature evidence that this is something that you should offer. That's one of the reasons why the units in the UK are now migrating towards it. But if it was not there, collectively as a group, were you all keen on making that shift?
Interestingly, it's not based on the evidence they asked us to do it. It's because previous health minister's friend's son had craniosynostosis. And they did research and said, oh, why are we not doing this? And that's how it started. So we were always a bit concerned and dubious about the long-term outcomes of endoscopic. And that's why it's not been done. And as I said, the first unit who's been doing it for a little while is Great Ormond Street. And Liverpool started doing them after. And because 2 units have started, we should consider it. And we started doing it last year. And the early results are very good at the moment. And one of the other pressures we have is the number of patients we have waiting. So if they present early endoscopic, we can do at least 2 patients a day. And we are hopefully thinking of moving to 3 a day, which means that the number of patients you can get through is more. And with the results being encouraging, that's why we cautiously started at 4 months of age and then see the outcome. And then we offer, we've not started on metopics yet. And now we've seen the results of sagittal, then we're moving to metopic later. Although we've seen the results of the other units, we want to make sure we see our results before we offer to other suture synostosis. We've not done any unicoronals yet. And that's the next step we'll be moving towards.
That answer is quite telling, actually. In addition to the scientific literature that's present, if you ask any parent, I don't even have to put an effort what they will choose. They will definitely choose the endoscopic suture, because in the endoscopic suture craniectomy with helmet therapy, they have a lot of control over their child's treatment.
It also means regular follow-ups and a lot more, right?
A lot more close association between the parents, orthotist, and the surgeon. Any
If
questions?
I can mention one thing, sorry.
What is the period of helmeting for the different sutures, and when do you expect your results in different sutures?
All right. Dr. Jag, do you have anything from 1.5 years?
So we tell the parents that it's between 12 to 18 months of helmet. And we monitor based on the head shape at 12 months, whether they go to the third set of helmets or not. And once the head shape is better by 12 months of age, the chance of it changing is less. So we say at that stage, they can stop and not go to the third helmet. If it's still sort of in the borderline, then we'll say carry on with the third helmet. And in terms of the counseling for the parents, I mean, one of the things we have to make sure is the compliance of the helmet, because we do extensively tell them that if they think that it's not going to be suitable for them, going to clinics every 3 weeks and make sure that they visit the clinics regularly, then we say don't go for the endoscopic procedure because, as you mentioned, the strip craniectomy is only a minor part of the treatment. The main outcome is reliant on the compliance for the helmets. And if the compliance is not there, the outcome may not be as good.
And with regards to our average, it's been 12 months, average across all 3 sutures. I don't have data regarding specific sutures, but 12 months.
Literature says that coronal sutures, you do endoscopic, you expect results longer than what?
Longer because of the asymmetry and things, and even the brow position might still not improve. It's only the forehead for aesthetics which will improve.
I mean,
And
does it still improve when stop mobility?
it still improves. When we see the same patient after 3 to 4 years, things have improved even more. And that's what we tell. And when it comes to the long-term outcomes, there's already been studies which has mentioned with 20-year follow-ups of endoscopic versus open, where asymmetry, the mandibular asymmetry, the nose asymmetry, the brow asymmetry, and strabismus is significantly less in endoscopic suture craniectomy versus open, because in endoscopic you have not meddled with any of the growth sutures per se down, and we are just focusing on the brain driving the growth. Any comments on that?
Not comment, 2 questions for panelists. One is for sagittal, is helmet essential? And second is for metopic, can we manage only with helmet?
Yes, can I have the last slide, please, that actually addresses this? So the last thing that we want to discuss is open endoscopic strip and springs as well for single suture craniosynostosis. What Dr. Shibu is asking, is helmet necessary? Is springs also an option? Because many centers do springs for sagittals and also just suture crane. Which among these 3 do you think is the most physiological operation, Dr. Suhas?
If done at an appropriate age, open, I have a gentle tilt towards.
All right.
Because I still do not favor the helmet acting on the brain.
All right.
Can I say something? It's always how you put it to the parents. You said you can very easily convince a patient for helmet. When you say that, you can avoid a surgery, always parents want to avoid cost. But then there's the other side where I'm sure people who all do it, when we present, we will say that, we're not very sure how the entire outcome is going to be. And we'll say that it will take a long time. It will take a long time, that, it will take 12 months. You have to have multiple changes. Your burden of care is going to be too much. Nobody talks about burden of care here, because in the NHS, even there, the burden of care, I'm sure they will look at it, the multiple travels, the loss of work, the travel expenses. Of course, they may not have to pay for the helmet, but there's a lot of other things. So it depends, how much even the parents can spend time-wise and money-wise. So you're not saving expenses completely, are we? You might be even spending more.
Exactly.
Yeah.
That's one of the, I think, myths that endoscopic is cheaper. And most of the papers suggest that, but the papers don't factor in the helmet therapy part. So that's very important. Actually, it's probably more costlier than the open procedure in terms of cumulative price for the patient.
So you would, if you had to look at what you would choose, you would look at, morbidity, mortality. Of course, there is no mortality in helmets. Then morbidity wise would be, immediate post-op morbidity versus endoscope or a helmet child going in for a surgery later. Yes. And mortality, then we will have to look at how many of these single suture synostosis children have a sentinel event. Probably we look at that.
Is refusion a problem? Because again, when strip craniectomies were done, there was refusion. This can happen in very well in a patient where you've done a strip craniectomy and a helmet, and imagine they have fused again.
The fusion can happen in open surgery too, for that matter.
So they are not compared. Actually,
I'm saying that they are, the endoscopic procedures per se are an effort to avoid the open surgery at all. They're not comparable. Open surgery always do more complex, the cases are more complex, we treat them more complex. So just comparing endoscopic with open, I don't think that is correct, even the cost wise. But because and then when the window moves, then you have no option. So you have to get the patients there in that window, you have to operate them. I mean, if you are able to save them from a better surgery, probably you will be able to save cost, otherwise not.
All right. I have a question. What is the redo rate in helmet therapy? Because you can compare that at least with open.
Yeah, a redo rate, we are pretty open about it. In the past 80 cases that we have done, we have offered redo surgeries for 2 patients, which they have not taken it up. But we ourselves, that's why I asked the outcome measures, we grade it as Whitaker classification 1, 2, 3, 4. Anybody who falls into 3 or 4, we offer redo surgery. And they have, but the parents have not taken it up. But we were not happy with the final result with terms to the measurements that our star scanner from the orthotics gives us.
Because there is always a surgery, right?
Yes.
So cost-wise, if you had to do a complete open procedure versus a minimally invasive procedure, how different is it in terms of hospital stay?
Purely surgical, right? Yeah.
Yeah, purely surgical.
Purely surgical.
Purely surgical. Would it make a difference in your?
Yeah, I think it's a significant difference. It's because hospital stay is 1 day or maximum 2 days. Whereas I think open procedures, we all keep our babies for 7 days, 5 to 7 days maybe. And no blood transfusion, no ICU stay. I think almost 50% reduction in cost when you talk about only surgery, but obviously the helmet kind of covers the rest.
Yeah, one comment?
Yes, please.
Yeah, from your last slide, I think spring is a very important part of the, should be a very important part of the armamentarium, especially for scaphocephalics and extreme metopics. I think with Pramod we have used for extreme metopics too. Spring, and it cuts down the cost. It's still minimally invasive. It cuts down your stay. So beyond the helmet, this is a thought process which should be.
Anybody else? I think Ames Rishikesh has done a few spring cases. I think if you can.
Yeah, I just wanted to have a question to Dr. Suhas, sir. I think he was talking about the results with respect to the open versus endoscopic.
In Scapho?
Scapho, yes.
Yeah.
You said 75 and 85% for open and endoscopic.
No, yeah, I do open for even later stage.
Yeah, that's true. So there are two things I think we have to also look into, because the age of intervention is quite later in the open.
Yeah.
That is one thing. The other thing is that we are using a helmet following an endoscopic procedure. So there's a vector which is being guided.
Okay.
So, but then we are not comparing this with the open technique, where after that we are using some type of distractor or spring.
In Scapho, no, there's no other additional adjunct.
Yes, sir. So what I'm saying is there is, so since they are not equal comparisons, I don't think it should be reflected on the result.
I didn't get the last point.
So we are doing endoscopic procedure. Following that, we are using a helmet to direct the vectors and to maintain the vectors.
Agreed.
But in open, after that, we are not trying to compare them with an equal technique, where we are opening up the sutures, but then we are not guiding the vector using a spring or a distractor. In those cases, I don't think we can compare them.
Yeah, so I always felt that open is gently, has a drawback in terms of outcome, because the child is positional. The child sleeps on the side, so it might become, you might not expect the outcome which you want.
Yes, sir. So I think we should have studies.
Agreed. They are not
Run out of time, ladies and gentlemen, and time to conclude the session.
Thank you.
All the panelists, including Dr. Jag from UK, for joining us. Thank you.
Thank you, Dr. Vaibhav, and all the panelists. We'll move on to the next session on endoscopic suturectomy by Dr. Anurag Sharma, neurosurgeon from Amrita Institute of Medical Sciences, Faridabad.
So disclaimer, as I mentioned, that I don't think open and endoscopic are competitors to each other. They endoscopic per se is just an effort to avoid, if we can avoid the bigger surgery or open surgery later. If it doesn't happen, we have to do it, then we have to do it. So among the minimal invasive surgeries which are now in vogue in all spheres of surgical specialties, endoscopic suturectomy is one of the procedures which is now being promoted, has been mentioned as to a shorter hospital stay, less blood loss, overall cutting down in the cost for the hospital part at least. So this basic slide, I will not delve deeper into it. We all know what craniosynostosis is. And my focus today is going to be just to explore the nuances of endoscopic techniques, how it is done, what we do, and how are they revolutionizing the care. So in this slide, we highlight the transformative advantages of the endoscopic techniques in craniosynostosis repair. The endoscopic approach, which is celebrated for its minimally invasive nature, significantly reduce scarring. It improves the aesthetic outcomes which are very crucial in pediatric care. It dramatically lowers the blood loss, thereby decreasing the need for transfusions, especially in the infant, because at that point every ml of blood is significant. Losing it, we want to save it. These techniques also offer shorter operating times, shorter hospital stay, almost nil ICU care. So that's what makes it very entailing to achieve. And now long-term studies have also come which shows that they are acceptable. I mean, they're not supreme, but they're acceptable results to compare to the open procedures. So which means that at least for the surgeries they can be compared with the outcomes. Now we come to the surgical techniques and as the evolution. Initially, we were just trying to focus on treating of the symptoms rather than looking into the overall shape. And as our understanding has improved, we started with the we'll try to make the head more better looking. We will cut the sutures, and as it was been discussed that then the sutures used to fuse again because we were not looking at what is causing it. As our understanding has improved, and then the whole change which came. When we started doing the bigger procedures, when we started doing the cranial vault remodeling, those big procedures started bringing significant changes into it. But then, since there were so many, not so many, but the complications associated with the big surgery needing blood transfusions, that need for blood had to be present in the OT at the time of incidence has been taking. And then in 1990s, doctors Yemnes and Beron, when they published their study about their results into the endoscopic approaches with helmet therapy. And when I say endoscopic, please accept the helmet part is part of it. If you remove the helmet part, then it does not serve any purpose. So current trends and techniques as they are evolving, they are getting better, and there more and more centers are going to, for whatever reason, maybe political also, but they are now being utilizing these endoscopic services. And once anybody starts using it, I can assure you that the results are gratifying. There's no doubt about that. Very important part of this, is how do we select these ideal candidates. The surgeries most of the centers will only take their extreme patients of endoscopic procedure up to 6 months only. And we used to do in Canada, less than 3 was the ideal, because then cutting the bone becomes easier because you just create the incision, then you cut the bone. Blood loss never had any problem. In one metopic only we did the transfusion because we had some loss of through the emissary vein, we lost a little. Now, the important part why we do it before 3 months is that after between 3 to 6 months, actually 3 to 9 months, the brain forces, they drive the growth of the bone, and that is why the helmet supports it. By restricting some parts of head and leaving some parts open, the shape of skull becomes. And the CTs, once you see, you realize that how beautiful the 3 or 6 monthly CT becomes when the scaphocephali becomes almost normocephaly. Correct. Now, it's primarily indicated is for single sutural, but coronal, now bilateral reports are also coming that they are doing bilateral. They're more extensive, but they are being done. And we need to evaluate, as we have already discussed, that there is no way we can say that single sutural is not syndromic sort of thing. And for a specific group with very specific subgroups, it's very useful. The families have to commit to the care. If the families do not commit, if families don't understand, families do not want to. I mean, in Canada, it was very easy for us to understand families are committed because the insurance was not covering for the helmet. So the families were paying out of their pocket, $2,500 we used to pay. So we knew that if they're paying out of their pocket, they'll commit to the care. Now, the important part is pre-operative preparation, which means that we have to have detailed imaging studies for the surgical planning. We have to understand how much to cut, where to cut. Initially, we used to cut long. So for sagittal, we'll do 3 centimeter on each side along with better stage. But now studies have come which say that just cutting between 1 to 1.5 centimeter either side of sutures is sufficient. You do not have to do that big radiectomy. Even barrel staving, which is now many studies have come, so they say that it is not required. You just do a suturectomy and that will take care of it. Typically what is done is that we just create the sutures of interest, we just create 2 small incisions on either side of the suture. We just define dura above and pericranium above and dura below, and we just cut it and we just remove the bone. And the rest is done by the helmet. We have to monitor the kid. The kid is under GA. It's a very small kid, and so we brain activity, oxygen levels, and blood flow. We have to see, and that is where endoscope helps actually. If there is any significant bleed, we are able to see and deal it with then and there. Once the surgery is done, then we shift our focus to the post-operative management. Again, because it's not that big surgery, the post-operative management is also not. Coming to the initial recovery phase, we just monitor the patient sign. These kids, they don't go into ICU. So from post-op, they can directly be shifted to room, and most of the places they can be discharged next day. There are just 2 incidents which have been made. Now, a custom fitted orthotic crucial for molding the infant skull is mandatory. If this is the most important part of the endoscopic approach. If we cannot do it, then the outcomes are not going to be good. So the outcomes become dependent on how the orthotic is following up on. Now, we usually start between 7 to 10 days. The people will go for getting their head size measured and planning for the helmet. About somewhere around 3 weeks is the time when they start putting up helmet. Over next 10 to 14 days, starting from 1 to 2 hours, they will keep on increasing, and the helmet will be worn for 23 hours every day for next 12 to 18 months. The kids get very used to it, so it's not a problem. Initially, they just for 1 or 2 or 3 days, but they start loving so much that at the age of 18 months, you want to remove it, you want to throw it. The kids will try to resist. They want their helmet on their head. So the monitoring when the helmet therapy is very essential. So every 3 to 4 weeks they have to monitor, and of course they can come like here directly to the doctor. So every time they will go, they will come back to us also. But in Canada, they were visiting the orthotic more than they were visiting neurosurgeon because of the appointment related issues. Parental involvement every time whenever it was being the orthotics, they were explaining the parents what to look for, what the pressure points, how to check for when they remove, when they give back to the baby and all. Coming to the isolated, treatment for the sagittal craniosynostosis, it started with this only. So sagittal craniosynostosis, most people can be done. You don't need much. Just the lighter rhinoplasty retractors can help also. You really don't need endoscope if you have because direct visualization can also help. You just put 2 now. There's the papers which are published that only with a single incision also you can do sagittal craniosynostosis. This thing. So that you just define the dura, you just place the scissors across it and then leave it this thing. It's of course the outcome wise, that the operation time is very less. It's less than, it's about an hour or so surgical time per se, in which you can just apply the cut and you can remove it. But still, you have to have the imaging work, and you have to plan your incisions. You have to understand the anatomy and the disease well before you can say that this is outright. Because once you understand, then only you are not going to raise the parental expectation unnecessarily. The metopic is slightly more difficult. But still, the difficult part is that the cosmosis is not that good because it is in the frontal part. It is seen by the patient. Another thing is that if you cannot go till the nasofrontal suture line, then the problem is that we have probably not treated the disability per se. As I said that, the stay-wise surgical procedure time, my experience is that the metopic used to take twice the time that it used to take for the sagittal ones. The coronal, the unilateral and bilateral coronal stenosis, again, same thing. You put incisions above the suture, you define dura above, and then the one-sided is relatively easier. But then again, you have to remove that. You have to go down till the floor of till the base of the skull to remove the suture. Once you remove the suture line, you can see in the both sides the sutures can be removed, and then you let the this thing to take care. the helmet to take care. The common complications, actually, again, they are not comparable. When we compare to see that what is the open endoscopic versus open, I don't think they are comparable. Literature has tried to put some comparisons. But since we do not have any significant complication rate, it appears that the complication rate for endoscopy will be less. But we don't. We have to understand that when we are doing the open procedure, they are more complex procedures. The patients are more complex patients. So getting them into again does not mean that endoscopic was very safe procedure as per complication rate. And there is a very significant role of post-operative care, and outcome are good. Parents are generally happy. So to ensure excellence, to ensure that that what we have done, it is follow up. We have to understand that it's a long-term care where we have to follow both the cosmetic and the functional outcomes. The data on success rates has to be calculated, mesocephalic index, the metopic angle, and everything we have to keep on storing so that we have more and more evidence as we progress into it. The regular follow-up, the importance of regular follow-up is there. The family engagement and support is required because for them it's a continuous engagement. But most of the families are very happy. They probably think that they avoided, that's why they are a major surgery, but they are satisfied with general cosmetic results. And as the challenges build up, as the challenges happen, as you note down some problems, as you notice some pressure point developing, they have to be addressed at the earliest, and that what make any healthcare excellent. Economic wise, again you have to understand that as we say that multiple visit to orthotics, multiple follow up, 2 or 3 helmet, the cost per se, whether it comes or not, but if we think of psychologically, we are discharging the patient in 1 or 2 days, not going to ICU, shorter time, no transfusions, and it does appear mentally that it's a relatively cheaper alternative. It is not. I agree to that part. And the impact on healthcare resources, as Dr. Jag also mentioned, is good because they can do more procedures can be done in the same time being, right? And most of the families, they have said that this is, they are very satisfied with the procedure which has happened. So as we move to the futures, the technological innovations, things are changing rapidly in the field. Everywhere minimal invasive techniques are coming, robotics are coming. You can actually define everything pre-operatively, that what exact line you want to cut. And it's a time when we have to keep on following those things. In terms to material science also, the new biocompatible materials are coming. You can have custom fits. You can design in such a way that the helmets are made individually for patient. They can exactly calculate now how much pressure is going to exert on the growing bone on the scalp. Right, and it's a collaboration and multidisciplinary approach. So that we have to understand that all the specialties to come together, including the genetics, including the orthotics, craniofacial, neurosurgery. Everyone has to come. They have to chip in together to deal with these problems. So to conclude that as we embrace the future, we have to accept that there are advancements, and we have to at least try and to see how it happens, that most of us are comfortable in doing what we do, because we do it, over a period of time, we have done it well. But once or twice, if we get right patient, trying this is going to be, I think it's going to be worthwhile doing it. We have to acknowledge that the challenges it will throw. It's not everything, but as we'll keep on evolving, we'll know more about doing it. We have to get data. We have to store more and more data as to how things are happening, how long-term outcomes, as the successfully the 20-year follow-ups of these initial cases done by Dr. Jimenez and Beron are coming up. That we know that it is something. It's not, you cannot just rule out, reject out that this is not something which it's a force to be considered at least. And so final thoughts, I would like to say that the endoscopic craniocentesis repairs a significant advancement by offering a safer and more effective treatment early in the part, and while it paves the way for continued innovation and improved patient outcomes in the year to come. So we operate as a team, myself, Dr. Anil, Dr. Sachin, and Dr. Arun. 75% of this team is here. And if there are any questions, I'll be happy to answer.
Thank you, sir. Next session is on cranial orthotics by Mr. Sharavanan Sundar Krishnan, orthotist from Care Prosthetics and Orthotics.
Yeah, good morning, everyone. First of all, I would like to thank Dr. Vaibhav and the organizers to have me be a part of this. It's been a very wonderful morning session, And I think the previous two, the panel discussion and the presentation just now by Dr. Anurag will make things more easier for me with this presentation that I'm doing. So I'm an orthotist and prosthetist by profession, and I currently lead the clinical department for care prosthetics and orthotics. Next slide, please. Oh, sorry. All right, sir, I got it. So the objectives of today's presentation for me is to kind of go over a few things. To identify infants with skull deformities, which usually happens at the doctor's clinics, understand about the orthotic intervention programs, types of cranial remolding orthosis, understanding the function of the CROs, and of course, talk a little bit on the interdisciplinary approach for these deformities. Okay, sometimes patients directly come to us through the social media channels. They get to know about cranial helmets and all. And first thing what we do in our clinic is to make sure we identify what is the cause of the misshapen head and clinically, and then we direct them to the concerned doctors, a maxillofacial surgeon or the plastic surgeon, where we are in contact with. And then only we proceed with the helmet. Even if it's a positional deformity, we usually prefer that they go through a doctor and make sure that there is no craniosynostosis or any other thing involved in it. Usually the skull deformities that we see are in mainly two divisions. One is the positional, which is probably caused due to sleep positions, premature birth, torticollis, restrictive intrauterine movement, birth trauma, some other cervical abnormalities, and of course the second group is the craniosynostosis, in which of course surgery is involved. So how do these skull get deformed if it's a positional condition? So basically the effect of the force is dependent on the pliability of the tissue, stage of development, and the duration it's on. So for example, if there's a patient with a torticollis involvement and they're laying down on their side, usually we do see a plagiocephaly kind of a condition. Ultimately, we all know that the skull is going to grow along the path of least resistance. So some of the most common deformational head shapes are plagiocephaly, asymmetrical brachycephaly, symmetrical brachycephaly, and scaphocephaly in the positional. And if it's craniosynostosis, these are all the conditions. Scaphocephaly and trigonocephaly are very commonly seen, and then we do also see some amount of brachycephaly too. I'm not going to go in detail with this, much has been talked, but usually the two most common things that we have encountered is the CVR and the endoscomic craniectomy or the strip craniectomy. Now this is a very interesting topic. When do we start the helmets? And it all depends on, of course, the surgical input also. So let me first start with non-surgical cases, the positional cases. So the plan is based on many factors: the infant's age and potential for growth or change, severity of head deformity, presence of torticollis or movement asymmetry, and of course whether it's a craniosynostosis or not, and surgery is needed or not. Infants up to 18 months can benefit from CRO. We never have gone past 18 months. The best results are obtained if the infant completes treatment by the end of the first year of life. So 12 months is usually the most common time. Beyond that, we very rarely go, but in one or two cases, depending on the doctor's reference, we do have stretched it beyond 12 months. Now, if the baby was premature, we need to subtract the number of weeks of prematurity from the infant's chronological age to get the corrected age. 4 to 6 months of age is the most ideal age, what I have experienced dealing with making helmets for the last 18 years in deformational conditions. So usually if it's a moderate, we expect approximately 20 centimeter of growth for the correction, 20 millimeters, sorry. And in severe cases, approximately 30 millimeters of growth is needed. So 4 to 6 months is a very ideal age because a lot of brain growth happens during this time. As far as craniosynostosis is concerned, again, 3 months is the usual cutoff, what we usually follow. But then if the surgeon decides to go early because of any other complication, we have done for even 2+ months. I have not done less than 2 months in non-syndromatic cases. I have done a few, where Pfeiffer syndrome, Eppert syndrome were there, but this was when I was practicing in US. So brain growth is very important to understand with the helmet therapy. The infant skull doubles in size by 6 months of age and doubles again by the age of 2 years. So that is the reason why after 12 months of age, usually helmets are not provided that much. The head is going to continue to grow. The shape is going to keep getting better, especially as Dr. Weber mentioned, unicoronal. It is going to keep getting better even without the helmet. And we have seen that as an evidence. Skull is easily deformed when subjected to prolonged external deformational forces while the brain is growing because it's malleable. So the fastest brain growth typically occurs between birth and 8 months of age is what we have seen. 80% of the head growth occurs within the first 12 months, and this is what the ratio which has been kind of devised. And 1 to 3 months, it is 2 centimeters per month. 4 to 6 months, it is 1 centimeter per month. And then 6 to 12 months is usually 5 millimeters per month. So CROs applied during the months 4 to 6, they can capture and direct a total of up to 3 centimeters of circumferential growth into the flattened areas. And which the same thing if you're doing after 6 months, it takes twice as long to affect the same change. We do get results, but they have to wear the helmets for a much more longer period. How does the cranial remolding orthosis work? This is a very interesting question which every parent wants to ask. And a lot of them think that it is because we are trying to press the head and trying to get it into shape. But we do not press or constrict brain growth with the helmets. We are redirecting where the growth is desired. And this is achieved, as you can see in the illustration. We create spaces where the growth has to be there and just maintain contact points in the areas which are more prominent. The goal is not just to get a good looking head shape, but we also try to make sure that we are attaining proportional and symmetrical head shape for growth. The different types of cranial remodeling orthosis that we use in our facility are Starlight Bivalve, Starlight Pro, Starband Bivalve, and Starband side opening. These are all, we get it imported from US. It's all FDA approved devices. So the materials, where it is made, all those things are extremely overseen by the FDA. They're very, very sensitive about where it's manufactured. So not every clinic, even in US, has the capacity of manufacturing this, or they're allowed for manufacturing these. I'm just going to go very quickly over the details of these helmets so that you guys are aware of it. So Starlight Bivalve, this is made up of clear plastic shell with some foam pads, as you can see in the picture. It is in 2 pieces. And it has a side as well as a top opening. This is the most common helmet which we use post craniosynostosis surgery, post the endoscopic surgery. It has a clear material which allows visual inspection. So this is very key for us, especially even if it's a minimally invasive surgery. The first few weeks, it is good to observe how the suture is, whether there's because it's going to be on the patient's head for 23 hours a day. So we want to make sure that no sign of infections or those things are there, and the parents can have a good visual view. It also can be used for other conditions like plagy, brachy, and scaphocephaly because of positional deformities. Then there is another design called Starlight Pro. It's similar to the Starlight Bivalve, but this is a single piece helmet, which is the style is called the one piece living hinge. This is the advantage of this over the other one is that it is a little bit less cumbersome in design because it's a single plastic, because of which the weight also is slightly lesser than the first design. But the problem with this is there's not too much of adjustability in it as the patient grows. And if you're going with this, we usually have to use more number of helmets. So we use this, but very rarely. And the next 2 helmets, the Starband Bivalve and the side opening. Now, these are the helmets which we use as the second or the third helmets, usually after the 6th month or 7th month. The advantage of these are that they are made up of copolymer material, which is a little bit more adjustable with heat, and they have a lining of foam padding, which can be 1/4 inch to a 1/2 inch, which allows us again to accommodate all the growth that is happening. So as the patient's head keeps growing, we keep doing adjustments to allow those growth. So we reduce the thickness of the padding, we see where the pressure points are, give reliefs to them, and then go from there. Starband side opening, this is the most widely prescribed headband design in US because the cases of plagiocephaly are much well recorded earlier over there, and this design works really well for plagiocephaly cases. It's similar to the Starband bivalve, but it has a more open design, so it opens from one side and it has an opening on the top also. So how do we make these helmets? So the helmets are, we use the Smart Sock scanner. Again, this is software which is pretty awesome, and it's highly sophisticated, but it goes through an iPhone device. The Smart Sock basically delivers a fast, portable, accurate, and affordable scanning platform for ordering any of these helmets through Ortho America. Some of the salient features of Smart Sock is it's an FDA cleared class 2 device for image capturing, which means that it's pretty safe for us to use it on kids even if they're 1 month or 2 months old. It's a HIPAA compliant device. The accuracy is up to 0.01%, so it's far better than taking a mold of the head and then going. I know there are a lot of scanners out in the market also where they do scan and they prepare a 3D printed helmets and all. That's getting more common, but we have to really see what is the accuracy of those scans and what kind of designs which are being made through it. It allows for patient for moving also during the seance. So we all know that kids, we cannot just put them in one place. So even if their head is moving, shaking, this will capture it very easily. And there's a short video which I'll show at the end, which will make you understand how it works. It enables the easy organization of scans and orders by patient profile, which means that we can have n number of data. We can compare scans at whenever we take them. So at the initial stage, if they're going through different helmets at the end of the treatment also. And this is the data which we share with our referral sources and make sure that they can also give their feedback on if any other changes are required or they're satisfactory with the result, and then we move on to the next helmet. So some of the benefits of these scanners are it's very fast. Within 5 minutes, the scan can be taken, although it takes some time to get the preparation ready. It's very portable, so we can use it, we can take it, we can go to the doctor's office or patient's home also to do these things. It has 240 plus data points, which is available for reporting. So we can check the measurements and cranial wall asymmetries and all at different levels. It is pretty simple. It's just an iPhone with some software and some device attached to it. Can we play the video which is there in the folder? Sorry, I could not get it into the presentation because of the size. So this is a special sock which is put on the patient's head. We call it the Smart Sock cap. It has different data points for collection. And then there are some specific markers which we have to put in the tragus and the other point, the glandular. Then this is the scanner. You use for taking pictures and scans of the Once this is taken, it goes to the software and we give another dimension. On the other dimension, the expert and what part comes in. saw, it gets scanned on a PU foam and once carved on a PU foam, and then we get the exact shape of the patient's head, which is modified, and then the helmet is fabricated out of it. Depending on what kind of material we are using, it is thermoformed and vacuum formed on top of it. So I just wanted to discuss one last slide with me. These are the results of one of our patients. I started collecting more of the data after April, so we have done close to 26 helmets in some of our locations in India. 23 of them were from Dr. Vaibhav's patients only. And out of them, I think 4 were positional cases, rest all were craniosynostosis. Majority was trigonocephaly and scaphocephaly with some coronal, unicoronal and 1 bicoronal, if I'm not wrong. Now, this is a case which the patient was seen by Dr. Vaibhav at the age of 3 years. They went ahead and they went for the surgical option of endoscopy. It was a sagittal suture craniosynostosis. So you can see the head shape, scaphocephaly on the left. And the pre-cephalic index at that point was 71%. And then we made the helmet. I think this patient went through 2 helmets. And by the age of 10 months, the cephalic index had improved to 78%. But you can see the shape also on the right hand side. The same patient before and after pictures. And on the extreme left or right side of yours, you can see that was the first scan in the violet color. And you can see it's not just the elongation of the head, there is some flattening on the topmost quadrant, the top left quadrant. And you can see the results in the bottom side after the helmet therapy and all. So these are the kind of results that we kind of try to aim for and try to share with our doctors also. And based on whatever the inputs are, we do necessary changes. Now, as far as cranial helmets are concerned, so after the surgery is done, we have been doing the scans just 1 or 2 days before the surgery versus waiting for an 8-day thing. And then the usual protocol is once the scan is taken, within 7 to 8 working days, we usually get the helmets from US, and the fitting is done within 2 weeks. And once the fitting is done, we do a 1 week follow-up and then a couple of 2 weeks follow-ups, like 15 days. And then we are on a monthly follow-up pattern. The first few months are very critical. That's when majority of the head growth happens. So we have to keep seeing them very frequently because of this reason. Once they cross the 6th or 7th month, then it's usually 1 month or once in 2 months that we see them. Every time we see them, we also take linear measurements, as you can see in the chart. So that we kind of continue to monitor how the growth is happening and do all the necessary adjustments for accommodating the growth during this time. That's pretty much it from my side. Any questions, I'm more than happy to answer. All right, thank you so much.
Thank you, sir. Next session is hydrocephalus and Chiari, an overview by Dr. Suhas Udaykumaran, Professor and Head, Department of Pediatric Neurosurgery, Amrita Hospital, Kochi.
Thank you. Thank you, everybody, and good morning again. As you realize across the day goes on, that this is one entity which is very classical and mostly in the syndromic craniosynostosis, the combination of hydrocephalus and Chiari. So when do you diagnose this? So clearly there might be signs of raised ICP. The CT and MRI might show it, demonstrate, and if it's a syndromic, you expect it. So you have a CT MRI which picks up the hydrocephalus. you have an evidence of Chiari. You might have a subarachnoid spaces which are very narrow, which are thinned out or effaced. The veins are very prominent, again clinically, and on the radiologically it is reaffirmed. And on sometimes the hydrocephalus appears on treatment follow-up. So these are the situations where you pick up the hydrocephalus or you have the hydrocephalus already, and Chiari is usually always there much earlier than you have seen the patient. So how are they different? How are they different, the Chiari and the hydrocephalus, compared to all other neurosurgical situations? Now here, all the ventriculomegaly which appears in syndromic craniosynostosis is not hydrocephalus. At the same time, no ventriculomegaly does not mean there's an absence of hydrocephalus. And so an enlarged ventricle might represent a hydrocephalus which is shunt dependent, or ventriculomegaly which is shunt independent. So you have a situation where ventriculomegaly is in hydrocephalus, a ventriculomegaly which is not hydrocephalus. Both situations are possible, which is very unique for craniosynostosis. So then the second aspect is you have a progressive hydrocephalus without the change in ventricular dimensions. And then you have a force which is outwards, that is the hydrocephalus, and then you have an inward force secondary to the primary craniosynostosis. So these are very unique to craniosynostosis. The pathogenesis is also very unique. You have an obstructive element, you have a crowded posterior fossa, you have a functional element secondary to the venous hypertension. So very clearly, presence of ventricular dilatation or pericerebral collection may or may mean presence of hydrocephalus. So additionally, very occasionally, sometimes you have neural tube defects along with craniosynostosis, which can add to the possibility of hydrocephalus in these children. And then additionally, you have situations where standard management, like putting a shunt when you see a hydrocephalus, can be counterproductive. So there are adverse effects of your standard treatment of hydrocephalus. And so hence, hydrocephalus and Chiari in craniosynostosis is a completely different approach-wise, pathology and outcome. So when you look at the incidence, it's very common in syndromic craniosynostosis and very rarely in simple craniosynostosis. In lambdoid it might appear, and sometimes in sagittal synostosis. But at the same time, syndromic, it's very high in incidence, especially the Cruzen's and Pfeiffer is about 30 to 70%, whereas in a PERT it's much lesser. How do you start evaluating? The imaging, of course, if you do not have a functional presentation, CT and MRI and an airway situation might direct towards hydrocephalus. When I say airway, it's equally important in terms of hydrocephalus because you have a situation where there's a raised ICP secondary to PCO2 retention, which might be adding to raised ICP and incipient hydrocephalus. So hydrocephalus and Chiari are probably they have a common causative mechanism, and the management is extremely complementary, unlike any other neurosurgical situation. Just to go about very specifically about Chiari, Chiari is observed in 90% of patients with syndromic. It's a condition that's necessary but not sufficient to ensure the presence of hydrocephalus, and so hence Chiari malformation by itself cannot be considered as an inducer of hydrocephalus in these children. Just for the youngsters, what defines a Chiari? It is secondary to a small posterior fossa in these children, and there's a premature fusion of sutures, which leads to a cephalocranial disproportion, and then there's a crowding of the posterior fossa and a hindbrain herniation. So that is Chiari for you. So, and MRI is the gold standard. The presence of absence of cisterna magna and the asymmetry and the displacement of brainstem and the downward protrusion of tonsils demonstrates Chiari. It's very high in syndromic, to the extent of 100% in Kleeblatt-Shuttle and about 70% in Cruzen's. Occasionally, non-syndromics can have it, especially lambdoid, and very occasionally in metopics. And again, another important aspect is it may not be present at birth, and it slowly develops as the sutures start closing. So you have a situation where Chiari may not be present at the first scan, but you might anticipate if you have a situation which is possible to develop Chiari. And again, as I mentioned, it's secondary to the basal sutures, involvement of basal sutures, which is much common in Cruzen and less common in PERTs. Again, the less smaller the anteroposterior diameter axis, you expect a Chiari to be present. And lambdoid closure especially is very commonly associated with the presence of Chiari, secondary to synostosis. So as I mentioned, venous stenosis and the tight posterior fossa leads to secondary effect of hydrocephalus in the presence of Chiari. So how do you manage hydrocephalus? Hydrocephalus is managed either by endoscopic third ventriculostomy or ventricular peritoneal shunt, or more functionally posterior calvareal distraction. The issue of shunts are very common in most of the syndromic ones because they have high chance of hydrocephalus and less common in other syndromes. So cruising like fever usually requires shunt at some point of time. I would allude to it later, but others might not require it as much as cruising syndrome fifers. The major pitfall of using a shunt and craniofacial anomalies is when you use a shunt, you are reducing the intradural force which tries to expand the cranium, and shunt by itself can cause secondary craniosynostosis. So that if the hydrocephalus is very prominent, you might need to do a shunt, especially if you have a very young baby coming to you with prominent hydrocephalus. But at the same time, if you expect it if you see it after your calvareal remodeling, you should try to delay it as much as possible, at least for around 2 months, so that you're at least the voltus stabilized and you don't cross a secondary synostosis. And the next important point is the implant selection is equally important because you want to avoid over drainage, which can create, which can add to secondary synostosis. So usually the preferable shunts for these situations are programmable shunts, or one with the programmable valves and one with the anti-Sybin valves. So the cost logistics needs to be kept into account, which putting a normal shunt or a regular shunt might be counterproductive. Endoscopic third ventriculostomy is another option which we use in presence of hydrocephalus, because you believe that there is an element of obstruction functionally, and the advantage is it does not have the classical demerits of shunt, with about 60% success. Technically, it may not be very challenging, but the failure rate is there. So as you notice, there's a 60% success. So you might fall back. You might have a situation where you have to fall back to different other procedures. So maybe it should be used as a primary surgical option because it maintains a positive effect of the expanding CSF force compared to a shunt. But at the same time, again, as I mentioned in the last slide, a higher failure rate should be taken into account when you use it. And hence you need a close clinical and radiological monitoring. Just to give you examples of these situations, so this was a 3-month-old who came to us with severe failure to thrive and a large hydrocephalus. We started off with endoscopy, failed, started leaking, did a shunt, and then went on to do posterior calvareal distraction. So you might have to use all three in different ways and tailor it according to the situation. So this was the posterior calvareal distraction ultimately. This is another situation where a 4-month-old comes with a full fontanelle. Again, here ETV succeeded, and I could do a ETV, and later went on to do a posterior calvareal distraction because Chiari was very prominent. So this was a classical cruising, but presented the hydrocephalus in the beginning, at the early infancy. This was a different situation where I had a 9-month-old with full fontanelle. Here we preferred again a cruising. Here we preferred use of posterior calvareal distraction directly. So this was a CT scan showing the lambdoid involvement and multiple suture involvement. Here we used the posterior calvareal distractors directly without using ETV and hydrocephalus in between, because the child was gently more acceptable in the clinical scenario. So that's what we did. Posterior calvareal distractor, again, supratrochlear technique, and then went on to have an airway issue. So to summarize, the hydrocephalus, in case of presence of hydrocephalus, ETV or endoscopic third ventriculostomy is an option. VP shunt, preferably the controlled ones, are more of a standard when you want to use it for hydrocephalus. Posterior calvareal distraction is probably more functional. So when you have a situation where hydrocephalus and Chiari both are present, you should realize the fact that these are candidates for total calvareal construction, either staged or in terms of or total calvarial. So when it comes to management of Chiari malformation, posterior distraction is a clear option, and that should be the primary thing. You might use foramen magnum decompression alone in older children, and very occasionally, if you think the ICP is not much raised and it's an older child, a frontoorbital advancement might can be added to your armamentarium in direct Chiaris. And when you have an older child, it's very important to understand the fact that you need to have a venogram much before you decide on handling the posterior calvarium, because they might have venous emissaries which are very prominent, and you might have to play with different other techniques rather than the standard posterior calvarial distraction. This is another example where a 17-year-old scaphocephaly presented to us with Chiari and symptoms of Chiari. So he had intermittent syncope, his fundus was normal, he has large ventricles and has poor performance issues, but he's 17-year-old. So I started off with a foramen magnum decompression instead of a posterior calvarium because he was scapho, and after that he did not have any issues of his presentation. So once in a while, you can get away with the foramen magnum decompression, especially in the older child. So this is pre-op and the post-op scans. So to conclude, ventriculomegaly is not hydrocephalus. Infants or severe hydrocephalus, you might prefer shunt and or ETV. In older children, prefer posterior distraction if the signs of raised ICP are present. And FOR might be an option if there are no clear signs of raised ICP and in an older child. But at the same time, it's very, very clearly, each of these situations should be tailored according to the clinical scenario. Thank you.
Questions?
Nicely presented, sir. I think ETV versus shunt probably, because ETV sometimes is not successful in very young children, particularly below 6 months of age. The subarachnoid space is not that formed because we are diverting the CSF flow from ventricles to the subarachnoid space. So the younger the children, I think the ETV success rate is less. So shunt is probably more preferred.
Yeah, this is a separate cohort in the sense that you have secondary synostosis elsewhere.
Agree, sir.
Whereas ETV in a failure of infancy is classically reported in children with completely open fontanelle and open sutures. So
yeah,
ETV here has an advantage because one, closed sutures. Yeah. Second is shunt has its negative effects.
Absolutely.
Children on the treatment which we are going to perform in the future.
Yeah. And sometimes you have to see the pre-pontin cistern also.
Yeah, so ETV is an option to try off, especially when you have a very sick kid.
Yeah. Absolutely.
Sir, I have a nice presentation. This shunt-induced secondary craniosynostosis, how will tackle like?
You can go ahead with the same procedures, remodeling, distractions, all these are standard.
Like,
so first, I'll tell you, let me start off, prevention is the option first. Yeah. And then beyond that, any cranial calvarial remodeling techniques can be used, including posterior distraction.
Okay.
Slit ventricles, everything, all these are.
And it's a norm in ACM that you go from top to bottom. Like ACMs have, like you have hydrocephalus, you have foramen magnum, you have Chiari, and you have some meningomyelocele. So we start from top to bottom. Yeah, like hydrocephalus first, then CV junction, and then.
Yeah, if you notice that 17-year-old.
Yeah, I agree.
I gently stepped slower because he's 17-year-old. You have emissaries elsewhere, and he's not presenting with hydrocephalus. He presented with syncope and direct Chiari signs.
Agree. Thank you, sir.
Any more questions? Okay, thank you so much, sir, for that informative session. Next, we have a video presentation on PCVD technique by Dr. Arjun Krishnadas, Reader, Department of Craniomaxillofacial Surgery, Amrita Hospital, Kochi.
Good afternoon, everyone. So I would be speaking on the surgical video demonstration of posterior calpebral distraction today. So I have made a video and I would explain the intricacies or the things that you have to take care while you do a posterior cranial wall distraction. So this is a 1-year-old boy. He has bilateral lambdoid synostosis and requires a posterior cranial wall distraction. That's him. So initially, the patient positioning, the patient is going to be supine, okay, and then you flip the child, make him into prone. The things that you have to take care is, one is the eye, and next one is the airway. Okay, so once all that is prepped, next what you do is you have to mark the incision. So when you mark the incision, you have to have a pair of distractors at that point. You need to have a distractor in place so that you can mark the incision according to the position of the distractor. Having said that, the posterior part, that is your posterior flap, okay, that should accommodate your arm or the distraction port. Okay, so you keep the distractor there and then you mark the incision. So we all prefer using a zigzag incision. So you keep it there and then ensuring that the port is on the posterior flap. Similarly, mark the distractor position as well. Do the same thing on the opposite side also. And you complete the incision design all throughout. When you do this incision, you have to take care that later on you might have to address the frontal region. So your incision should not be way too posterior. So it should be at the vertex. At the same time, this same incision can be used for the posterior procedure as well as when you address the forehead. So the incision is, we raise the pericranium along with the flap. We go sub-pericranial. And we use Rene clips so as to control hemostasis. So now coming to the marking. So when you mark the calpebral flap, okay, so the few things that you have to take care is, one, you have to have the marking of the flap on the flat surface over here. If you go way too posterior, what will happen is the cranium is going to converge. So when it converges there, what happens is that your distractor is also going to converge. So your vector is also going to converge. So at one point you won't be able to distract because of a narrowing of your vector, or it's going to converge together. So you need to have the distractors parallel to each other so that your vector is parallel. And also when you have it way too posterior, what happens is that the foot plate stands out laterally. So there are chances of your distractor getting dislodged or your distractor breaking also, because there's a point in the distractor where it is very fragile. That is the point where it rotates and the central rod, that's where it usually fractures. So always have the distractor placed on the flat surface of the calvarium. Okay, so that's how the marking is being done here. And as you go towards the vertex or towards the height of the cranium, what you need to take care is, you will never want to translate the entire height of the cranium posteriorly, correct? Because usually these children have an increased cranial height. The height is more. So you don't want to translate it posteriorly. So you want to go posterior to the vertex and you want to translate that slope posteriorly in an inferior direction. So when you mark the height, you need to have, that's the vertex that I pointed out. And now that is the slope that you want to translate. The inferior part of the craniotomy is dependent on the neurosurgeon, or as to whether it is going to be supratrochlear or infratrochlear. So once you do that, you keep the distractor in place, which is halfway. That is, you're in the middle of the flap. You're not way too high, not way too below. You are in the middle of the flap. And also you see that the distractor vector is a little inferior. It is not straight. Okay, so you need to get the slope down. So you keep the vector also a little inferior. And if you noticed, I showed one point where, yeah, that is parallel, and you can keep it slightly lower so that the vector is also lower. And the footplate of these distractors, it moves. You don't have to adapt it. Unlike your R0 distractor, R0 does not move. You have to, sit and adapt it to the bone. This moves. So that is the advantage of a posterior calibrated distractor or an R0 distractor. So to check for parallelism, you keep one distractor, see it from the top and see whether it is parallel and it is at the same level. So once that is done, you repeat the same thing on the other side. You mark where the distractor is supposed to be. Then you can measure the flap size, you can measure that, and you can also say that, how much of volume that you're creating, you can calculate that. Then burr holes are required. You go paramedian and not in the midline. And then you collect the bone dust that has been generated from the burr hole that is placed. Then the craniotomy is done, starting from one burr hole to the other. That is on the lateral aspect. On the superior aspect, it is usually done a little bit more carefully, considering the venous sinus. The midline is obviously done very carefully. The inferior part of the craniotomy is usually we make a larger window over there because the vector is a little inferior, so that the lower part of the bone does not come and hinder your direction of vector. When the flap moves, it should not come and hit here. So a large part of a sleeve of bone has been removed, and also to make more space for the brain to expand. So the distractor is placed. Now you want the port to come out through the posterior flap. So you mark where exactly it needs to come out. Make an incision, pass a mosquito and get the arm through that, through the pericranium. So this distractor has these hooks at the the bone margin where it would engage properly, so it does not slip. And once the distractor position is ascertained, you can go ahead with your fixation. Fixation, we prefer using self-tapping screws instead of self-drilling, because self-drilling has their own number of complications, which we will discuss during the panel discussion. I would prefer at least 4 screws on either side for better fixation and stability. The same maneuver is done on the opposite side as well. The smallest drill, that is the 4 mm drill, is used, and since the thickness of bone is very less, you should always protect the brain from below. Once the distractor is fixed, always move it, activate and see whether the entire flap moves or not, or whether there's any part that is still holding. So you need to move the distractor a few millimeters, maybe 5 or 6 millimeters, and see whether the gap is created between the bone segments. Similar thing is done on the opposite side as well. This particular lock, it's there in Careless Modern Distractor, wherein you lock it, then you cannot reverse the distraction. So it's like basically if that lock is not there, there's a chance that the kid may play with that, or when the kid sleeps, the distraction can go behind. So when you put this lock, the distractor cannot go behind unless you release the lock. So once you have got the bone flap in contact, you lock it and then you close the incision. And this port should be visible outside the skin, because later on, if you want to reverse a distraction, you can always unlock it. That is one. Second thing is the arms are detachable. So after the course of distraction, how much you had to distract is over, distraction is over, you take out the arms and you can leave it, so that it does not project outside and it does not cause trauma or distractor breakage, etc. The bone dust can be placed in places where you feel that the defect is more, and a 2-layer closure is done. We get serial X-rays done just to understand the course of distraction, whether the distractor is moving. A lateral skull X-ray and a PA skull X-ray is the one which we use. Once you're done with distraction, always take out the arms, and we leave it for a period of at least 2.5 months of consolidation. Thank you so much. We leave it for 2.5 months.
Any questions?
So do you release the bone from the dura, like supposedly one we do in normal craniotomy?
No, only where the craniotomy is
allows
done.
easier. No, there's no need of that.
No.
Okay, it might allow easier distraction of the bone. No,
it's not required.
Okay.
Only where the craniotomy is done,
you release some part of the dura from the.
It has been released.
Okay,
Otherwise, it is not.
Okay.
You said you could go either above the torcula or below.
Below, yes.
But if you really want volumetric expansion, below would be always preferable. Right?
Yes, sir. It is better that we go below torcula, but then there are situations where if you have an
where
emissary,
you cannot do it for
but then
various
yes.
reasons, but otherwise. Yes.
Any comment about consolidation period by Dr. Dipesh, please?
Say consolidation period for the distractor removal. So these distractors do not work like the mid-face distractors or the mandibular distractors. You may be able to take them off early because the brain occupies the space. So if there is an indication for you to take off early, you can take it off early. But he's using it, I mean, they're keeping it for 2.5 months, that's all right. But because the brain occupies the space, there is a possibility of taking them out in 3 to 4 weeks also.
I just have 2 questions for you, Arjun, if you permit me.
Yes.
That's a nice presentation. The first one is regarding the step deformity when you do your distraction of posteriorly, and you're saying it should go inferiorly,
Correct.
isn't it?
Yes.
Now, there will be a step there.
Yes, there is a step which will remodel over a period of time.
No.
Which is something which we have always seen.
No, it never remolds unless you have to call, it's called as a hinging. What we suggest is we hinge it with the sutures.
But then we have seen that when the entire flap moves, at one point it will remodel. Even though there is a step that is created here, over a period of time that would remodel and it would take a good shape.
No, it never, especially if you're trying to.
Because in our series, I think we have done around 20-25 so far.
Because if you're doing it in very early, like, what you call 8 to 10 months or 12 months old.
Yes, sir.
But sometimes we do it a bit later, like, a year-old child or 2-year-old
little bit more,
child.
but that is
doesn't
also,
remodel.
we have seen it remodel
It's
because
been
of the
well
pressure.
documented, saying that especially you're doing anything about 12 months old, it's best is to hinge the posterior.
But then
inferior
we don't get that much of volume.
No,
then,
you get
sir.
the tilt up.
But
get a good
still,
tilt.
it would still not be as much as the entire
3 to
thing
4
moving.
centimeters you can do.
No, but the distractor itself is 2.5 centimeters that we get.
We can use a bit bigger distractors. We have in Synthesis nearly around 3 to 4 centimeters you can get.
We have used KLS so far, but that is I think the longest that we get is 2.5 centimeters.
In Synthesis you get around 3.5. That's something.
Okay.
One. And
but if you over distract, won't the skull become really big? I mean,
no, based upon what volume you
volume is required. Yes.
So that's how because so that you can get because you said volume, so
correct.
You can get more volume. 1. 2 is your suggestions and indications for using a piezo, especially when you're doing a smaller children, because you need to do a bar drill. Again, you need to put the bone dust so that you can go ahead and use a piezo for.
We haven't used piezo because we don't have a piezo for a cranial procedure. We have always used a craniotome. So, sir, would you want to say something with regard to that?
Yeah, I've seen piezo is very slow in its performance.
No, we have the 25 mH, which is quite adequate. We have
It's the patience.
And these, the bone is highly expendable in these children. So, I don't know. That's what I thought when they demoed it for us.
Because you have the Synthesis make again 25 mH, which is very powerful.
Okay, the Mectron.
The Mectron is marketed by Synthesis before.
Okay, so
which
this
is quite
very slow compared to our craniotome, you know.
Yeah, of course,
Only
because
the
you want
midline had to
hurry,
protect.
it's fine, but
Midline had to protect.
you can avoid all the, because basically again what happens,
Bone
the
dust and all.
bone dust and the
But in
hole
India,
sometimes
the
leaves.
babies which we operate PCVD, etc., they're infants. The bone is not an issue, and syndromic ones, bone is never an issue.
So we were feeling comfortable
yeah,
using
piezo. I've seen my colleagues from Europe, etc., using. They are very. I mean, that's a very popular.
These are the only two
concerns
I raised in your thing, but very well done. Thank you.
Thank you, sir.
Can I make a comment?
Yes, sir, please.
Regarding the consolidation period and Deepesh's comment. So brain expands, yes, but the biggest problem of brain expansion is it will not hold on the amount of expansion you have got. You have asked for 2.5 and the brain expansion will not hold it. So relapse is a very high issue when you have you can have a short consolidation period in infant, but you need to allow for bone growth to bridge that gap. Because so that the biggest point of the problem in the standard calvarial augmentation or advancement techniques was the relapse, and that is because we don't give enough space for bone to form.
So when you go back in 2.5 months or 3 months, do you actually feel bone between the gap?
Yes.
Yes, of course.
Bone?
We do
Yes,
see.
It's completely filled up with gaps.
Bone?
Yes.
Yes.
The same calvarial bone which is there on either side.
Which holds on.
That would bleed more also when you take out the
It is,
distractor.
yeah, like it is not yet bone. No,
No, but
is
then
not,
it is
not
hard.
bone.
It
It's
is
not a
hard.
ossified bone,
It is
it's a-
hard.
it's a-
Especially when you
it's a
go
callus.
into an
immature callus bone, immature bone,
Yes.
right? But it is
Unlike-
But then it is hard. It is hard when you take it out.
Unlike a brain which would relapse.
Of course, not it is.
So you won't get the 2.5 which distraction is meant for.
Yeah.
Thank you, sir. Sir.
Just thinking, would you consider barrel staving that portion below the lower cut before your distraction so that you avoid the step?
The inferior part, sir?
Yeah. Because then you avoid this problem of a step because you barrel stave it down.
But I think we usually take off the bone there for various reasons.
I think the only thing is anything below the tocula, I'm a bit worried when it's an infant.
Yeah, right.
So I do evenectomy and I'm not worried about the bone formation.
Oh, right. Okay.
So and the bone and the dura fills up very beautifully and no step at all.
What do you?
The thickness is more.
Yeah, thickness is more. Each of the handling is transmitted to the tocula and you don't know what happens and that's blind. So you don't want to take risk at all.
Any alternative if you don't have the good bone quality to put the distractor?
No, in that case, you can use self-drilling screws instead of tapping because once you drill a hole, then the hole becomes big. So it is better to use a self-drilling screw to just slowly fix the screw.
And you might even use a additional plate.
Yeah, additional plate to hold on to it, just in case if the bone is really thin, and during the course of distraction, it may actually, this infracture at the lambdoid or something like that, you can always span a plate to hold it there.
And that's where you have the Mercedes-Benz kind of pattern, where you have the open sutures.
Yeah.
That's where you have a more chance of the inward bend of the osteotomy segment. So you can span a plate to prevent that. Another thing is the kind of the distractor that you use. Now you have specific PCVD distractors which have the hooks on the side. So that will, in addition to the screws, the distractor hook will also hold on to it. So we don't usually see distractor dislodgement in the foot plate dislodgement. However soft the bone is, we don't see it loosening.
It's only the distractor breakage is what we have seen.
Since we use multiple times.
We have just done a couple of cases of springs for posterior cranial vault when we haven't been able to put distractors. That's a good alternative where we are very sure the whole skull is like filled with holes, and that kind of cases, springs has been very nice. We've just done 2 cases, mind you, so we don't know the long-term results.
Yeah, the same. We use our orthodontic wires, 1725 rectangular night tie wires, which is bent on table and put there, and the activation completes almost in 7 to 8 days. If you look at periodic X-rays, so maximum 10 days the activation is complete.
Nowadays we have commercially available springs also in India also.
Yeah, these are free. Yeah,
If there is a thumb printing, severe thumb printing, because of increased ICP, then obviously the part of the posterior vault which has to be expanded, the fixation of the footstep is then going to be a real problem, isn't it?
Yes, if it is very thin, yes. So in that case, like how Dr. Vaibhav mentioned, you can do springs. Yes.
Thank you, sir. We move on to the panel discussion on understanding hydrocephalus and Chiari in craniofacial syndromes, the role of PCVD. I invite Dr. Suhas Udaykumaran to moderate the session. I also invite the panelists for the session, Dr. Gosla Reddy, craniomaxillofacial surgeon, GSR Hospital, Hyderabad, Dr. Arjun Krishnadas, Dr. Anurag Sharma, Dr. Deepesh Rao, Dr. Ajay Sinha, neurosurgeon from Spire Liverpool Hospital, UK. He'll be joining us online. I also invite Dr. Sherry Peter to moderate the session.
So we'll just go into the details of it, more the same as the discussion which went on until now. Hydrocephalus, I think we are nearly clear that program is required, as anti-7 device is required, timing is an issue. I think that's it. Not much for discussion there. So I thought we'll delve on this aspect of use of PCVDs for any of these syndromic ones. So as you realized during the talk that the best aspect of distraction is a non-devascularizing operation for the cranial bones. So, and the standard place of PCVD in the algorithm is nearly clear in the literature. It can be used for the syndromic ones when you have signs of raised ICP, Chiari and hydrocephalus, and you have a classical posterior flattening or presence of brachycephaly. So you have an option of PCVD and an option of shunt, but you would prefer a PCVD because it's probably more functional. And all other situations you might play with PCVD plus or minus other procedures. So PCVD has a classical place in the algorithm. So I'll start off the panel discussion with the standard indications for PCVD in your practice. So you have syndromic situation, non-syndromic, and a non-synostotic. So I think I'll get all the panelists to opine on this. Syndromic, what is your segment of syndromics, and how do you choose on? And then the non-syndromic situations where you want to use PCVD, and the non-synostotic ones where you would prefer PCVD as an adjunct to your techniques. So these are 3 situations. The first one is a Cruzan, the second one is a brachycephaly, the third one is a craniocerebral disproportion secondary to shunt. So 3 different set of problems where PCVD can be applied in different ways.
Yeah, may I ask?
Yeah.
Yeah, especially in syndromic, it's quite indicated because mainly most of the syndromic is multicranial stenosis you have, and there is a very high chances of quite high rates of ICP there. So to reduce the immediately to get a good amount of movement posteriorly for a long term, I think posterior calvarial distraction is very indicated in syndromic.
Can you mention which syndrome which you're referring to?
Even if you take like a Cousins,
Yeah.
it's very indicated. And especially again in situations like we have trucephalus.
Upwards. Do you
Upwards.
want to use post PCVD in upwards?
Yeah, even in upwards you can use. And yes, sometimes we can even indicate both together with an FRO and a posterior calvarial distraction together in upwards. It's quite indicated. So it can manage both the optic compressions and also the reducing the ICP in these situations. Yeah, non-syndromic, I keep it indication mainly is for situations where there is an increase in ICP only, but otherwise for aesthetic purpose, I don't indicate a posterior calvarial distraction for non-syndromic.
So in syndromic patients, bicoronal craniosynostosis is secondary to syndromes. So in Appert's, Cousins, especially where there is posterior fossa crowding.
Again, upwards.
Upwards.
Upwards, you might have a lambda which is open. Which
Yes, depending on how breaky the child is and how much, if the child is also showing signs of raised ICP, it might be helpful to stage the procedure into having a posterior calvarial distraction and then do a formal FOIR later. So yes, in an APOT as well, in some situations, yes.
Amrita, you want to comment? Yes.
I'll just add that I think that hydrocephalus with Chiari is there. That is the time when I would actually want to go in, and Cousins and Appert is there. Clipetals we have also done in that, but non-syndromic I don't remember doing it for any non-syndromic case per se, posterior cranial wall distraction.
So if you look at the phenotype, Apert has a classical phenotype equivalent to a extreme brachycephaly, isn't it?
Correct.
Why don't you use it in non-syndromic ones?
No.
Non-syndromic brachycephaly. I'm talking about non-syndromic. I mean,
I'm saying I've not done it. It can be done.
If there's an increase in the ICP, that's again the brachycephaly. Then it is indicated because it's doing an FRO there. It can reduce the pressures and automatically young children it will remodel automatically. The anterior circumference gets remodeled, and especially if there is a severe exorbitism is noticed, the pressures are released and then the remodeling is quite high. In those situations, yes, but normally it is not indicated.
I think I'll open it to the audience to non-syndromic and PCVD. And so,
is there a role for a calvarial expansion versus a distraction in a non-syndromic? Because the quantum of problem is rather less
compared to
syndromic one.
Yeah. Any opinions on PCVD for non-syndromic? Extreme brachycephaly with turicephaly.
Whatever you do, you can't decrease the height.
Yeah.
So in brachycephaly with the increased height, posterior wall distraction is indicated.
Yes.
Even if it is non-syndromic.
I agree.
Yeah, when there is a raised ICP, right? So if the beaten copper appearance and I cannot do anterior, then probably I'll do posterior. That's what I'm saying.
I think with the extreme turicephaly, we find it. I find Pramod trying to put at least a 2 centimeters, 1.5 forwards, and you still have a completely brachycephalic head, which is, and with the turicephaly not being controlled.
Correct. So you want to give some more volume, then you do it on the back.
It worsens on follow up, because the turicephaly keeps going upward because everything is restricted still.
Correct.
Depends on the type of the calvarial remodeling. It would depend on the type of the calvarial remodeling. When you use, suppose you're saying a turicephalic head and you're not addressing the posterior and just doing an FOIR,
exactly.
Then it depends on the type of the calvarial remodeling that you're choosing. If you're using something where you're using the parietal bones to restructure the forehead, then you can address the turicephally at the same time because you're almost doing as STR, subtotal calvarial remodeling at that point of time. So it depends on the type of remodeling that you're using for FOIR.
The brain sitting like this, you think you can remodel it on table?
That I think because once you open up, doesn't the brain take its natural form as soon as you open up the whole
Posterior calvarium is not open.
posterior calvarium is not big. It depends on the extent at which
That
yes.
push is still there.
Right, true.
Don't you expect, when you do a posterior calvarial distraction and increase the volume, there are two choices of things. The remaining calvarium remodels. So in some cases, they say you don't have to do another remodeling procedure for the front. But in syndromic cases, the chances of with this reversal of the already set in juries and all those compensatory mechanisms doesn't fall back. So I think it's clinically, you see the response of the posterior calvarial. Remodeling happens or not happens. If it doesn't happen, then you already jump in and do something to correct it.
We have done quite a few Turicophiles, none of them with posterior calvarial distraction, but you have done a complete remodeling of the rest of the calvarium. So which includes anterior, posterior and sideways.
Yeah.
And that has given enough space to settle the Turi component as well. And as well, we haven't had to do the PCD in that.
So I think it's a difference in philosophy that in non-syndromics, PCVD has a place, but probably CVR is an option. I mean, unlike just an FOR, isn't it?
So would you overcorrect it to get that height down, or how is it?
See, once you will have to take out the strip of bone along the Turi component, and once you expand the rest, you just let the bone float. You're not fixing it back. It's the pressure of the scalp and the rest of the brain getting into the shape of the expanded calvarium. Eventually, you find that about 6 months to a year down the line, the head takes a normal shape and the Turi disappears. Not really, because you are leaving gaps of about couple of centimeters on either side. When you are barrel staving or even taking out the parietal bones and expanding it, you have huge gaps in between. So it doesn't reach the nose.
But you need to give some amount of fixation somewhere.
Not only in the central part, you don't need to. You allow the brain to take its position. In the rest of the place, as long as the skull is expanded in all the dimensions, it does. I can show some cases, so you'll see that actually it takes the shape. So I think, Deepesh, what you said is more or less what I said.
So I think after that, the non-synostotic indications, any of you would want to comment on it?
In Chiari malformations,
Classical Chiari in non-syndromic situation?
Yeah, not always.
Yeah.
So yeah.
Right.
So for me, it's train more in terms of FMD. I'll go and I'll do FMD too if I have to deal with that. Unless I feel that the posterior fossa is very small. I think FMD, I'm used to it. That will come in my mind first thing as to let me do and let me deal with it.
I have no experience in these things.
Anything from the audience? Anybody? Non-synostotic indications for PCVD? Yeah, I think I mean, as a general from the neurosurgical and the functional point of view, it can be an adjunct when you have raised ICP, extreme raised ICP in a well reasonably preserved child. It's an option. When you think you can play with the shape more comfortably rather than doing a cranioplasty or a cranectomy and more morbid procedures, this can be still an option when you have a slow. Second, other thing is like the shunt-induced secondary craniosynostosis, the craniocerebral disproportion. The last child is like that. A premature who had a shunt very early in life, they become flattened because of the shunt causing secondary synostosis. So here it's again an indication for classical PCVD as an option. Any other question? Any questions from the audience on the indications? So technique, as Dr. Arjun mentioned, multiple nuances of it: supratorcular versus subtorcular, with or without foramen magnum decompression, and the vector.
So one of the points I would like to make that recently in 2021, they published an article from the same group, Birmingham Bedded, where actually started using the posterior distractors at the first instance. And they stated that supratentorial supratentorial versus infratentorial, supratentorial eventually had a better outcome versus the infratentorial, despite the notion being that if you do infratent, you'll get better volume. It is ironically yet proven now that they have a better volume gain with the supratentorial. Comments? And this is their own series of patients of 54 odd patients, I think, wherein they have now seen that in some instances where they were not happy to go sub trochlear, not being able to do it because of reservations, they ended up doing it supra. And then in some cases they went infra, and then they've checked the same and they found that the volume gain, ironically in the supratentorial group, was more. And we keep saying that we should go as low as possible, but that might not hold good then.
I totally agree on that. It's not about the inferior most component that is involved. It's always about the distance it's going in the posterior in the superior component. The posterior superior movement gives you more volume, and the lower component, in fact, a lot of people now advise that leave it as it is with a hinge with sutures there, so that in fact putting it the cut as superior as possible to the supratentorial area. So that gives us more volume because of the shift, not about moving backwards as it is.
Martin was here also, he was mentioning the same thing, that they were seeing these cases and they were seeing probably the tenting effect was
increasing.
Yeah,
That been our observation as well, I'm not sure.
Yeah, supratentorial addresses the physiology equally.
There's a paper by Iris Mathesjan. I think she talks about a superiorly based clamshell osteotomy, and she claims the same thing, that the volume expansion is as much as torcular.
So then it is safer and better.
Yes.
To remain supratrochlear.
Yeah, but in the smallest, youngest ones, I do some calvarectomy, so the venous sinuses are exposed and decompressed probably, and I still get away with the older children. I still prefer angiogram and then decide on supra infra.
So as my training, we have always thought, training, I have not gone across this paper, that as much as you go down underneath, so we will take pains unless we have emissary venosum vessels, then only I will leave it. Till now, I think my practice would have been majorly to go as much down as possible, so that, when you go much more down, you probably create more. That's my understanding. The distance wise, you'll be able to create more distance, so you'll give more volume. I'll go through these papers and I'll see if my practice changes accordingly.
And the addition of foramen magnum decompression.
Yeah. So we are going down. So we always alongside, I'll always do the foramen magnum decompression if I'm able to take it down till that point of time. So obviously foramen magnum becomes widened.
So incision is biconal only.
Biconal, yes, sir.
Biconal, you go the foramen magnum decompression.
So we retract it down till the point, but we take out a drill and we nibble out. Last case we were able to do the foramen magnum also. Yeah.
So you include the posterior fossa decompression along with the foramen magnum decompression.
If I can reach, if I'm able to, feel the foramen magnum, I'll nibble out and I'll take out the bone from.
So don't you feel that the cerebellum will sag further down, as we have classically reading about it, that if foramen magnum decompression should just 2.5 centimeters. The larger is the defect on foramen magnum, the more the cerebellum is going to fall down. No, you never.
I never thought that much actually. I just thought that if I'm going to open up that space, if I'm going through foramen, I'm a little bit widening, because most of these cases also have carry, and the thought process would be to permit the CSF flow across the foramen magnum as well.
Yeah, but the literature says it should be small as possible, 2.5 centimeter.
Tight.
Still restricting.
So this is different from.
This is not the classical congenital. Yeah.
And the next is the vector, use of vectors. How do you, is everybody standard on that vector on inferior?
So that Dr. Arun will do. So depending on the vector, then you fix it.
The PCB distractors. Gently inferior and. Yeah.
When compared to that, the clamshell will be different. So you keep it a little low and fix it on the top. So you're clamshelling the whole thing up. So only the back, the lower part opens up, and the upper part stays more or less the same.
No, that is we try doing it going posteriorly.
Straight.
Yeah,
That
so
is, you don't want to change anything.
Change the shape, yeah, the height, yeah, you do the
Like another
clamshell.
yeah, inferior is when you want to drop the height, whereas this is possible when you don't, you're not just in the height alone. I think we are clear about this. I picked up some very different situations where you have a challenge of doing a PCVD. One is, as Sir mentioned, in between having a lacunar skull. And second is when you have a shunt in situ. And of course, with the additional technique like spraying. So lacunar skull, when you have a lacunar skull like this, how do you want to handle it? And you want to decide on PCVD or without.
We have the same situation, and that is why I asked.
Okay. Anybody wants to comment on?
Here, the problem is fixation.
Yeah.
So probably we can use the longer plates. We can modify the distractor with a long plate and use wherever the bone is there, hanging around to this fixation. This is definitely a challenge and doesn't have a textbook method to do.
You mean a customized distractor?
We could also do a posterior release. It's not necessary to do put a distractor. If you don't have a spring, for instance, and you just do a posterior release in the first stage, it tends to ossify afterwards, and then it is a good point to come back and put the distractor. But just disregarding the posterior release, which was done for many years before the PCVD came in, could be one of the options of you in such severe cases. Like Sir said, this is not a case where one size will fit all. The approaches will be different.
The disadvantage of that used to be that the child is lying on his back, and that is why the advancement was not more. But I agree with you because it's been done previously before.
Just do a large release and leave it, and then the posterior bit can ossify, and that might have you might have a chance to go back with a distractor at that point of time.
Maybe give a helmet. Bigger one so that it doesn't lie on that.
Yeah, that's an option. Oscillation is an option here.
Yes.
And the second option, which
Calvarectomy, huh?
Yeah, use of shunt in this scenario when you have this is hydrocephalus, so this is secondary to raised ICP. So when you use a shunt, the bone reforms very well.
Yes.
So again, you are taking a bite of the disadvantage of a shunt, but at the same time, that's an option in this situation. I mean, because the child is sick already.
Yes. See, we have a patient with clover lip. We have done FOR. We couldn't do a posterior wall distraction because of the poor quality of the bones. The head shape is very big, and we are not able to convince the neurosurgeons that the child needs a shunt. What they are saying is we'll not put shunt because it looks okay, and we, in spite of our repeated advice, they're not doing it, and the bony condition is not improving. I don't know what to do. Bony condition is not improving at all because there is an inward pressure.
I mean, this is one situation where probably you cannot get away from shunt. Unlike any other situations in neurosurgery, I would still be on the gentle front on the decision of shunt. Because these children are very, very sick. We need to move faster, especially in the functional period of life.
We have come out of that sick situation. The kid is doing well.
Okay.
Everything is okay. But the bony condition, the quality of bone is not improving at all.
We want to do a PCVD now. At the next stage, we are planning a PCVD at the next stage, but we still don't have good, bone quality to put the distraction.
So there might be one possibility of the situation is the hydrocephalus is still active. That's why the bone is not reforming.
We did open decompression, posterior wall, but it didn't work in a very good way like the posterior wall distraction was.
So this is the one with extra-axial cases, which one?
Same thing which I showed you.
Yeah. So direct evidence, so the bone quality is not good. I don't know if it's syndromic or not. My reservation was that the extra-axial spaces are still very well defined. And that extra axial spaces are very well defined. I was not comfortable that if we put a shunt there, how it is going to reduce the pressure, subduals will form, or already challenged, kid who are at risk, who is syndromic. So that's the reason I was not very convinced myself that putting a shunt is going to help. The bone is actually very bad.
So here the hydrocephalus is an additional element, that is the venous stenosis. So pericerebral collection is a part of expression of hydrocephalus. So because you have to agree that the CSF has to go into the one of the sinuses. So pericerebral collection is an expression of hydrocephalus in these children.
So we do have some amount of experience with springs. So in certain selected cases, because spring has just one entry point of fixture. So if you have some amount of stock just to hold one single pin on either side, we can still think of
Spring is
springs.
an option. This is one situation, and the second situation is when you don't have the distractors and you want to play with the finances. Spring is a very good adjunct, because these children we're not interested in the aesthetics especially the posterior calvarium.
Also, it is minimally invasive as well. Absolutely minimally invasive. Just to the strip craniectomy of the lambdoid sutures posteriorly, just like how we would do it with the endoscopic suturectomy, and then apply the springs. We went through the data of Great Ormond Street by published by Dr. Umesh Jilani, where they have done some 250 cases of spring-assisted posterior vault expansion, and only then we had the courage of trying it out in a lacunar skull kind of a situation. And the quality of the bone improved drastically, as it would improve even after with distraction as well.
Sometimes you might have, regarding springs, you might have a problem in actually locking it in. The bone quality is bad, but you could do a modification. You could put a mesh and lock the spring onto the mesh. So the advantage is the mesh will give you more coverage over the area. You can actually locate some areas where bone can be sort of put at least 1 or 2 screws. So that redistributes the force and then also the area. So you can find some area where you can put one small, at least 4 mm or 6 mm. So redistribute. But you have to make a lock on the mesh so that it just locks in. And when you want to remove it, you just unlock it and take it out. And that mesh sometimes can be even be left alone for a redistraction at another time so that you can go and lock back on again.
One more situation, and we have few minutes only left. A child with a shunt in situ, and you want to do PCVD.
Yeah, we'll go around, sir. We'll go around. We'll leave this part option.
Excluded.
We had similar kind of vision and we went down and left the
Sorry.
and we marked the posterior
anterior
to the curve.
Yeah.
Yeah, we marked the posterior flap.
Yeah. No, so we just went around the shunt. We just marked the craniotomy around. So just saving the shunt part bone, and we just rest of the procedure was the same.
Yes.
Yeah, did you ever shift the shunt?
Yeah, I did that once. I had to do that frontal because it was too.
Too much in the way of
exactly.
So if you can't go around, we can use a frontal one also. Yes.
But yeah, so that's what we did, a frontal and then repositioned it. And the one more direct situation is this gull winging, which is seen and when you have an open lambdoid when you do such situations. Any comments on this? This is the complication of PCVD secondary to the presence of open lambdoid in a child where we do craniocerebral. This is like, amongst the other complications, device failure, CSF leak, etc. I have many questions remaining, but yeah. I think this is coming up into the picture.
Here we really need to take a balance. Is this an aesthetic procedure or a functional? Here for us is the functional.
This child's aesthetic, sir. Okay. This is a craniocerebral disproportion secondary to shunt.
Then I think PCD is not indicated for aesthetic purpose there.
Why not?
Because we don't have the control of the bone formation there. The direction where it is
but
going.
It's extremely. You saw the child in the first picture, and it was completely flattened.
It's a difficult challenge.
Yeah. So these are one more situations where you find, and these are the complications. Gull winging. Yeah. So
they're difficult challenges.
Yeah. One of the last situations after this, we learned this. We spanned the plate across. I think in spite of more questions, I think we'll have to close the session here for lunch and because of time lag. Thank you. And we need to reconvene at 2 p.m. 2:15. Okay. 2:15. Thank you.
Thank you.
And all the panelists.
Keep a controller on the shunt if you want, because you don't want the shunt to be very active when you're doing the PCVD, no?
No.
So, because
Normal program shunt.
See, you have only two options. Either change the shunt to other place, or
See,
mark your anatomy accordingly.
the problem here in India is the cost associated. Everything which you add, it adds to the cost. And once you have, because the patients for 10,000 different, they will switch over to another hospital without, they don't care about the team, the care, about everything. So that limitation is a big
having
limitation.
said that, it's not always true, sir. Because at the end of the day, now the patients become that much more aware. So if they get the right team, the right environment. I think it's the
No.
first point of contact.
Some of them will come. How you convince them? If you tell them of this thing. It's very easy to convince international patient. It's very easy to convince international patient coming from out of Africa. Then to convince a patient coming out of Middle East.
See, we offer free treatment, and still patients are not sure because they like. Is it essential? Is it something that is important? Because my pediatrician is saying no problem.
So that another is a big gap.
they
We should go back
should be there
to.
here.
They should be here exactly in the morning. That's what I was saying.
Because
A pediatrician has to be here. They have to listen to this. They have to understand. They say it's not required.
Against the procedure. Some say that. Exactly.
मैं आपके लिए नहीं बोल रहा था, मैं वो PLK वाले के लिए बोल रहा हूँ।
अच्छा।
कन्विंस ही नहीं हो रहा है। Mother is a doctor. The baby's mother is a doctor.
मैं वही सोचा था, मैं जो एक पेशेंट जो था जो हमारा हैंगिंग में चल रहा है।
My kid will be shunt. Huge sum. वो आपको दिखाया था।
You can do it whatever you want. So from where I do, okay. This one, if you want, you can write it from here. Okay. ठीक है, and then I can do forward and backward from it. If you want, you can use this. I'll just check my video. Video is working. My presentation is tomorrow.
So we'll resume our sessions. We'll begin with panel discussion on challenges of multiple cranial procedures, balancing ICP with aesthetics. I request everybody to be seated. Kindly be seated. I invite Dr. Pramod Subhash, Professor and Head, Department of Craniomaxillofacial Surgery, Amrita Hospital, Kochi, to moderate the session. I also invite Dr. Subhash Konar, neurosurgeon from AIIMS Faridabad. Sorry, from NIMHANS Bangalore.
Hands, Mangalore. Panelists.
I invite all the panelists for the session. Dr. Anil Murarka, plastic reconstructive surgeon from Amrita Hospital, Faridabad. Dr. Suhas Udaykumaran, Dr. Dipesh Rao, and Dr. Stephen Wall, plastic reconstructive surgeon from Oxford, UK, who will be joining us online.
Who is missing here? Dr. Anil Murarka is, okay. So would you please join as well, sir? Would you please join? Yeah. Can you shift this slide? I would on the stream. We also have with us Mr. Stephen Wall, who is on the screen. He's joining us from Oxford. Dipesh, he worked, trained with him. Steve, thanks for joining. Can you hear?
Yep, you're welcome. Good to be here.
Yes, thank you so much for joining. So we will start off. Slide. Okay, we will start with a young child, known case of multisutural craniosynostosis with both ICP and mid-phase issues. She underwent a VP shunt in 2018, PCVD in 2019, as you can see on the slide. Then robot-assisted mid-phase distraction for her mid-phase issues, followed by, after that, she came back with raised ICP issues, and then again a decision to redo a PCVD was made, which was performed. And at the time of distractor removal, FOR was performed. Now, that's the course. She's 5 years of age now. She has had 2 episodes of recurrent globe subluxation. Recent ophthalmology consultation shows fundus examination, shows bilateral eye temporal pallor. Airway-wise, she is reasonably okay. She is reduced frequency URTI, which does not require hospitalization. The question is, what next? The first question to the panel would be...
Sorry to interrupt. I can't see any of the clinical photographs.
Did you see these?
Nope.
Can you check?
I'm looking at myself, unfortunately.
Can you shift the screen? See, ഇതിന്റെ പ്രോബ്ലം ആണോ? Where is my, can you? Can you see the slide now? Steve, hello.
Hi, I can see the plain white slide with your name on it, and I can see the photographs. Yep.
Okay. So that's the first one. Initial VP shunt followed by PCVD. Post mid phase, redo PCVD there. Now this is after the last procedure. So she has received 2 PCVDs, shunt 2 PCVDs and a FOR. Current presentation, she has eye signs. The pertinent questions that we would like to raise is one, what's the reason for sustained raised intracranial pressure? Suhas.
Subluxation itself may not mean raising.
But do you think
By itself.
do you think the pallor is significant?
Pallor might be an old pre-existing one. I still think we should be okay. We have a child who has.
It's not on.
Sorry. No, somebody has not heard. Raised ICP may not be an issue now because subluxation itself does not directly link to raised ICP always. There is an element of ICP when you see the first time, but you have treated it in different ways, isn't it? Airway, FOR, PCVD, multiple 2 PCVD, shunt in situ. I don't think it's ICP issue now.
Okay, so let's, if we assume that it's
Pure
an ICP. No, if we assume that, are we looking at, so we don't have to consider the ICP at all, or if we have to, how would you monitor?
With this scenario, I would keep it on the bottom.
But if you had to monitor, suppose.
Secondary.
Papilledema is, cannot be potent, isn't it? She has pallor already. Then maybe ICP monitor is the only option. So this is a gently difficult situation. In case I have to check on the ICP, I would have to monitor ICP.
So what kind of monitoring for the audience?
Intraparenchymal monitors are there. But only thing is in children, it's practically difficult to hold on the child with the intraparenchymal monitor. That's why we do not rely on this. A child with a monitor continuously being monitored is difficult, especially a 5-year-old.
Well, I can't say that I agree with that. We regularly monitor children invasively, and displacement of the pressure monitor in our experience is extremely uncommon.
Yeah, only thing is I would be worried about the discomfort of the child. So intraparenchymal is an option.
Would you?
And you're sure that your shunt is working?
Pardon?
Are you sure your shunt is working?
Yeah, that's the next question, that really the shunt is working or not, we have to confirm.
But you have an awake child, I still would keep that in the bottom of my priorities. Awake child with multiple procedures gone through.
So what are the other options? Let's assume that the shunt is patent.
ICP monitor.
ICP monitor. What other parameters would you consider, like
ONSD?
OSA?
ONSD, yeah. ONSD.
There's a surrogate marker for ICP.
Sheath diameter.
Sheath diameter.
Ultrasound based.
Basically, that is again the ICP.
In our experience, once you've had prolonged intracranial pressure, raised intracranial pressure, and you've got the eye signs present, it can take an enormous amount of time for them to resolve spontaneously or acceptably. So I think that monitoring in terms of fundoscopy is probably unreliable. What we tend to do here is obviously monitor the eye signs across longitudinally. If there's increase in signs, it then raises further questions. If there's a question of obstructive sleep apnea, what we tend to do is check the shunt and then consider raised intracranial pressure with a simultaneous sleep study, so that if you do have surges of raised pressure, you can check and see whether or not there is a link to the areas and periods of obstruction.
Yeah, exactly. Like we are also discussing in that way. Like we have to check the first shunt patency, and then the reason for secondary raised ICP is one is like venous hypertension. So we can see the skull base and then see is there any venous sinus stenosis or any venous obstruction anywhere, or you have to check that the child is still having OSA, some component of OSA that will cause a secondary raised ICP.
Is that what you would think if you rule out? You can, of course, other parameters that need to be considered, venous obstruction. But after PCVD, do you think it's possible?
Two PCVDs and you have a recent PCVD, I still think
it's unlikely.
And that too in a 5-year-old child, when you already have a brain which is fully grown or reasonably grown, I would gently keep still skeptical about the whole situation.
Okay.
Can I ask a question? What was the initial cerebral venogram? Was it normal?
Venogram?
No, we've not done it in this child.
Okay.
Infant, when we do PCVD, we do not do.
Yeah,
older children, yes.
We do venograms on all of our children, usually at the first stage of investigation. Yeah, with the syndromic children's, we want to know what the venous drainage is doing before we'd even consider doing a posterior distraction, because you sometimes have massive collaterals in the posterior skull, which then raises the question as to whether or not it would be better to do a lateral expansion rather than a posterior vault distraction. So we always document what the venous anatomy is.
For me, if you were to go back to the first slide, your very last point, which is OSA and venous problem, would be my first question actually, rather than raised ICP by itself as a primary cause. I think whatever ICT is there is secondary to either venous obstruction or OSA.
Okay. So,
I mean, you do have to take into account that you can still have craniocerebral disproportion. If the kids aren't growing and their brain continues to grow, they're going to get raised intracranial pressure independent of the venous drainage and the obstructive sleep apnea. You've got to be sure that the child's head is actually capable of growing. Otherwise, you're going to be locked into repetitive expansions. We've a number of cases where we've been forced to do a variety of expansions up to 7-8 times in one of our individuals who's now in his early 20s.
Okay. So we wouldn't do anything for the calvarium. We would look at other reasons. That's what consensus is. Okay, fine. Let's move on to. But now he looks like his skull is, there is definitely.
The volume must be like expansion must be good.
That's an assumption. He's only 5 years old, so you can still.
I think
may still have a disproportion. May still not have enough volume.
I think I'll definitely consider invasive ICP monitoring.
I
This
think,
is the gold standard.
Yeah, that's the gold standard.
yeah. I think from a stepwise point of view, if you have to prove whether you know there's going to be potential venous obstruction, but you can't really do anything about that. You've got to prove whether or not there is documented pressure present. You've got to make sure you can link it to the presence or absence of obstruction. And if he hasn't got significant obstruction and he's got venous hypertension or venous anomalies, but his head hasn't actually grown a lot, you're still going to have to do an expansion of some form.
Oh.
You would leave the calvareal expansion as a late option. If he's got obstructive apnea, you've got to address that, and that would either be through midfacial surgery or tracheostomy. Okay.
Would you be
Occasionally you can get away with CPAP, but they don't really tolerate it that well.
would we be
The other question is you've done 2 posterior vault distractions. What we would tend to do is do 1 posterior vault distraction and then a lateral expansion, because you've now got a young man who is quite substantially scaphocephalic, and if you want to do mid-facial advancement as a monoblock type procedure, you're going to make that even worse. So the question would be is whether or not on your second expansion operation, you either went to a monoblock distraction to start with, or you did a lateral expansion first.
So that's one way to consider aesthetics, because if you have to do another procedure here, it is going to become too long. So lateral expansion would definitely be a option if we consider aesthetics as well. Fine. So let's move to the next case. 6-year-old male Crouzon syndrome, again previously operated elsewhere with a strip craniectomy, then FOR at 2 years of age. Another Bandu reseparation, that's what the note said, at 3 years of age. And that's him at presentation with his skull like that. There's no papilledema, his eye is okay. That's his CT scan. Question, do we need to address the voids in cranium? Yes,
Can
sir.
I, okay, so I had a similar case several years ago. I had been operated for Crouzons who had been operated with the standard procedures, and even more significant bone loss than this. And I actually went in and did a rib grafting, which vanished after some time. And then we ended up putting a mesh because a lot of the brain was directly under the skin. Now, these patients are difficult to manage, but if the clinical issues are not significant, and they are able to protect themselves in terms of, avoiding physical activities where trauma is possible, I think you leave them alone. They're difficult to reconstruct. You will keep on reconstructing sometimes, and if there is a failure of an implant, you'll have to go back and make another peak or make another titanium implant, whatever you do.
So the question was
one-shot solution.
Yeah. So the question was also, do you actually need to do anything about the voids? Suhas. See so it's why these voids are there, 1, and 2. If you have to reconstruct it, is for 2 reasons. It's functional as well as aesthetic.
And protection.
Yeah, so protection, that's my question. Would you, if you are asked to choose, would you reconstruct?
We certainly wouldn't rush into doing a reconstruction. In our experience, there's actually a fairly significant rate of reossification in the late towards the sort of 8, 9, 10 years of age, even into the teens. Our tendency is to put in a helmet if we are concerned that the child is at risk itself. In other words, if there's other issues. And a standard healthy child, we have never had an injury due to a calvarial defect.
But at the same time, primarily, I would rule out an element of ICP which is remaining, because that's very important, probably an important fact that might not allow reossification.
So that's the next question. Are there any signs of raised ICP here? Because the fundus is normal. You saw the scan.
The big question would be, is the child's head shape changing in an unacceptable manner? In our experience, if you've got a child with ongoing raised intracranial pressure, they would tend to have a significant bulge through the defects, and the skull would tend to grow in the path of least resistance. So they tend to prolapse through the defects, and you obviously have an indication that there's an ongoing issue. If they've got a soft defect that's not bulging, the chance of there being significant raised intracranial pressure must be very low.
So if we have to reconstruct this for a aesthetic reason, then what would we do? You said you would rather leave them alone.
Leave them alone and wait for if they are old enough, you can do a
Redo procedure, yes.
I'd agree with that.
I'll protect for a few more years and maybe later we'll reconstruct, and with the autogenous tissue.
Do you think the initial procedure, if you look at the scan, the initial procedure has addressed only a very small part of the anterior cranium, where it looks like a more of a multisutural or a pansynostosis, and that, you know, the doing a TCR, an anterior part has been done, and that could be the reason why the sustained pressure has pushed the brain forward. So if you have to do a second procedure, you would create a neo forehead from the posterior by doing a TCR? Total calveolar remodeling, Dipesh? Is that what you would think?
So I will agree to everybody that we would not touch him if not required. But now to assume what has happened in the first or two procedures is going to be very tricky in this, what is left behind. But if we have to intervene, then yes, you can do the remodeling like you're suggesting. If we are going to intervene and do something, then that would be the opportune time to remodel using the parietal bones for the neo forehead. But that's something that if you are addressing, if the child has raised ICP, the fundi were not abnormal, and you want to try to do a remodeling, then that would be something that we could choose. But otherwise, just wait and watch.
Mr. Paul, if you had to operate for an aesthetic reason, when would you operate?
I wouldn't do anything for an aesthetic reason. A child is still at risk of raised intracranial pressure and might need any surgery. I think that the aim is to keep the child safe and then see how things go. I think to go and do a highly complex reconstruction in a child when you're not too sure which way they're going to grow, we're not doing aesthetic surgery, we're doing functional surgery. If we can get an aesthetic benefit at the time that the child needs a formal functional procedure, then you would do it, as you said earlier, using the lateral panels to create a near forehead, remodeling the front and giving a significant lateral expansion. Would be the way that I would do it, but I certainly wouldn't do it just because of the way the child looks.
Okay. Any questions from the audience about this case?
Pramod, can I comment?
Yep.
Looking at his configuration, the phenotype, and he being a cruising genotype, you consider both of these, he's a high risk for some element of hydrocephalus at any point of time. He being a young child. I would still keep that option open, including consider PCVD at this stage too, and then look at forehead later, as others pointed out. But PCVD is still an option if, let's say, OSA is ruled out too. If OSA is not ruled out, work on OSA first and redecide this later again.
Okay. Okay. So did you get that? What Suhas meant is if he wouldn't rule out ICP, so he would look at OSA, which can be a contributor to the ICP, and if OSA is ruled out because of mid-phase, then you would consider PCVD. Okay.
Well, if the child doesn't have raised intracranial pressure, there's no indication for doing any calvarial surgery.
Yes, that point is taken.
And then if you have got documented raised intracranial pressure and you need to do some form of calvarial expansion, then I would choose the one that would give you the best aesthetic outcome. And I'm not entirely sure with the length of the child's head at the moment whether a posterior vault distraction would improve things. From an aesthetic point of view, it would probably make it worse.
What is the reason for
the bossing?
What's the reason for loss of bone? Any speculations
being a syndromic child, normally we see so much of bone formation. And then what is the reason in this case there is so much of bone loss?
That was my question too. What's the reason?
Do you know what the mutation is?
Cruzon.
Which one?
FGFR.
Because there are multiple genetic mutations giving you the phenotype of Cruzons, and a lot of them seem to behave in a slightly different way. There's differences in their ossification. There's differences in their hydrocephalic rate. So we are fortunate enough to be able to know exactly what the mutations are, and we can then predict on the basis of our other patients over the years what the likely outcome in terms of the bone healing would be. But you know, it is important, if at all possible, to document the exact mutation. It does have an outcome predictor attached to it.
Okay, I think that's something we should look at, definitely. So, how much time are we left with? What's the time? 5 minutes. Okay, if we can quickly go through this case. Another child, 14 years old. When he presented, was he 14? Yes. Bichronal synostosis and SAG. It's a multisutural synostosis. Operated at age of 6 months, and again FOR at 1.5 years. Now, see, he has a very thin scalp. Why is it that not every patient that you see very thin scalp, and in some kids you see very thin scalp? Is it because we take the pericranium away? Dr. Shibu?
No, we routinely elevate the pericranium from the bone, and it doesn't appear to have any effect on the scalp. So we do our scalp dissection supraperiosteal, and then we take the periosteum off the bone as well. That can be used to redrape various areas, and certainly in anterior skull surgery to line the anterior fossa. But I don't think that lifting the periosteum from the bone or discarding the periosteum has any effect on the scalp itself.
So this boy was taken up for aesthetic reasons, for calvural remodeling. And the question is, how do you manage these voids? As a surgical tip, if you have to, what are the options? Dipesh?
Options of closing the voids.
Yeah. And deformity correction, basically augmentation and everything.
Bone defect and.
So the bone defect, I think whenever possible, if you're doing a formal remodeling, you have to be able to get the right construct in the right place, and then share the load in the parietal area. So if you're looking at getting your forehead corrected, you use a stronger construct which devoid of any holes for the forehead, and then share the load behind that area. So that is something that you can do based on what bone you have available. So design your forehead and then share the load behind in the parietal area.
What we do is we use the bone dust and also try to fill the void.
Yes, you can use bone dust, but sometimes, I guess it is about how well you share the blocks properly rather than having larger gaps.
How old is the patient?
He was 11 at that time.
Which means you will not have enough room to leave behind those.
Could you not wait and do something a little later?
At 14 or 18?
Yeah, 15,
The problem was the child was brought with psychosocial issues at that time from school, parents demanding procedure at that point in time. This is
I think
him.
you've got to be careful about whether you're operating for the parents or for the child. If you've got a child who's got a normal intellectual ability, I think you should wait until the child is old enough to make the decision for themselves. I really think doing aesthetic surgery for the benefit of the parents is not a great concept from my point of view.
It was the child concern that was transferred by the parents at school. It was not the parents alone. But I do take your point that we shouldn't be operating for the parents' concern. But what time would you operate this child if it was no functional problems, only aesthetics? 18? Sir, when would you operate?
See, if you go back to the picture again, I would have thought of addressing the midface in the lower jaw. From the, not this, the clinical picture. Oh, you're not talking about the other picture that you said?
No, this one.
Okay,
this boy.
Okay.
That's him now.
So you had a profile picture of this guy?
His midface and mandible was okay, sir. He had a facial scoliosis.
So I would wait till 17, 18. Because he's going to lose more bone, probably.
Why?
No, some patients lose bone. I don't have an answer for that, but I've seen patients lose bone.
Is it worth considering virtual surgical planning? Because we are doing it for aesthetic reason. Virtual surgical planning, proper, absolute meticulous planning, and then use autologous bone from. We should wait for some more years and then use autologous bone from other parts of the body and do it absolutely like in a proper way. Because we are doing it for aesthetic reason.
I think there's a couple of elements. The one is that if you believe you have to do something and only use his own bone, then you could argue that the earlier you do it, the more chance you've got of getting spontaneous healing of any bone gaps that you leave. The aim would be to try and make the bone gaps in individual areas as small as physically possible. There are a number of osteotomy techniques, one known as Hendel's technique, which is interlocking cuts, to expand the bone, and you effectively can stretch it, leaving interlocking smaller defects that have a much higher chance of healing, or giving you structural stability that even if they don't heal, there is no single large defect. The disadvantage of waiting until they are 18 or 19, the advantage would be you could theoretically split the bone more easily, it might be thicker. The disadvantage is there seems to be a quite more significant resorption of bone in the adult population. If you look at cranioplasty work, etc., you could argue the fact that what you should do is wait until the child is old enough that you can safely put in an alloplastic implant. There is a role for that as well in a child whose growth is finished. There's some work being done on early alloplastic implants using PEEK or other similar material, but we don't have a huge experience of that.
Right. I think it's time that we wind up, and I hope that was informative. Mr. Walt, as usual, your inputs are always very good, very informative. Thank you so much for joining us on a holiday, and have a nice day. Thank you.
Thank you very much. It's been a pleasure.
Thank you so much. Thanks, panelists, and we shall move to the next panel.
Thank you, Dr. Pramod. Thank you, Dr. Subhash, and all the panelists for the insightful session. Next session is an overview of orbit and airway in craniofacial syndromes by Dr. Shibani Nerukar, Assistant Professor, Department of Craniomaxillofacial Surgery, Amrita Hospital, Kochi.
Okay, like that is it. So I'm just going to give an overview of the orbit and the airway anatomy in craniofacial or craniosynostosis cases. So basically the orbit and the midface is influenced, growth is influenced by major sutures, minor sutures, and its primary growth potential. Craniosynostosis basically results in midface hypoplasia. It's just that the degree and the deformity varies according to the suture involved. We know as per the Virchow's principle, the growth is restricted perpendicular to the growth of perpendicular to the suture. So if we have to see how each of these sutures actually influence the growth of the midface, to start with the unilateral coronal synostosis, to be specific, the frontoparietal suture synostosis, basically restricts the growth of the frontal and the parietal bone perpendicular to the suture. Now this results in retropositioning of the frontal bone in that on the involved side. Also, the endocranium is deviated towards the involved or the ipsilateral side. To compensate for this, the frontosphenoid suture would grow and would result in something called as Harlequin deformity, which is seen on an X-ray, and that is caused because of increase that results in increase in the height of the orbital of the orbit. So on clinical presentation, this patient will usually have a superiorly and posteriorly positioned supraorbital rim and the frontal bone, and the eyebrow on the affected side is raised, retropositioned. It also has an effect on the zygoma and the maxilla on the involved side, which is also retropositioned. When there is involvement of the frontosphenoidal suture only, in that case, what happens is the endocranium is actually deflected towards the opposite side, and with the retropositioning of the frontal bone onto the affected side. This is opposite to what happens in coronal suture synostosis. With the involvement of both the frontoparietal and the frontosphenoidal suture synostosis, there is reduced verticalization of the orbit with increased retropositioning of the frontal bone. Along with this, there's also altered positioning, alteration in the globe axis, which results in altered head position clinically. On clinical presentation, the patient will basically come with an altered head position. Along with the increase in, there'll be more, the roof of the orbit will be more smaller. For frontonasal suture synostosis, frontonasal suture synostosis will result in restriction of the nasal bone, and the root of the nose is deviated towards the affected side. So clinically, the patient will have the nasal root, which will be deviated towards the affected side. With the splenotemporal suture involvement, there is restriction of the growth of the temporal bone posteriorly. So what happens is the glenoid fossa will be positioned more anteriorly onto the affected side. As the mandible grows normally, what will happen is the mandible will continue to grow and deviate the chin towards the contralateral side. So there'll be a scoliosis of the face. For sagittal suture synostosis, there's a decrease in the transverse dimension of the face. Metopic and intranasal and nasomaxillary suture synostosis causes midline ridging and there is hypotaylorism. However, with frontonasal synostosis, there will be hypertaylorism, which will be seen. For the spleno-occipital and the spleno-ethmoidal suture synostosis, there's literature which shows that there's decrease. This is basically going to reduce the cranial base length and then subsequently cause midface hypoplasia. So this is how each individual suture would actually influence the midface, but when it comes to syndromes and multisutural synostosis, both major and minor sutures are involved in varying degree. So just to summarize, if we have to see the most commonly seen sutures, commonly seen syndromes, these are the clinical features which they usually present with. So the cranial base will be shorter, the posterior cranial base will be shorter and anteriorly positioned. The orbit, roof and the floor length will be reduced. The orbital floor will be sloping downwards. The lateral orbital wall is positioned posteriorly. There is reduced orbital volume, hypertaylorism, and in Apert syndrome, the roof and the lateral orbital wall bulges into the orbital cavity. The zygoma is again retropositioned, smaller in all dimensions. There is increase in the bizygomatic width. In Apert syndrome, the zygoma is more deformed. For the maxilla is retropositioned. There is transverse dimension is usually increased, but the anterior, posterior, and the vertical dimension is decreased. It may be associated with cleft palate, which may cause the maxillary arch to collapse. So the arches will be constricted, and patient may have an anterior open bite. They may even have a high arch palate with a long soft palate. So the consequences of these are basically that from ophthalmological point of view, they'll have an incomplete eye closure, reduced globe support, exposure keratitis, exorbitism, globe subluxation, and strabismus. And for the airway, the patient will have a reduced airway volume, subsequently increased respiratory effort, obstructive sleep apnea, recurrent URTI, reduced weight gain, compromised growth, delayed milestone. They'll have a skeletal class 3 deformity and malocclusion. That's it. Thank you.
Thank you, Dr. Shibani. We move on to the last panel discussion for the day on improving midface aesthetics in adolescents and adults. I invite Dr. Krishna Sharma Rao to moderate the session. I also invite the esteemed panelists for the session, Dr. Mustafa Khader, oral maxillofacial surgeon from Yenapoya Hospital, Mangalore, Dr. Moti Haslan, craniomaxillofacial surgeon from Glasgow, UK, who will be joining us online. I also invite Dr. Gosla Reddy, Dr. Pramod Subhash, and Dr. Anil Murarka.
Moose.
Say hi to
Murthy, yeah. Is Murthy on? So in the interest of the neurosurgical friends whom I do not wish that they go to sleep in this particular topic, this will be mid-face in relation to craniofacial. I have already loaded. I hope they have it. Hi Murthy. Can you hear me? I think he's on mute.
You are muted. You have to unmute yourself. Can we unmute from this side? നമുക്ക് unmute ചെയ്യാൻ പറ്റുമോ?
Hi there, can you hear me?
Yeah.
Great to have you, Murthy. So Dr. Murthy Hasnad is a craniomaxillofacial surgeon in the UK, and he's been a frequent visitor to our country and a great champion of craniofacial surgery. Welcome, Murthy.
Thank you.
So we are discussing, where's the first slide? So Dr. Mustafa is here. So now this is the right time to start the show.
Sir, if I could say a sentence,
Sure.
Since you said the neurosurgeons may go to sleep, but I request them not to go to sleep.
That's what I made. I have kept cases that would interest them as much as a maxillofacial or a plastic surgeon.
Sir, it's a craniofacial,
yes.
so we cannot separate it.
Yes,
So it's
yes.
integral that you have as much awareness. Like we try to learn about hydrocephalus and functional things.
So this young man first presented to me about 12 years ago, unoperated croussons with raised intracranial pressure and several complications, as you can see, of the eye and mid-face, sleep apnea and everything else. At that time, we did a frontoorbital advancement and cranial vault remodeling. and called him back after a few years. He lives actually in Bengal, somewhere in one of the districts very far away from Kolkata. And he then came to us with this. So what would you do, Dr. Mustafa? I should keep him for the last now because he would give us the final answer. We'll start from Srinivas.
Sleeping off.
Yeah, should
thank
know
you.
whom to catch.
Yeah. First is we need to get a proper ophthalmological evaluation to know the status, what is exactly happening. It looks like probably there's no vision on the right side. It looks more, can't make out.
There is very minimal vision on both eyes, but it's just enough for the patient to, go to the bathroom, go around the house.
Yeah. Do you have any of his radiographs, the CT scans?
Nothing. I'm
Only
not
the-
showing any of that.
Only the pictures.
Yeah, only the picture.
And does he have any still increased in ICP?
There was, and which was corrected because he had a VP shunt put and he had a frontorbital advancement done. But he still has significant exorbitism. He has midface hypoplasia. And
So no, the concern is only about aesthetics.
yeah, concern is midface.
Oh, midface, no. Then at least a good Leaford 3 to start with, and a combination of Leaford 1 if needed, also based upon his occlusion, same time.
Okay. And
Here we are not discussing anything about the orbits.
no, we are discussing the orbit only as a incidental thing because it's part of the midface, and the midface is involved in supporting the eyeball.
Then Leaford 3 with a Leaford 1.
Yeah. Okay. Anybody else?
And also of the mandible based upon the self and everything.
Pramod?
It depends upon their commitment, sir. If they have neglected the boy, and he would need a lot of things. So if you're looking only at aesthetics, considering that, his vision is whatever is lost, but we have to retain what is present and make him presentable. Then we have to consider all aspects. We have to consider his airway, we have to consider his occlusion, we have to consider the fact whether his dentition are present or not, whether they are willing to undergo orthodontics. So all these parameters put together and with investigations, we have to go forward to make a plan, which would mean addressing the midface.
So basically, the parents are very loving, but they were very scared of treating him, and they couldn't. Somewhere in Calcutta, they were told that it shouldn't be done or something, and they avoided surgery for years and years. So he is presented very late. So this is not a common presentation. The reason I show this is we have to bring it to a level where we have got clefts today, that we get them as newborns rather than adults unoperated. So he is practically a young adult unoperated. So we did do a Leaford 3 and we also had to reconstruct his lower eyelid, and it reduced his OSA. This is what he looks like. This is from about 3 months ago.
Looks good.
He comes to Bangalore once in about 5 to 10 years. Yeah.
What did we achieve?
See, the main thing is you need the parents would like him to live as long as possible. I think from a parent's point of view, it's very good because his sleep apnea itself would lead to issues. He will be dependent for a long time on his parents or the society, but that doesn't mean he doesn't have a right to survival.
Like if you look into the risk cost benefit ratio, what all things we have achieved?
I think he's been alive for 11 years because of the OSA being treated, and further damage to the eye has been prevented for the time being. Beyond that, nothing else, which is why I'm putting it to the panel.
Do you think still his orbits are shallow?
Yes, they're still shallow, but much better than before. Yes.
Why I'm asking is still his supraorbital rim looks.
Yeah, supraorbital rim and infraorbital rim both are a little shallow.
Yeah.
Yeah.
So I mean, if you're thinking in terms of protecting the eye to some
Mhm.
extent, because he could navigate. Okay. So we have improved, but it's not ideal.
So what else will we do now?
Yeah, like again here we need to ask ourselves is the question is it only the aesthetics we are looking at?
Mike, please.
Is it only the aesthetics we are looking at?
Functionally now he is almost as good as he can get. I don't think he can get any better than this functionally. He will be a dependent on society. However, he has a right to live.
So from the first picture to the second picture, what is the age difference?
It's about 7-8 years or a little longer.
Yeah, one is he lost his youthful look phase, what it is to be before. The multiple reasons there could be. Second is his total nasal bridge is collapsed.
Correct.
He's lost his nasal anatomy totally in all dimensions, and he has a severe teeth show because his vertical excess of the maxilla is seen, and then he looks like a very retruded chin, and we can see the double chin more of. So there are a lot of other factors involved. Now, what all you would like to do more to make him more beautifully? This is what we need to ask.
Can I?
Yeah, please.
Now, the first important question is whether this patient needs to be addressed or not. That's the fundamental question. And the right for aesthetics is equal to everybody, whether he is blind, whether he is mentally stable or unstable. Ethically, you can't ask that question, does he deserve to be aesthetically better? Which is the question I cannot ask. Or rather, I would put it, I cannot deny. Now, in certain instances, the decision making is not the patient, but the patient's parents. Now, if the patient's parents are insisting that my child, whether he is very young, adolescent, or grown up, requires better aesthetics, then the onus is on professionals to provide that. So that is my viewpoint in terms of decision making. Now, in terms of what should be done in order to improve the aesthetics, because when you're improving the aesthetics, it also has a direct bearing on the function. Now, in this case, I'm sure the airway may have improved because you have done a mid-face advancement. Now, how to do it may vary from me to him to the rest of the panelists. Now, what I would do in a case like this is I would evaluate the patient thoroughly with the help of a CT scan and decide how much of mid-face advancement is required in order to get better aesthetics, in order to make sure that the globe is adequately supported, and whether it requires an en bloc advancement to the mid-face or whether it has to be sequential. When I say that, what I mean is whether it requires a uniplanar or a biplanar. For example, when you do an en bloc advancement of the mid-face, by say, if at point A it is 30 millimeter, and if you advance the entire mid-face by 30 millimeter, they may be aesthetically very displeasing. So that I would evaluate. So probably I would do a biplanar distraction or maybe a multiplanar, depending on the CT evaluation and a VSP if required. And I would also take into consideration the lower face because I want to get a balanced face, not just the mid face. The focus, if you are looking into aesthetics, you cannot just look into the mid face and say, I'll correct the mid face and patient will look good. Patient will not look good. The idea should be a balanced face in order to achieve good aesthetics. That's my limited contribution.
Pramod? Murthy? I can't see Murthy.
Murthy.
Can you hear me okay?
Hi, Murthy, yeah.
So, I'm sorry, I'm sitting in a different kind of a system where the complete craniofacial, services run on a state-funded healthcare system, and the benefits and disadvantages exist in both systems. But whenever I sort of come across this type of an adult untreated from early age, now we are reached a stage where the possibilities are quite limited in achieving those ideal goals. So something like I know I'm probably comparing incorrectly. In an oncology meeting, we are talking about placing implant, dental rehabilitation when somebody's life's expectancy is bit limited. I mean, that I feel a little bit to that extent. A patient who's syndromic and reached adulthood with not much done in the early age, or maybe lack of system in place where we reached this situation. So achieving aesthetics, I mean, he's an adult. I mean, from our UK healthcare system wise, it's the adult who makes the decision. So it's completely sort of, we have to take patient's view, and I didn't get it. If what was that patient wanted for this treatment, disregarding parental point of view at side. I know that it's important, even though he's an adult, but he's probably more looked after an adult rather than completely independent living. So may I ask what was his concern in this case?
He wants to just be able to do his activities of daily living. He is not expecting that he'll go to work for a job, because he has not been in school for a very long time, and he is not expecting to be a professional earning member, but he wants to live.
So, I mean, in what way his activities of daily living was impaired with this pre-surgical status?
His eye was getting worse, and he was going to be completely blind probably very shortly.
Yeah, I mean, no matter, I mean, exposure, conjunctival exposure, that may lead to, so that would be my main aim. What you have done is to, I mean, it's almost like you have not touched his supraorbital rim. So it's a subcranial LIFO 3 advancement. And I agree with Mustafa that if you completely advance disregarding the dental occlusion, then you will have completely, appearance may worsen. So you may have to modify for the correction or protection of the globe, X amount of advancement of the orbital floor component, and then maybe LIFO 3 with the simultaneous LIFO 1 if if there was no pre-existing scar tissue, etc. It looks like you had done a previous LIFO 3 number of years ago, so that may be bit dangerous, because you could actually lose the LIFO 1 segment. But if it is all favorable, then you could do a simultaneous LIFO 3, get the globe protection, and then a LIFO 1, maybe less of an advancement. So you could do that. That would be, and also I think I've actually come across in Cruzones in particular, constant pressure of the globe does actually stretch the lower eyelid excessively. So when you actually bring their bony component forward, there is a lag of thalamus, almost like you need almost lateral tarsal strip and canthopexy. That would actually achieve much aesthetically pleasing and also functionally better eyelid competency. That's what I would actually do.
So now we have come to a LIFO 1 osteotomy, maybe mandibular osteotomy, maybe, and some eyelid work. I think that's the least we can offer him.
His lower eyelids are not very well supported,
Mhm.
and his malar areas are looking very like hyperplastic. We can consider augmenting that area, and we can do rhinoplasty also.
Yeah, you can do rhinoplasty, genioplasty, and all those things.
See, if you put some implant to support his lower eyelid, then that will improve his malar area also, and that will support his lower eyelid. So he'll look much better with that, and his eye will be more supported.
The reason this is put as every patient, I believe, has a right to live and live to the best of his ability. I think patient must come first. We cannot have the most ideal situation, especially in the setting that we are in India. Not all patients come to us at the right age. Not all patients come to us who can be perfectly treated. I think if you understand that there are limitations to what you can do, you will be a better craniofacial surgeon than if you think that everything should be corrected, and if it's not ideal, then it's not enough. I don't know. What do you say? Pramod? Yeah, Pramod.
What drives me, at least, all these craniofacial cases, what we do is we have to get them as close to perfect as possible. Of course, there are situations when it is not possible. But if there is nothing stopping us from doing it, if the parents are supportive, if the child is wants it, and if it is only dependent on us to do that, then I would do it.
Everybody agree? Vaibhav?
I have some major reservations regarding speaking about aesthetics in this particular patient, because I feel aesthetics is visual. He has minimal vision. I don't think he can even look at the mirror to assess his own appearance. And when Murthy mentioned about consent coming from an adult, I think that stands worldwide, need not stand to any particular system, and we shouldn't be bullied into doing something which we feel that it's not appropriate, or the patient feels that he doesn't need it. If he hasn't demanded anything regarding appearance, I don't think we should be doing anything about the appearance. The only indication for this patient is probably OSA, as you have rightly addressed that with the liphoton, and the support for the eyeballs. That's the only thing I would do, and I'd stop at that. But I will continue conversing with the patient himself and not anybody else.
Yeah,
honestly, if I'm given an option, unless it's a functional issue in these sort of things, then only I would address the issues. If it's for aesthetics, I don't think I would, at least I would not feel like my heart will not say, let's trying to do something, make him beautiful. Because whatever you try to do, you may not get him any aesthetics in this. Aesthetics has a definition, a defined role. Whatever you do, it may not satisfy anyone. So I don't think we can ever satisfy this person in any way, or even his parents or anyone. So trying to put a patient under knife for aesthetic purpose in this sort of situation, I don't think at least I could take over.
Can I ask a question, sir? I would like to know the IQ of the patient. First
Okay,
of all.
so
I mean, average.
He's he doesn't have a score of 131,
Yeah,
but,
then
he
average
doesn't have a
intelligence-
score of 70 or 80 either.
So he has an average intelligence.
He is very average intelligence.
Yeah.
He is not challenged
Yeah.
in that
Well,
sense.
I'm not asking this question for a bias. I'm just asking because I would like to know how much he understands that what procedures can be done to improve his.
No, you can talk to him. So,
Yeah.
it's possible to converse with him.
Yeah.
Though he speaks in Bengali and you need a translator, but
Right.
it's possible to converse with him. It's possible to converse with his family. And he basically just wants to carry on his
daily activity.
Yeah.
So I'm saying that aesthetic outcome that we are talking about is not purely cosmesis in the sense.
Yeah.
I think there is a psychosocial factor behind it, the general morale, the self-confidence of the patient. I think these all should be considered under functional outcome rather than just pure
Correct,
aesthetics.
yeah.
So I think that's one important factor to be taken care of when
So
we
the
are doing it.
psychosocial
So I think it still
and
would
the
go for it.
patient and the family, actually they don't want any more surgery, not because they're scared of it. They're quite happy with what they've got. So I'm not pushing them. In fact, they sent me some pictures yesterday as well. So they are in touch with me regularly.
Yeah, we should not be deciding about that, what they want. If they are like requesting us to improve, we should be I'll give you a small example. We had a child around 7 or 8 girl child, from a Muslim family from Saudi Arabia, doctor parents, and not at all normal. Had a like severity, hypertolerism grade 3. And they came to us, and with other comorbidities also. And they came to us, doctor, I want my kid to be improved. And I mean, in that case, would you be saying, why do you want to get this surgeries done? You know, there is so much of complexities involved in surgery. It's such a like complex surgery. Your child can die also. And the last, you'll say like there are a lot of like finances involved also. We explained everything. And in spite of that, doctor parents, I am quoting again, doctor parents, they said, no, I want my child to be better than what she is now. It's not the patient only, it's the parents or it's the family also. They don't have any social life. They can't leave the child at home and go. If they have to carry that child to the society or to the market, they can't do that. So we have to like make the child or make the patient to some extent presentable. I am not saying that he should be Shah Rukh Khan or Amitabh Bachchan, but at least presentable we should be, if they are asking. We're not forcing them to get the surgery done.
Yeah.
There's an old saying that beauty lies in the eyes of the beholder. So who is the beholder? The beholder is not you yourself. The beholder is the one who is looking at you. So therefore, as Dr. Moraka pointed out, it is incumbent on the parents that their child looks good, and every parent would want that. And when the child is not able to take the decision themselves, the responsibility falls on the parents, and they would take the decision. And if they are for it and they are giving you a consent, and I think in this particular case, the patient is understanding things reasonably, may not be very intelligently, but he's able to understand now, for example, that he's going to undergo the surgery he's well aware of. Yes?
Absolutely.
So that being the case, I don't think so his aesthetic component should be denied to him. Now, look at it from your own point of view. If you have a child of that nature or who has a similar thing, wouldn't you want your child to look better? I think the answer would predominantly be yes. I don't think so you would deny your own child. But of course, there are a lot of ethical issues here. I'm not denying that. But then the simple answer is now an 11-year-old kid with a severe cleft midface hypoplasia, who makes the decision? Does the child say, I want a midface distraction? No, it's the parents who make the decision. So I think it's fine. This is my argument. You can disagree.
So can I ask one question to Dr. Sujitra? Ma'am, you saw the first photograph. Do you think both the globes were subluxated in that, and that was chemosis from the subluxation that we saw?
Yes.
It could have been a transient thing? Or
not transient, it's quite chronically.
Recurrent, but...
Recurrent, yeah. Right eye is more damaged than the left. So if we could cover the eyeball, then the ocular surface will improve. And
so once we get at least some part of the midface, the globe
yes, definitely
support,
it protects
then it this chemosis and the subluxation can
improve
get corrected. Okay. So, sir, if I have to add to what I was saying earlier, we know that form follows function and function follows form. So the question is, why should we stop halfway? If we are going to do it for function, then what we do is we correct the form and then correct it properly to the best extent that is possible, so that the function follows, you get the best functional outcome.
I agree with this, as the patient wants it and the parents.
Yes, that is taken.
Yeah.
That is taken. Once they agree for whatever.
Absolutely.
Yes.
So let's look at one more patient. Treacher-Collins syndrome, had severe OSA and underwent calvalular bone graft to the zygoma at that age and a mandibular distraction to reverse the OSA. And about 10 years later, this is what the child looks like. And then last week she presented like this. Now she is about 14 years old. Requires ear reconstruction, of course. So what has happened is the malar augmentation, the bone has not resorbed, but it has not grown. So the calvarium has stayed to the same size it was previously. There is no OSA, but the chin is deficient. The patient now wants to look better. They want everything done stepwise. They want whatever we would say, they agree to that.
Airway is okay, sir?
Airway is okay now. So the sleep apnea, which was severe, is like now, I would say, borderline between normal and mild. Yeah.
Yes, like this is like any other standard midfacial surgery. You need to first get your proper orthodontics done, evaluation and orthodontics, proper planning. Then we do an anti-clockwise rotation with chin and then rhinoplasty and all other. And most important is again re-augmenting with cartilage in the malar and the zygomatic areas as much as possible.
Okay. And then what will you do for the ears?
Yes, of course, that has to be reconstructed in anyone who is really experienced in doing the ear reconstructions.
Okay.
I'll do the ear first because still waiting for a few years for his growth to be completed. So I'll do the ear first. She is 14 already, and we always wait till 10, 12, or the chest circumference is around 60 centimeters for the ears. So I'll do the ears because the position wise looks okay. So I'll do the ear first, both the sides, obviously with the costochondral grafts, and meanwhile the preparation for orthognathic surgery that will be done. And once she is grown up, I won't be I'll be putting patient-specific implants for the malar area.
Okay.
Because see, I mean, it's already been done. It's already scarred. So even if you put bone, so it's more likely to get resolved. I've tried everything, so I'll prefer patient-specific implant for malar augmentation.
Okay.
After orthognathic.
Treatment plan, sir?
Yeah.
The calvarium is okay. The cranium, there's no. I mean, it's a very flat.
Going to school, doing
it's a
well at
very
school.
I mean, aesthetic wise.
Yeah.
Aesthetic wise. There's no nasofrontal angle. It looks like a brachycephalic head. Very flat forehead without a slope and with absent frontonasal angle. And I would say that her or his nose is where we should take as a standard landmark and try to reconstruct the bones around the nose. So the problem here is that the occlusion would be compensated. If we cannot distract them, even though the mandible looks very deficient, the maxilla is clockwise rotated downward and backward. So there is one technique that is described by Hopper, where he has described the counterclockwise rotation of the maxillomandibular complex hinging on the nasion, where we use a red and two mandibular distractors and external mandibular distractors, and keeping the nasofrontal angle intact, counterclockwise rotate everything, because there is no overjet that you can get between the maxilla and mandible indentation, which will allow you to move one jaw alone forward.
It has to be both jaws.
It has to be both jaws. So now the maxilla looks prognatic here, right? So unless you need more quantum of movement at the chin, and that happens with rotation, and that rotation has to happen with a point at the nasion. It's a very
morbid procedure, but then that gives the best
Aesthetic
that you
results.
can. Aesthetically, that would be the best outcome.
Murthy?
Yeah, I was in Seattle seeing Richard Hopper's work number of years ago. And over the years, I've actually seen his case series gradually increasing. My opinion is everybody comes with the treatment plan from their, background experience. I personally do think that particular way of doing, I don't think it's very well, has got a long-term outcome in terms of patient's function, 5 years down the line. Because we all know if you're loading so much on the lower joint, particularly, we don't know. I think trichoccolin, just a diagnosis with a facial deformity, we can't just plan a treatment without really understanding what is the TM joint deformity this particular kid has. So a CT scan that would actually allows me, and I'm sure Pramod will agree, because the type of treatment, what is required for a significantly deformed trichoccolin patient is almost similar to a bird face deformity caused by a primary condylar pathology, for example, juvenile idiopathic arthritis. And I'm dealing with number of those patients with the patient-specific and orthognathistically driven TM joint replacement. So that gives me a complete, robust foundation that is an alloplastic TM joint on which you can advance how much ever you want, maybe with added distraction in sequence. So I think for a trichoccolins of a significant deformity, as you have showed today, you have to analyze the treatment plan based on the actual findings that would be available on a CT scan. That means maybe a sequential treatment. It does require both maxilla-mandible correction because occlusal plane needs to be flattened, and then mandible advancement, and then the treatment of that particular thing could be a distraction or a distraction followed with the TM joint replacement. But if the temporomandibular joint in this trichoccolins is reasonably robust, then the distraction alone may be sufficient. But having this hinging on the nasion and doing the complex distraction, I'm yet to see a long-term good outcome rather than just a before and after picture with a long-term follow-up and that patient's masticatory function. That's not yet been proved, I think. That's what I'm at the moment about to do a surgery, something similar to the same diagnosis, but iatrogenically much more deformed because an early intervention of costochondral graft, which has grown into a straight mandible from the condyle to the chin, and then a distraction which is failed. So patient has got a severe asymmetry. Now I'm going at 12 years age, bilateral TMJ replacement and LIFO3 osteotomy. So it is interesting. Trichoccolins is something I've spoken to a number of really expert in the field. They still say they haven't really come up with a foolproof protocol that works for moderate to severe cases. I mean, David Richardson, somebody in Liverpool, has got X number of years of experience and he's almost retired, or he's retired now, and he just says, I'm still not an expert in trichocolin patients. He can do certain procedures, but getting that absolute facial harmony is really difficult. I think the more severe they are, it's very difficult to achieve.
I agree. I remember Richard Hopper saying this time in Seattle that he is now reserving that procedure for the patients who are tracheostomized and not decannulated for a long time.
I think I want to ask Sherry. About 2 weeks ago, he shared a patient with Treacher Collins, who is an adult. And there were a number of treatment options that he was thinking of.
Yeah, we had thought of that, the counterclockwise rotation in terms of keeping the end point as a rotation. But I felt it was a little morbid for the patient which I had chosen. My plan was, I discussed this with Dr. Mustafa had also about the counterclockwise rotation at the maxillomandibular complex region. But the quantum moment, so we did a counterclockwise VSP, but the bone overlap was rather very minimal. So it was only around the end of around movement of around, we required a movement of around 30 millimeters of mandible at the point where the osteotomy is done. So we extrapolated it with the distraction, extrapolated it with different designs of osteotomy, other than a SAD split or a Z osteotomy or an L osteotomy or a C osteotomy. We tried all these things on the VSP, but the average moment which we required was around 26 to 30 millimeters of movement. So in the end, we ended up actually doing, so I did a distraction, I fixed the distractor, just you're not started activating yet. So it's still in consolidation, the latency period. Because the gap, I tried, and you suggested extended genioplasty to me. I did a VSP on that as well. And the bone contact after advancement of that much of chin advancement, the bone contact was also very dicey. So I did another VSP like you described as a sandwich osteotomy with a 2-piece genioplasty. Again, the bone overlap was not very great. Double sliding genioplasty, where again I felt that the bone overlap was rather minimal. So I think it boils down to there is not much of ideal treatment for this.
Sir, if I can get into a little, I have a case which I completed some time back, Treacher Collins. Not everybody would have big numbers, but then I had done exactly this, mandibular distraction, where you have to increase the size, the vertical height. I had completed the orthodontics first, because once you finish this, your quantum of anterior advancement of the mandible at the dental level is very minimal. You are limited by that because your maxilla is already in a relatively forward position, apparently forward position. So once you complete the orthodontics, there's not going to be much of an overjet. It's going to be probably 3 or 4 millimeters, and that is not the movement that you want at the chin level. So the idea is to have external distractors, increase the vertical height, and do some callus molding with the 3D external distractor, and come to a little bit of because they have a very steep occlusal plane, and then jump the bite, but you cannot go more, and then do at the end of consolidation, when you remove it, do a Lefort-1 osteotomy, close the posterior open bite with a counterclockwise rotation of the maxilla. But you will have a little bit, and do a double sliding genioplasty and calvarial bone graft for bilateral malar augmentation. She looked very good for some time, but then after some time, I would say there was around 25 to 30% relapse. She's still good compared to if we go back to the first question, how much can you make them better? They look good, but then after some time you have to accept what you get.
Especially Treacher Collins, for some reason, never look perfect.
So, can I add something?
Yeah.
So another challenging aspect of Treacher Collins is basically a bilateral form of hemifacial microsomia. So what
But
we are talking
symmetrical, but symmetrical.
But symmetrical. So still now we have been discussing only the treatment in terms of sagittal treatment. What we are also lacking here is the horizontal horizontal direction. Transverse. Sorry. So that also leads us to it's another challenge to correct the transverse deficiency in the Treacher Collins. You cannot widen the mandible because probably the cranial base is also not normal. So it's challenging in that direction as well.
Yeah. Murthy?
Yeah, it's a good discussion point. What are everybody's thoughts on malar augmentation for Treacher-Collins patients?
I said I placed calvarial bone grafts, correctly calvarial bone grafts.
So calvarial bone graft at what age?
Oh, she was an adult. She
Okay, I
was
mean adult is, I mean, I think if you're seeing, say for example, if you got a severe form of Treacher-Collins, I have actually acquired some unoperated Treacher-Collins patients, and I can, in my view, I think I do agree with the sort of, I think AO reference, as you know, they've got some good protocols in it. I think Treacher-Collins patients with severe form of lid deformity, that area, if you don't put the bone graft early enough, you are really restricting what can be done later on, because I have a patient whose lower eyelid is just next to the buccal sulcus of the second molar. So I think if you got a severe form of Treacher-Collins, you do have to put the, accepting it's not going to be ideal, but I think it will give you good lid position later on. You can actually improve. So I think this girl you, Dr. Shamra showed, has had a calvarial bone graft. Of course, it hasn't grown because it hasn't got a growth potential, but it actually has helped her probably lower eyelid. Now you're in a better position where you can actually improve with another patient-specific implant or any other type of augmentation. So I think I'm of the opinion, in severe form of Treacher-Collins patient with lid deformity, bone grafting 7 to 10 years age, in that age group probably would be advantageous. I've just interested to see if anybody has any vast experience in this field.
Mustafa?
Now, to give a definitive treatment plan for this particular patient would be rather difficult at this stage because we don't have the radiographic evaluation. Having said that, I would go by what Dr. Muraka just happened to suggest, that do the year first, because the child is just 14 years old and may not be the right age for skeletal correction. But that is not the fundamental rule. So as an orthognathic surgeon, I would like to bring this into the notice of everyone. Any advancement procedures where you need to advance the skeleton, you can do it before the growth completion. So that doesn't hold good for this patient, because if you look at the mandible, it needs more advancement. But the challenge is linear advancement in this patient is not possible because of the dentition. So a good pre-operative orthodontics is mandatory for this patient. So I'm not able to right now make a decision on what kind of orthodontics is required. So in a nutshell, what I would say is good orthodontics. There is scope for osteotomy. There is also scope for distraction. The basic concept would be, since linear advancement is not possible, therefore you need to change your plan and rely more on rotations, because rotations will give you, in terms of aesthetic, that pogonium advancement it will give you. Another thing is genioplasty would give you significant advancement of the chin. With genioplasty alone, you can bring the POG forward by at least 15 to 16 millimeter if you do a double sliding genioplasty and put some interpositional bone graft and plan it properly. And with the VSP, you can do a very, very precise definitive planning. So that is one thing that I would like to bring into notice. There is also scope for alloplastic implants here, and depending on the temporomandibular status, the TMJ status, as Murthy just mentioned, so we don't know about that. And the advantage of a PSI in terms of the TMJ apparatus is because it can give you the transverse dimensions as well. And there is also scope for PSI implants as far as the zygomatic complex is concerned, because that would also give you the sagittal projection as well as the more difficult thing to do is to get the transverse dimensions correct. So there is scope for a whole lot of things that you can do, provided you assess the case properly, and then do your treatment plan. Thank you.
Anybody else? Yeah.
So with my limited knowledge, I want to ask first we go for pre-surgical orthodontic treatment for malalignment of teeth, followed by what if we go for maxillary expansion, and then after maxillary expansion, if we achieve somewhat maxillary expansion, followed by we can go for submandibular osteotomy, subapical osteotomy, and then followed by genioplasty.
In this case, I don't think subapical has any role in that sense. I think counterclockwise rotation and bringing the jaw forward would be good. Another distraction also might be good. Will make a difference, especially the condyle is normal here. So you can do vertical plus horizontal if you want to. Just to show you that there are many ways to treat the same patient. Nobody seems to have a single answer, which is why we need a forum like this, where we can discuss. This was the whole idea that not a single answer exists for most of the issues that we deal with, especially in craniofacial region. Would you agree with that? Holds true for cleft lip and palate. There are hundreds of techniques. The reason there are hundreds of techniques is because not a single one has the solution for everybody. So there are many ways to do this, and everybody's ideas are good. And I'm sure everyone will get perfect results in the years to come. But till date, I must confess that I have not seen an end result in Tricha Collins which is looking like a normal adult, honestly.
Dr. Shamra, can I ask Dr. Murarka's opinion about the ear reconstruction staging? I just wanted to ask, I work with someone else who's working in Edinburgh for ear reconstruction. So we have this joint ventures most of the time. I just wanted to know his opinion about if somebody is with this similar kind of a situation where you need to do a coronal incision for reaching for malar augmentation later on, etc. Has he come across and done an ear reconstruction after somebody who's had those type of procedure? Is there a difficulty in doing autologous ear reconstruction? Just wanted to know your opinion.
We can do in this case also. I mean, as you suggested, there is already a bicoronal scar. So in the first stage will not be a problem where we are like framing or carving our ear framework and putting under the skin.
Yeah.
Second stage, if we need temporoparietal facial flap, in that case, there can be problem. Reason being the superficial temporal artery may have got injured. In that case, we have to plan something else. Otherwise, doing ear autologous ear reconstruction in this case, we can do it.
So what do you do if superficial temporal fascia is not available? What is your other choice to put the skin grafting on the
fascia in every case in second when you are creating cephaloauricular groove, or we do it because that gives us better result. Otherwise, we can put like mastoid fascia, turnover flap, and top of that we can put our graft, skin graft.
Skin graft, yeah.
Yeah.
Thank you.
But obviously, the superficial temporal artery based flap is definitely better, and results are definitely more consistent.
Thank you.
But we can have compromise and we can get away.
You can also think of an implant-based prosthesis in this case.
I mean, we always prefer doing with costocontact graft, so I'll talk about that. But that option is always there.
Just to add a little more to what Professor Rao just mentioned, why there's so much of difficulty when it comes to Tricha Collins. The sagittal and the vertical disproportions are easy to correct, but what is very difficult is the transverse proportions. And what is glaring in the Treacher-Collins syndrome is the transverse disproportion. And that is always very difficult to correct in terms of soft tissue and in terms of skeleton.
There are a few auxiliary procedures also which can be done after we have completed our bony work and other things like fat grafting to camouflage the things and to give a little bit more wider facial look.
You could also put a PSI for the gonial angle and
the TMJ processes, because that could partially take care of your decreased bigonial width.
We have to be careful about distracting multiple times because it can lead to ankylosis also.
Can you explain a little bit more about this?
We have patients who have gone into ankylosis after multiple distractions. So we, especially, in cases like these, there is a Treacher-Collins patient itself of ours from the olden times who has gone into TMJ ankylosis following multiple distractions. So one needs to be careful about that as well, just to keep in mind.
I have not come across one, but if anybody else has any experience in that,
one case, that's what I think promotes talking. So we had distracted the child at age of 2.5 with sleep apnea. And then she came back for aesthetic correction. So we decided to again re-distract her. So the first one was an internal distractor. It worked out fine. Everything was okay. The second time we distracted with an external distractor. The distraction went on fine, but then after the distractor was removed and mobilized, she ended up in bilateral TMJ ankylosis.
what are the condyles like earlier?
Condyles was that usual squeamy small head of a usual Treacher-Collins. But it has happened in the second section, because after the first distraction, her mouth opening was fine.
Where was the osteotomy site in the second one?
The second one was the angle.
Okay. So if the angle to skull base distance was short, you think callus would have caused the ankylosis?
We went through literatures and then we found a couple of other cases also, but all case reports where the ankylosis has happened because of they postulated it's because of the pressure in the joint space. That's the only case I've come across.
I haven't
Later,
come across
I guess,
any, so I don't
she
know.
underwent bilateral joint replacement. Am I right?
There is, I think there is a definite hypertrophic bone formation tendency. That is why these patients ankylose, because she underwent heterotrophic, I'm sorry. So because she underwent ankylosis release multiple times and every time she fused again. So there is that tendency with her. That's why they ankylose. Whoever ankylose, it's because of that, I think, I assume. Finally, we had to do a joint replacement.
Also add, I have seen heterotrophic bone formation despite temporomandibular joint processes, where the TJR is given, and then after a year and a half, it's on a neocondyle there. And patient was going in for an ankylosis and we had to redo it. Basically, it is the tendency for heterotrophic bone formation. So is it connected with why I'm asking you is there anything to do with the distraction per se? Or is it because of the distraction?
The load that comes on the
So if that is the case, then every ankylosis patient, you have to be guarded while doing distraction.
We are talking about a apparently normal joint that goes into ankylosis because of the excessive load that you exert on it with the distraction.
With the
Because
vertical distraction.
Yeah, when you, especially when you use a multi-vector, you
Yeah,
can
yeah.
exert load in various planes. So it's not only the anterior movement, it's the the force that gets transmitted to the glenoid for the temporomandibular joint, which may initiate a repair process that leads to ankylosis, probably. Murthy, any experience?
Not in trichocolin patients, as well as any distraction. I mean, I've come across an ankylosis post distraction in a bilateral craniofacial microsomia patient who had an extra articular ankylosis. That meant, the really 6 weeks old baby who had a distraction achieved, extubation and airway was done, but the child came back 2 months later with trismus and restricted mandibular movement. And then we found there was a ankylosis on the and in front of the articular eminence to the condyle. I think that's exactly because that's the age of the child is so pro bone formation, and that sort of gave us idea that even if you do distraction in young age, you have to give parents instruction to keep the jaw in motion and do some physiotherapy as well, but not in an adolescent or an adult patient. No.
This was adolescent, right?
In this case, which we were discussing, we had done a vertical distraction component first, like what we had described before, and then tried to callus mold it for the anteroposterior projection. So that probably that vertical force would have probably banged the condyles back into the glenoid first.
I mean, for exactly for that purpose, to control the proximal segment of the mandible, Matthew apparatus that is KLS Martin designed is the best ideal gadget one can use. It's got it makes the externalize the whole temporomandibular joint with a hinge attached onto a vertical rod and 2 pins going on to the ramus, so that patient can actually move the jaw. But when you're distracting in huge distances, there is no backward or upward into the TM joint force, because that's been controlled with the Matthew apparatus. Worth having a look at it, those who wants to do those kind of stuff.
How are we doing time-wise?
We are already past the time.
Okay.
So whenever
then,
you want to
let
stop,
me conclude.
we can. Yes.
So, thank you very much, gentlemen.
Murthy, thank you so much
Thank you, Murthy.
for joining us on.
I would have loved to come in person, but you didn't invite. That's okay.
April, so do you want to invite for April? Yeah, your hometown is organizing cleft conference.
Oh, I'm not a cleft surgeon. Sorry.
But it will have craniofacial. There's one craniofacial day.
Yeah, thank you. I'm on holiday in April. Thank you.
All right. Thanks, Murthy. See you soon.
Bye. Bye. Bye, everybody.
Thank you. So we have one more session, that is forming a task force for craniofacial surgery in India under the Indian Cleft Lip and Palate and Craniofacial Anomaly Society, which I would invite everyone to join after a tea break, because this is a core group of people who actually perform craniofacial surgery and are keenly interested in craniofacial surgery and who have come as a team. So then chart a course forward for what to do and how to do. So tea break and get back, 15-20 minutes.